Attention, do not worry about that. All right? So good afternoon, and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Milnick, and with me is my wonderful vice chair, Ariana Kelly, to my left. We have our counsel, Ms. Erin Hopwood, to my right as well. This is our first session back in person since 2020. So I ask for your patience if we encounter any technical or streaming issues, and it will happen, so just be patient, okay? Please set your electronic devices to vibrate and don't hold conversations in the committee while testimony is happening. If you need to do that, please be gentle and go outside. We're going to hear from the bill sponsor and the bill and the sponsors panel. When I call you, please bring your entire panel up. Followed by an all-person witness, and people will testify favorable with amendment, or unfavorable. I try to group the panels in that category. Then our virtual witnesses. So we have people that have signed up virtually, because this session you can testify in person and virtually as well, and the same format follows. The bill sponsor testimony is not limited in this committee. However, please do not take 10 minutes. While all witnesses will have 2 minutes to provide testimony, because if you do take 10 minutes, I'm going to tell you to wrap it up. And then next time I won't give you 10 minutes. Just kidding. A timer is displayed on the screen and a sound will be played, and once your time has expired, please adhere to our usual committee rules. To the committee members, you have been wonderful. Please continue to adhere to the committee rules of 1 question and 1 answer from the panel. Not 1 question and 1 answer from each witness. And I don't want to hear a story. Just ask the question, please. Sometimes you'll see that I'll give you some flexibility and allow you to ask a question, or sometimes I'll allow another witness to speak, although we are only allowed 1. And that's because if I feel that we need it to be able to explain the issue as well. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today we will hear the bills in the following order. First, we have House Bill 53, followed by House Bill 340, followed by House Bill 302, House Bill 288, House Bill 82, House Bill 318, House Bill 290, House Bill 283, and the last bill of the day is House Bill 59. We also today have some bills that are jointly assigned. That means that they're jointly assigned with another committee where we're primary, they're secondary. Those committee members that are here to represent that committee, you will see them sit behind here, and they're also allowed to ask questions. We're going to start with House Bill 53, my wonderful colleague, Delegate Forbes. In the title of the bill is Human Services Maryland Statewide Independent Living Council. Will you be so kind and bring your panel, and good afternoon, and you can get started when you're ready. Again, you'll see that our members are coming in and out. There's no sign of disrespect. Is that they also have bill hearings in other committees, but we're here. Delegate Forbes, good afternoon. It'll go on as soon as you start talking.
Thank you, Chair Peña-Milnick. Thank you, Vice Chair Kelly, and thank you, members of Health and Government Operations, for the opportunity to present to you today HB 53. This bill will enable the Maryland State Independent Living Council to form as a nonprofit and have autonomy over the federal monies that fund them. So if you're not familiar with the Maryland State Independent Living Council, they were formed by federal legislation in 1992, and each state is required to have one. Currently, the mission of the Maryland Silk is it's committed to enhancing freedom and independent decision-making of individuals with disabilities. The vision for the Maryland Silk is for people with disabilities to have information, choices, and control over the services and supports in their life so they can participate fully in all aspects of society. It's a big mission. But currently, they're federally funded entirely, and their federal funds go through the Division of Rehabilitative Services, or DOORS, in MSDE. And what they're here today to ask you for is to pass this legislation so the money can go to them directly. They'll incorporate and become a nonprofit. This will have two big benefits for them. The first being that they could hire their own staff, and the second being that it would enable them to go out and look for more grants so they could increase the work that they do. This bill has been requested by the advocates here today, and when you hear them speak, you'll see how passionate they are. The majority of the members of the Maryland Silk are people living with disabilities. Other silks across the country, and as I said at the top, that the federal government mandated that we have a statewide independent living council in each state. Half of them have taken this movement to become nonprofits. So other silks across the country have made this change for the better for their programs, and I ask for a favorable report. Thank you.
Thank you. And who will be next?
I'm Mike Bullis. I'm the treasurer of the Statewide Independent Living Council, as well as the representative from the Centers for Independent Living. As Delegate Forbes said, the state receives about $2 million in federal funding to fund 7 centers for independent living throughout the state. There's one in every county in the state. There's services in every county of the state. The 7 centers are operated by people with disabilities and fully run by people with disabilities. This council meets approximately 4 times a year. It has subcommittee work, but it develops a 3-year strategic plan to improve independent living services for people throughout the state. It's a worthy council and a worthy activity, and in order to comply with federal assurances, that's why we're here. The federal assurances require that we be able to hire, supervise, and manage our own employees, and that we be in control of our money. The governor will still appoint the members, but the council will be able to be autonomous from the Division of Rehab Services because it represents a conflict for them to continue to manage the statewide council. So I want to thank you. I would make a side note and say that there has been a fiscal note. This council's budget for $139,000 a year. Apparently the AG thinks it's going to cost them $285,000 a year to manage the council. You can take the fiscal note for what it's worth, I guess. Thank you.
Thank you. Welcome to our world, right? Now you know how it really works. Who's next?
My name is Lorna Mae Silcott, and I am the secretary for Maryland Silk. Currently, the Silk receives $139,000 in federal funding through the Maryland Department of Education, Division of Rehabilitation Services, as we know as DOORS, which acts as the designated state entity. Because the Silk is not a freestanding entity, it cannot receive and expand funds or hire its own employees, but must use DOORS to expend funds and to hire personnel to carry out the work of the Maryland Silk. This situation does not allow for the independence outlined for federal assurances from the Administration for Community Living. The Statewide Independent Living Council, a majority of whose members are people with disabilities, in cooperation with the Centers for Independent Living, develops and monitors across disability, state planned every 3 years to enhance services delivery throughout Maryland. The State Plan for Independent Living, SPIL, for Maryland serves as the strategic plan to advance the independence and full inclusion of individuals with significant disabilities. HB 53 puts the Maryland Statewide Independent Living Council, the SILC, in statute which will allow the compliance with federal assurances and regulations to act as an independent agency of government. In closing, for the SILC to be effective and contribute meaningfully to the goals in advancing independence and inclusion, they need a staff that can be supervised and directed by the SILC. Restructuring the organization of the SILC will allow them the ability to manage their own funds. And guess what? It costs the state absolutely nothing. I thank you.
Great way to end. Thank you. Are there any questions? Actually, is she on your panel? Okay. So we do have a virtual witness, Ms. Rose. How are you?
I'm fine. Good afternoon. How are you?
Well, you're making me feel like I want to go back to my island.
I wish I were there, right?
I'm telling you, you can get started.
Okay. Good afternoon. My name is Rose Carey, and I'm the chair of the Maryland Statewide Independent Living Council. This bill establishes the Statewide Independent Living Council as a body that can hire staff and pay its bills. The main purpose of the council is to create a state plan for independent living to provide services for all Marylanders with disabilities. The delivery of services is provided through the 7 independent living centers. The centers were established by federal law and work to ensure the civil rights and quality services of people with disabilities in Maryland, which is very important. Centers for Independent Living are nonprofit disability resource and advocacy organizations located throughout Maryland, operated by and for people with disabilities, which is very important also that they are operated by the people that control them. Centers are part of a nationwide network which provides information and referral, advocacy, peer support, independent living skills training, and transition services. The State Independent Living Council, the SIL staff, and their boards are all composed of at least 51% of people with disabilities. This bill will allow the governor-appointed council members to follow federal law and improve services to people with disabilities throughout the state. We urge your support for this bill, HB 53. Thank you very much.
Our pleasure. Thank you for making time to testify today. So this is the sponsor panel that you have in front of you. Are there any questions for them? First, I will start with Delegate Collison.
Thank you, Madam Chair.
My pleasure.
Thank you for this bill, Delegate Forbes. And my question is, this in no way diminishes the activities and responsibilities of the board, but actually creates opportunity to get funding to do more. And in that vein, where will the funds go, since it's not going to go to a state agency, but how do the funds work from the federal government in this kind of an independent setting?
So the funds would continue to come through the Maryland Department of Education and would be then given to the Statewide Independent Living Council. In other words, the path of the money wouldn't change. The difference would be they could give us quarterly budget and say, spend your budget. We would have budget authority to expend. Is that helpful?
Currently now, every expense they have to pay, they have to go back to the MSDE doors to get anything paid for.
Yeah, we can't hire employees, sorry.
And so this would allow them more autonomy over the funds that they've already, that are theirs.
If I may, Madam Chair. Sure. So in other words, you would have access to the full amount throughout the year. Is that right?
And they would incorporate and become a nonprofit. And so.
Excuse me, 1 minute. What was the answer to that?
What was the question?
They would have access to the full amount, yes.
Yes.
And they plan to incorporate and become a nonprofit. That's what, we're following the lead of other states. That's what's happened in other states. And they would have oversight and auditing and have the following the rules that they currently follow.
We would be responsive to the ethics laws, the Open Meetings Act laws, et cetera.
Thank you. Thank you, Madam
My
Chair.
pleasure. Any other questions? Delegate Bandari.
Thank you, Madam Chair. As you said, the Center for Independent Living are nonprofit disability resources and advocacy organization run by people with disabilities. At least 51% people are with disabilities. I wonder if this bill passes, how does your operation help or hurt in terms of accountability issues? Does still the MSD will be in charge of it? Could you clarify that?
It doesn't change the accountability at all. The Centers for Independent Living are already subject to annual fiscal audits and depending on the size of the organization. So it really doesn't change anything. It simply allows the council to do some really exciting and inventive things. One of the charges of the council is to do studies of the needs of people with disabilities. So we'd be looking at foundation money to perhaps fund some of those studies and help really dig in and figure out what do people with disabilities need so that we can build it into our plans for the state.
Thank you.
Delegate Kaiser.
Thank you, Madam Chair. Delegate Forbes, my only question, because we did something similar years ago with like the libraries, is there any concern that removing it from where it is structurally will maybe make it harder to get some of that funding? Or is that money only coming from the federal government and so it's passed through? So are you worried at all of losing something budgetarily?
The current funding that comes that finances the silk is all federal money. We don't anticipate that changing. So and then the state dollars and the federal dollars that come to the centers themselves is also under federal control and state control. Does that help?
Yes. Yes.
Yeah, thanks.
Any other questions for this panel? Seeing none, thank you so much for your testimony today, and have a happy Valentine's Day. I'm going to call on the other witnesses.
Thank you.
Thank
My
you.
pleasure.
Thank you.
Next, we have my pleasure. Take good care. Next, we have Ms. Lori Elenov. Are you here? She signed up to testify. If she doesn't want to, she doesn't have to. Is she here? Okay, thank you. So this will conclude the bill hearing on House Bill 53. Next, we have House Bill 340, Delegate Collison, Maryland Department of Health, 211 Maryland Oversight. Delegate Collison, will you be so kind and come up with your panel, please?
She's virtual. Okay, great.
Good afternoon.
Good afternoon and happy Valentine's Day, Madam Chair, Madam Vice
you.
Chair, members of the committee. You are all my Valentines, so.
Thank you.
And thank you for the opportunity to present HB 340 to you today, which is 211 Maryland Oversight. So all this bill does is it updates the current activities in describing the functions of 211 in our statute, and it transfers the oversight of 211 programs back to the 211 board, which was the intention of a bill that we passed in 2020. In 2020. So 211 for the new members is a public-private partnership that really works for constituents when they have individual needs. Sometimes they're in crisis, and sometimes they just need information. It's accessible 24/7, 365 days a year, on the phone, through text, on the website. And most of the time, people who call can get connected directly to the resources they need at that moment. Maryland 211 was established in 2010 in statute and has served millions of Marylanders since then. In that statute in 2010, the Health and Human Services Referral Board was established and charged with guiding and oversight to the program. But the board had no authority and no clear sense of purpose. And I know that because I served on it for 7 years. And so it really didn't matter how dedicated the appointed members were of this board. There was no sense of purpose, and nothing, came of it except the annual report from Maryland 211. So in 2010, we passed HB 669, which transferred that programmatic oversight and authority and responsibilities for operations back to the 211 Board of Directors. It was actually that board that was generating the report every year that the statutorily created board was charged with. And we just, did minor revisions on it at any time. In the meantime, 211 board has been working hard, increasing the capacity of the programs. It's been, during COVID, it was essential to our emergency responsiveness. It continues to be a major factor and contributor in our mental health services. So just to kind of give you an idea of the scope, there have been over 600,000 visits to the website, almost 400,000 texts and calls and website emails asking for help and information just to 211 Maryland. There have been almost 40,000 connections for people in suicide, in a suicidal crisis. And 20,000 folks have been guided toward food resources. So those are just some of the things that the 211 board, in the programs it's designed and implemented and operated, has been effective at. Unfortunately, the bill we passed in 2020, we included language that turned not only the auditing responsibility, which MDH would have just by virtue of the fact that the state was giving 211 Maryland finances or funding, not much, but some funding. But we also included language that provided programmatic oversight, which meant that MDH then became responsible for overseeing the call centers, for example. Prior to that passage, 211 was functioning well, was increasing. All of the programs had flourished and under the board of directors. The board of directors of 211 are community members and leaders and nonprofit leaders. So what 340 does is it clarifies the relationship between the 211 board and MDH. There's written testimony in your packet that says that MDH is ready to relinquish this responsibility. They might not have said it that way, but this is something that they are supporting. So with that, I thank you for your consideration and humbly request a favorable response. And I'm going to turn it over to Quentin Askew, who is the Executive Director of 211 Maryland.
Thank you. Good afternoon, sir. You don't have to touch it. It'll come on. Yes, go ahead.
Sorry, I got too
okay.
finger happy. Good afternoon and happy Valentine's Day to everyone. My name is Quentin Askew, President and CEO with 211 Maryland, Maryland Information Network. And I appreciate the opportunity to speak on behalf of House Bill 340. And I would also like to give a big thanks to Delegate Kellison, who's been a champion of 211 since its existence, and also a leadership on this bill. I'm pleased to be here in support of House Bill 340, which adds, as the delegate stated, clarifying language regarding the public-private relationship we have with our friends at the Maryland Department of Health, but also speaks to the new vision that 211 Maryland Information Network has. We have had tremendous growth over the past couple of years. We're a robust, technology forward-thinking organization. This past year, since COVID, we've had over 1 million individuals connected to services. We are the only entity within the state that, again, provides 24/7, 365 connections to health and human services within our state. And that's by phone, that's by text, and that's also by chat. So it's simply having a case manager within your pocket. Since its existence, actually almost 20 years ago, today, in 2004, the concept of 211 was cultivated in this very committee. The committee ultimately approved within the General Assembly to bring 211 to fruition, and it has been expanding and supporting Marylanders ever since. We continue to look forward to supporting those who are in need. We continue to look forward to supporting those who may be in crisis and seeking help. And I ask for a favorable report for House Bill 340. Thank you.
Thank you for being with us. We do have another witness for the panel, and that is Ms. Janice Williams. Ms. Williams, how are you today? And happy Valentine's Day.
Hello there, and I am well. Happy Valentine's Day to you as well.
You can get started. Thank you.
Okay. Good day, Chair Pina Melnick and Vice Chair Kelly and members of the committee. Again, my name is Janice Williams, and I'm the chair of the Board of Directors for Maryland Information Network 211 Maryland. 211 is a powerful tool which gives Marylanders 24/7 telephone, text, and web-based access to the resources they need when they need them. We are a partner in emergencies, crises, and homeland security with access to the state's most comprehensive health and human services resource database. Our board of directors is pleased to support House Bill 340, Maryland Department of Health 211 Maryland oversight. This bill reflects the current vision of the Maryland Information Network that administers the 211 system in Maryland to serve as the central connector for health and human services and clarifies the public-private responsibilities between the board and the department. Over the past year, the board and the organization has evolved to ensure the 211 system is in position to meet the needs of Marylanders and have the financial resources to support the demand for services. House Bill 340 will strengthen our relationship with the department, will support a path toward more sustainable funding and increased collaboration between other government offices. Our hope is to increase usage of the tools available through 211 and the Maryland Information Network to improve health outcomes and address socioeconomic disparities in our state. I would like to thank Delegate Cullison for being a 211 champion and the General Assembly for recognizing the importance of Maryland's 211 system. I ask for a favorable report on House Bill 340. Thank you.
Our pleasure. Thank you for the testimony today. There are also several people that have signed up, and just for the committee and the people that are listening, their written testimony, and the committee does read them all. So whether you're submitting written testimony or in person as well. This concludes the sponsor panel right now. Are there any questions for Delegate Collison and her panel? Seeing none, you did a great job. Thank you.
Thank you, Madam Chair.
So this actually concludes the testimony for House Bill 340. Next, we have Delegate Shetty, House Bill 302. Will you come up, please, with your panel? And it is the Public Health Rare Disease Advisory Council. Good afternoon. How are you?
Doing well, thank you.
Wonderful.
Good afternoon, committee. It's lovely to see you all. I just want to start out by noting that one of the witnesses that is signed up for testimony is actually my chief of staff. He will not be present for this, Dave Kuhns.
Yes.
So we can cross him off. The remainder of the individuals who are signed up to testify are part of my sponsor panel.
Wonderful. Welcome, everyone.
Thank you so much, Chair Pena-Melnick, Vice Chair Kelly, esteemed members of the Health and Government Operations Committee. For the record, my name is Delegate Emily Shetty, and I'm here to testify in support of HB 302. This is legislation that will establish a rare disease advisory council here in this state, and that it will study and make policy and regulatory recommendations on behalf of patients with rare disorders. So right now in Maryland, we already have, as many of you know, an advisory council on hereditary and congenital diseases. So that council oversees the newborn screening program, and they do additional exceptional work, but it primarily covers patients that are born with disorders that are rare. And so if you think of a Venn diagram, it's like the larger circle is the circle of those patients who have rare disorders. And a smaller circle within are those who have disorders that are hereditary or congenital. And so in 24 other states, they have already established a rare disease advisory committee, and 7 states plus Maryland this year are considering it right now. In fact, one state, Indiana moved their bill, I think, to the floor, right? So they're already kind of moving ahead, but we can lead here in Maryland too, right? So what's a rare disease that affects less than 200,000 patients nationally? 25 million Americans suffer from the known 7,000 rare disorders. And a couple of common examples include sickle cell disease, cystic fibrosis, ALS, and hemophilia. So those are the really well-known ones. And then within the rare disorders, there's so many more, some that are considered ultra rare, and they affect, just a handful of patients. So what this bill does is it provides an opportunity for patients, providers, and caregivers to come together and provide policy advice and regulatory advice to us as policymakers as we consider a roadmap for legislation that could be supportive of that community. It would live under MDH. The fiscal notes that they could use existing staff. They wouldn't require any additional investment from the legislature. And it would include representation from the government, from patients, caregivers, a cross-section of healthcare professionals, including a geneticist, a nurse, hospital administrator, pharmacist, health insurance carrier, scientists, and much more. So we've shared with the committee a sponsor amendment that mirrors a sponsor amendment to the cross-filed bill by Senator Lamb. And what that amendment does is it further broadens the council representation to include added medical stakeholders. It adds representation from the State Advisory Council on Hereditary and Congenital Disorders, and it staggers the terms of members to ensure the continuity of the council. We also have submitted an amendment, I believe, to drafting, and I don't think we've gotten that one back, but I will happily share it with the committee once it returns, that would remove the newborn screening duty from this council as drafted in the bill. Obviously, we don't want to overlap with the existing hereditary and congenital disease program. They're doing great work. We want there to be collaboration and make sure that all patients with rare disorders have a voice at the policymaking table. So I thank you, colleagues. I respectfully request a favorable report on HB 302. And with me today, I have Anissa Reed with the National Organization for Rare Disorders. They have been working across states to pass similar pieces of legislation. We also have Erica Augustine with the Kennedy Krieger Institute to provide a provider's perspective. We have Celinda Carr with the Coordinating Center who can share some perspective about coordinating care for patients with rare disorders. And we have Geneva Stone virtually, who is a caregiver and parent of a child with rare disorders. So I will now, if that's okay with you, Madam Chair, I'd like to turn it to Anissa Reed with NORD. If I may.
Sure.
Thank you.
Thank you. Good afternoon, Chair Pena-Melnick, Vice Chair Kelly, and members of the House Health and Government Operations Committee. As mentioned, my name is Anissa Reed, and I'm with the National Organization for Rare Disorders, or NORD for short. NORD represents the estimated 1 in 10 Maryland residents living with a rare disease. And I'm honored today to testify in support of House Bill 302, legislation creating a Rare Disease Advisory Council, or RDAC for short. It can be difficult for state lawmakers to understand the needs of rare disease patients and their families due to the small patient populations and the variety of rare diseases. This lack of awareness often contributes to the obstacles faced by rare disease patients and their families. And RDAC is a great tool to help fill that gap. The Council may conduct surveys to better understand common challenges that rare disease patients face, consult with experts to improve access to quality health care, or compile resources related to rare diseases. And in creating this council, as mentioned, Maryland would be joining 24 other states that have already enacted similar legislation to support their rare disease community. And it's really proven to be an effective way to ensure better government engagement and action on issues important to the rare community. As mentioned, in many ways, Maryland has been a leader in the rare disease community with nationally recognized healthcare institutions and distinguished healthcare providers with expertise in a variety of rare diseases. Furthermore, the Maryland State Advisory Council on Hereditary and Congenital Disorders has done really important work for 4 decades, but NORD still believes an RDAC would be a really valuable resource in Maryland, especially on issues related to access to care and treatment for non-inherited or congenital disorders. So once again, thank you for adding HB 302 to the committee agenda and for the opportunity to testify. And I urge this committee's support on this important legislation. Thank you.
Thank you. Thank you for your advocacy. Who will be next?
Good afternoon, Madam Chair, Acknowledgement to Vice Chair and members of the committee. Thank you for the opportunity to speak today in favor of House Bill 302. My name is Dr. Erica Fullwood Augustine. I'm the Associate Chief Science Officer at the Kennedy Krieger Institute, where I am a practicing child neurologist and also director of the Clinical Trials Unit. You've heard about thousands of rare diseases affecting small groups of people, and when you take those all together, the experience of navigating a rare disease diagnosis is actually quite common. This is an experience shared by as many as 600,000 people across Maryland and 30 million people across the United States. Rare diseases have affected my family, and I suspect that they may have affected your families as well. While there are unique aspects to each diagnosis, there are shared challenges, including the need for information, for access to expert care, efficient diagnosis, support and accommodation in the community, and the potential for financial impact for families. There's also the potential for isolation. The Kennedy Krieger Institute treats hundreds of rare diseases that impact the nervous system in children and in adults. We are proud to be the home of several rare disease programs that have national recognition as centers of excellence. The majority of rare diseases are still in need of effective, targeted, and impactful treatments. Fortunately, there have been a number of breakthroughs in recent years for the treatment of specific rare diseases. And as treatments improve and expand, the importance of early and accurate diagnosis, equitable access to care, and deep understanding of the needs of the rare disease community has never been higher. The proposed Rare Disease Advisory Council is an effective approach to raising awareness about the existence of rare diseases and about real-world impact on families day-to-day in Maryland. The council can serve as a unifying venue, a mechanism for shared knowledge, and I thank you for the opportunity to support House Bill 302 today, and I ask for a favorable report.
Thank you for your testimony. Who will be next?
Good afternoon. For the record, my name is Celinda Carr, and I'm here on behalf of the Coordinating Center. We are a nonprofit, and we have a 40-year history of providing care coordination to people living in the community with disabilities. I'm the director of a program that provides care coordination, also known as case management services, for a program in Health Choice known as REM. That acronym, REM, stands for Rare and Expensive Case Management. We currently have 4,100 clients statewide in the REM program. And the day-to-day for our case managers, who are licensed nurses and social workers, can be anything from helping a client to connect to primary and specialty care providers, perhaps assessing the need for a nurse to be in the home, ensuring that the parental caregivers feel comfortable with the complex tasks that they are doing at home, assisting with prescription issues, or maybe even helping to find funding for something that's not covered by Medicaid. A quick story of one of our clients. She came into the program at age 2 after she sustained a fall in a bathtub. During that hospitalization, she was diagnosed with a syndrome called Klippel-Feil syndrome. It's a rare disorder where 2 or more of the vertebrae in her neck are fused together. The doctors told her parents at that time she likely wouldn't speak and probably would not be very functional from a physical standpoint. Fast forward 11 years later, she's still in the REM program. She's thriving as a cheerleader from her wheelchair. She loves to sing, she loves to dance. But those past 11 years, she's had the benefit of a case manager who has helped to guide the family through this rare diagnosis as well as through our complex healthcare system. And most of all, they've had an advocate. And the council suggested in this bill would continue to ensure additional state-level advocacy for these individuals and their families. So the Coordinating Center asks for a favorable response to House Bill 302. Thank you.
Thank you for being here today. We have one more individual that is part of your sponsor panel. They will be testifying virtually. So good afternoon, Ms. Stone. How are you?
Good, thank you. Chair Pena-Melnick and Vice Chair Kelly, members of the Health and Government Operations Committee, thank you for allowing me to testify. I urge a favorable report on HB 302. I'm Geneva Stone. My son, Rob Stone, 25 years old, an artist and advocate, has an ultra-rare disease, dystonia 16. He's the only reported case in the US among only 20 cases worldwide. Dystonia 16 is so rare that we spent 14 years searching for a diagnosis that is still only available through genome sequencing, a test that analyzes the more than 20,000 protein encoding genes in DNA. Rob also has disabilities, and while Maryland has strong supports for disabled persons, the needs of the rare community do not fully align with the disability community. Our family struggles with prior authorization for life-saving medications, with coverage for the high-dose supplements research has shown are essential to Rob's well-being, with continuity of care, and with access to Medicaid services. Rob was not enrolled in the Rare and Expensive Case Management Program until he was 15 due to wait lists and lack of a diagnosis. There are 302 qualifying diagnoses for REM, yet there are 7,000 rare diseases. So REM serves less than 1% of the rare disease population. Furthermore, of those qualifying diagnoses, 68% end at the age of 21. So rare adults are often left out in cold in Maryland. While I applaud Maryland's progress with newborn screening, it would not have diagnosed Rob, nor would it my dad and sister diagnosed with rare diseases at the ages of 70 and 40, or my hairstylist's mother diagnosed at 60. Rare Marylanders need access to genetic sequencing, adult services, experimental treatments, and fair insurance guidelines. I urge a favorable report on HB 302 so rare Marylanders have a voice in shaping the policies that impact our lives. And Rob's a little tired because he's had surgery on Friday, but he thanks you as well.
Thank you.
And we thank you both for being with us today. Are there any questions for this panel? Seeing none, I do want to thank you for being with me. I have actually, for being with us, a couple of questions. Just basically, there's actually 3 testimony that are favorable with amendments. I know you referenced to some amendments, and when you get them, will you be so kind and give them to Michelle Furman in the committee, and she'll make sure that our council and the rest of us gets it. Those amendments, do they reflect all the amendments referenced to in the testimony? One from the University of Maryland School of Medicine, one of the doctors, the other one from the Maryland Department of Health Advisory Council on Hereditary and Congenital Disorder, and the last one from the Maryland Pediatric Medical Association. Are they reflected? Are those the amendments?
Thank you for that question. The amendment addresses on consistently across, I sort of have only 2 of the favorable amendment testimonies in front of me, but I did read the podiatrists as well. I did not see the 4th one, but I will pull it and confirm by writing whether the amendment addresses that specific concern. I will say that the letter of information from MDH, the sponsor amendment does cover that, as it removes newborn screening from one of the duties of this council to avoid that duplication between the 2. That is also the first amendment requested in University of Maryland School of Medicine, so that is addressed there. As far as the drafting of RDAC and whether or not a senator or delegate should be mandated to be included, truthfully, I'm open to the committee's feedback on that. We have not included that as part of our current amendment, but we certainly can if that is the will of the committee.
So the bill will be assigned to subcommittee. If you can make yourself available, and
Yes.
the advocates, that will be great.
Yes, ma'am.
This actually, since there are no questions, this concludes the bill hearing on House Bill 302. I want to thank your witnesses for being here, and good luck to everyone, okay? Take care. Next, we have House Bill 288, and that is Delegate Collison, Food Service Facilities Automated External Defibrillator Program, the Joe Chea Act, and we're jointly assigned by Economic Matters. Behind me, we have Delegates Waffle, and we will welcome to our committee. And you're free to ask questions, okay? Let me know. So good afternoon, Delegate Collison, again. You owe us chocolate by now. That is 2 in a row.
This one might not be quite as easy as the last one, Madam Chair.
I suspect not. Go ahead.
But I do appreciate the opportunity to get a few more steps in today, coming back twice. Good afternoon again to the committee and Madam Chair, and to my Economic Matters colleagues, and for the opportunity to present HB 288, which is Automated External Defibrillator Program. I'm going to call it an AED, and this bill is named after a gentleman who actually passed away due to the fact that there was not an AED present where he was at that moment. So the purpose of this bill is really simple, and that is to save lives, and it will do that by requiring some certain food service facilities to develop a plan to implement an AED program in their facility. And I want to be really clear, the facilities, food service facilities includes a wide range of places where food is prepared and served. And we are, in this bill, we are only including those who have a gross annual income of $400,000 or more in a year. The program will allow the public to be able to use these AEDs in times of emergency. They have the machines themselves, which you're going to see in a few moments, are actually now very simple. They are, much easier to use and do not require a lot of training. But just to give you the foundation of why we need a bill like this, why we need these machines to be as pervasive as possible throughout our public venues. A cardiac arrest is when your heart actually stops. And many of the victims of cardiac arrest have no previous history or are expecting that this could happen with them, and they're stricken without warning. About 1,000 people a day die from, and this is nationally, from sudden cardiac arrest. A quick shock to the heart with an AED can solve that, or can save that life. It's portable, it's battery operated, and anyone can safely use it. The machine itself checks to make sure that what's going on with the heart in terms of whether or not there's a rhythm. And if there isn't, then the machine determines that it needs to send an electric shock to the heart to restore the natural rhythm. So why don't we just call 911? We've got great emergency responses here in Maryland. Well, an average range of a 911 response call is anywhere from 4 to 10 minutes before they can actually get there. The chances of survival from a sudden cardiac incident diminish 7 to 10% for every minute that shock is not delivered. And after 10 minutes, the chances of resuscitation are really low. They are more likely to survive without a disability, and especially without a disability if the AED is used while waiting for the emergency medical services to arrive. It actually doubles or triples the survival rates to have that machine worked on the folks for that first time, within that short amount of time. George Shea might be here today if there hadn't been one of those, if there had been one of those in the restaurant where he was eating. And his wife is here today to tell us his story. And I don't know about you, but I was really happy to see Damar Hamlin at the Super Bowl, and he wouldn't have been here had there not been an AED immediately available to him. So, you're going to hear some testimony that says, we shouldn't be singling out a single industry. And so we are not singling out restaurants, just to be clear. In statute, a food service facility means a place where food and drink is prepared for sale or service, an operation where food is served
or provided to the public with or without charge. It includes a restaurant, coffee shop, cafeteria, short order cafe, luncheonette, tavern, sandwich stand, soda fountain, retail market, Safeway, Giant, or retail bakery outlet. It also includes an industry institution, healthcare facility, club, school, camp, church, catering kitchen, commissary, or any similar place where food is being prepared and served. And again, I'm going to emphasize that this bill only addresses those food service facilities that have a gross annual income of $400,000 or more a year. We feel like the machines have come far enough along that they are foolproof, so we're willing to discuss whether or not the training that is currently required in statute would continue to be required under this bill. So, part of our job as legislators is to keep our residents safe. And this bill is one way we can do that. I humbly appreciate your consideration of the bill and would respectfully request a favorable report. And I have a great panel here today who's going to explain a little bit more about what the impact would be, and also to demonstrate just how easily the machine is operated. So, Carol, you want to go first?
Yes, please. Thank you, Delegate Collison. Madam Chairwoman, member of the committee, Joe Shea, my dear heart husband, was a joyful man who was not ready for his life to be over. He was a public school teacher for over 33 years. He was a Reiki master who helped Congressman Jamie Raskin during the first fight for his life. He rode motorcycles with Senator Astle and was a student pilot. He taught Hapkido, gun safety, and scuba diving. He was an officiant who united many couples in marriage, including our 2 daughters. He was a lot of fun, a loving, honorable, courageous, good man. He was a victim of sudden cardiac arrest. There was not an AED available in the restaurant. He did not survive. Damar Hamlin is a joyful man, a talented athlete who gives generously to his community, a good man. He was a victim of sudden cardiac arrest. There was an AED available. He did survive. Cedars-Sinai Heart Institute states, compared to Caucasians, African Americans face twice the rate of cardiac arrest and are an average of 6 years younger. The Maryland Restaurant Association website says the Maryland industry is the most diverse industry in America. The patrons that support the Maryland restaurants are a beautifully diverse population. CPR AED training is very inexpensive and often available for free from people like Ryan Killow and Dr. Zachariah. According to MIMS, the cost of AEDs vary from $500 to $1,700. A $500 tax credit bill is cross-filed in Ways and Means and Budget and Tax. The balance is then tax deductible. It is a very small price to pay to protect the owners, the employees, and the patrons that keep the Maryland restaurants open. Please accept this bill for what it is. It is a simple, inexpensive, undisputed way to save lives that are not ready to be ended. My daughter said, "Have a heart, save a heart." Thank you from my heart. And I also would like to mention, very important, in all of the buildings here on campus at the security entrance, there is an AED. In the State House, there's one on every floor. Thank you.
And thank you for your testimony, and the committee is very sorry about your loss.
Thank you.
Okay, thank you. Who's next?
Hi, everybody. Thank you for, Madam Vice Chair, honorable delegates, committee staff. Thank you for the opportunity to be here. My name is Sammy Zachariah. I currently serve as the medical director of the cardiac intensive care unit at the Johns Hopkins Bayview Medical Center. And I worked at Johns Hopkins Hospital as well. And previous to that, I worked at the University of Maryland and a few other hospitals in the state. So I'm familiar with and saw a number of patients who suffered cardiac arrest, probably over 1,000. I also serve as the incoming governor-elect of the Maryland chapter of the American College of Cardiology. I know it's not as impressive as the Maryland governor position, but it's something, and we represent many cardiovascular professionals in the state. I want to just share a quick story. I was at a restaurant in northwest of Baltimore in Pikesville with 5 cardiologist friends and 2 AED, actually salespeople. And I know this is the start of a joke here, but after we finished our dinner and during the dessert, one of our party actually started swooning and kind of slumped over in his chair and then finally laid down on the ground. It took us, we're cardiologists, right? But even us, it took us some time to recognize that he was having a cardiac arrhythmia and suffered cardiac arrest. We ripped open his shirt, we felt for his pulse, and then we started the process of CPR. And then, it's just with foresight, one of the AED representatives had one in his car and ran to his car and came back minutes later. By that point, he came out of it himself with CPR and was rushed to a hospital, got good care, and then had an implantable defibrillator placed. But these devices make a huge difference for patients, and even among cardiologists, we can't do anything if we don't have these defibrillators at the restaurant with us. And I see this when I'm working in the cardiac ICU with all my patients who have suffered cardiac arrests. So I'm happy to support it. Please feel free to reach out if I can be of further help.
Thank you. And thank you for sharing the story with us as well. Next, sir.
Hi, my name is Ryan Killo. I'm an emergency department nurse as well as a paramedic and an AED advocate. I get to see this every day. Unfortunately, usually by the time I get to see someone as a nurse or a paramedic, they have not survived because they did not get defibrillated quickly enough. These machines, as pointed out, are very simple to use, very inexpensive, and you can't hurt anyone with them. So for my minute and 50 seconds, I would like to give you a demonstration of how easy these are to use. And I'm going to have Carol be my patient here. A little prep here. All right, so you bring the AED to someone's side. There's different manufacturers that make them. You bring them to the person's side. They're very easy to use. They have an on-off button. You turn it on, and it starts talking to you.
Unit, okay. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest.
The AED pads would be in an envelope. Obviously, the person, you would take their clothes off of them before you do that, but we won't do that here.
Well, thank you.
Attach defib pads to patient's bare chest.
You put the pads on the person just as shown. The AED is talking to you. It's showing you everything to do, and you also see all visuals.
Attach defib pads to patient's bare chest.
Once the pads are attached to the victim, the AED automatically recognizes that, and it will move on.
Analyzing.
And the AED is now analyzing the rhythm of the heart.
Don't touch patient. Analyzing. Shock advised. Don't touch patient. Press flash shock button.
This is a simulator. It will not actually deliver a shock. Once you're ready to deliver the shock, you press the button. It delivers the shock. It tells you to start CPR. It's going to walk you through the steps of CPR in case the person doesn't know that. It'll talk you through it. If you're not doing CPR correctly, it will take corrective measures to help you do CPR correctly. It's going to allow you to do CPR for 2 minutes and then stop you. And then it continues assessing the patient. So easy to use, inexpensive, and anybody can do it. Thank you so much.
Thank you. Are there any questions for this panel? I have Delegate Chisholm, followed by Delegate Chi.
Okay. Thank you, Madam Chair, and thank you for bringing this bill. I actually watched my wife save somebody's life in our gym at 6:30 in the morning a few years ago with an AED. They are pretty amazing what they can do and how they walk you through it and keep you calm. So thank you for bringing it. I guess my question is, because I did look at the list and I saw restaurants are down to like 26 or 27. I also saw that I'm not the only one that gets stressed out when I go to BWI. But do we have any idea of the 11,000 restaurants, bars, facilities that fall under this? What percentage actually have AEDs at this point?
We don't. That was one of the things you'll see in the letter from the MDH, saying that we don't have current information on that. We know that some do. And there are about 7,000 that fit in that 7,000 restaurants in Maryland, restaurants, only, not talking other food facilities, but restaurants alone, about 7,000 who meet that 400,000 gross annual income.
That would be great information to get, because
Yeah.
I'd be surprised if many of those establishments don't already have the AED, but I could be wrong. Thank you.
Thank you, Delegate.
Thank you. I have next Delegate Shi.
Thank you, Delegate Collison, for introducing this legislation, and thank you all for the testimonies. My question to the bill sponsor is, do you know what percentage of the restaurants in Maryland would fall below the annual revenue of $400,000?
Well, I know that the ones who do, it's about 7,000, and that's out of 11,000. So 4,000 would fall below that.
So 4,000 would?
It would not be required in those 4,000.
Okay, thank you.
Thank you. Next, we have Delegate Johnson, followed by Delegate Boafo.
Thank you, Madam Chair. Thank you, Delegate, for bringing this bill and panel. Can you tell us approximate cost of the unit and the training?
Can you do that?
I think Carol has the.
According to MIMS, they go from $500 to $1,700, but there, as I said, there's a bill in Budget and Tax and Ways and Means to give a $500 tax credit, so that would be, some of them would be free, some of them would be $1,200. I've seen them for about 1,000 to 11 seems to be the average, and they're also, whatever isn't covered by the tax credit is indeed tax deductible. So it can be written off as a business expense. Any training, anything can be written off as a business expense. I did check with an accountant.
My pleasure. Delegate Boafo.
Thank you so much, Madam Chair. Delegate Collison, thank you for introducing this legislation. And Carol, sorry for your loss, and thank you for your testimony here today. To the bill sponsor, two really quick questions. The first is just out of curiosity. Is there a reason why we're specifically focused on food service facilities?
They're the facilities that we are fairly confident everyone uses at some point. Not everyone's going to go to a gym, not everyone's going to go to a swimming pool necessarily, but at some point, sometimes daily, people are in food service facilities.
Thank you for that. And the second question is in regards to the annual gross income, right? So we're talking about income above $400,000. So the small mom and pop or the small newly opened Five Guys chain would not be eligible to that, right? We're talking about the individual businesses itself, not necessarily their larger conglomerates, right?
Great question, Delegate. And yes, it would apply to the individual store.
Thank you, Madam Chair.
Thank you. Delegate Kipke, followed by Delegate Bagnall.
Thank you, Madam Chairman. Thank you, Delegate. And my thoughts are centered around the threshold of $400,000. It's an extremely low number. Most, like a Five Guys is going to do more like 800,000 to 1.2 million if they're successful. But I see the public benefit to having these everywhere, wherever we can possibly get them. But having that threshold, what I'm concerned about is many restaurants fail on a regular basis. It's one of the most failing industries in the world because of the very nature of it: high labor, high turnover, high costs. Right now, food costs and labor costs is at a record high. Inflation, there's a recession possibly coming, we hope not. And so, I don't know if you considered tying it to or allowing for some type of economic hardship waivers or something like that. And then secondarily, have you considered maybe, since there's a public interest in this, perhaps there could be a public fund set up through the state that revolves every year with collaboration with perhaps the Maryland Restaurant Association, where the state actually pays for these?
In response to your first question, I'm absolutely willing to discuss what the threshold is and could be, and I would love to investigate the possibility of having a fund that would allow, as I started off with, it's to the benefit of all of our residents in Maryland to have these machines as pervasively as possible in all public places. Yeah, thank you.
Delegate Bagno?
Thank you, Madam Chair, and thank you for bringing this bill. I too think these are extraordinary devices. And I'm just trying to understand the threshold a little bit, because you had mentioned other food facilities that are like within schools, within other buildings and services. So is that threshold for the food facility that's encapsulated within another like nonprofit or school or organization? That's that threshold reflects the threshold from the food service. Is that correct?
It is from the food service, yes.
Any other questions? Seeing none, thank you so much for your testimony today. We really appreciate it. Again, sorry for your loss. My pleasure. Next, we have Ms. Kaylee Lackler from the Maryland Retailers Association, Mr. Melvin Thompson from the Restaurant Association of Maryland, and this is an unfavorable panel. Good afternoon.
For the record, Kaylee Locklear here on behalf of the Maryland Retailers Association. Respectfully in opposition, we have quite a few concerns, I think, to flag for the committee. And although I feel horrible hearing these stories, I want to acknowledge them. We understand that this is a very well-intentioned bill. Instances can and do occur in public with regard to cardiac issues, but wanted to flag a couple of things for you. The AED bill language, and my apologies to the sponsor for not getting to connect with her yet, but it specifies meeting the requirements of Section 13-517 of the Education Article, which includes device maintenance, facility registration, certification, and then training. I know the devices can operate and walk you through it, but the way the bill reads currently, someone operating it would have to receive training. So for each individual who is expected to operate the AED device at that registered facility. Because employees would have to receive training and a certification at a time when it is extraordinarily difficult to find employees, this is potentially an additional obstacle for employers who may have both existing and then potential employees who just may not feel comfortable performing this task. And then I'd also just say probably most concerning here is that with high turnover, numerous shifts in retail, ensuring somebody meets the state's requirements for training and then having them on every single shift just may not be possible. So Delegate Kipke, thank you for bringing up potentially some sort of hardship waiver, but I think we're gonna have to work through that. I also, the reason I'm sitting at this table, I know restaurants were just referenced quite a bit. The definition of food facility that's found in this bill is a lot more broad than I think what we've been discussing. You're gonna grab grocery stores, you will grab convenience stores, anybody basically that's selling any sort of prepared food. But also that section is really odd with regard to someone who has a beverage station giving away beverages for free. So we started to go down this path of nonprofits and churches and things like that. So wanted to flag those issues for the committee, more than willing to work with the committee and the sponsor.
Thank you. Good afternoon.
Thank you, Madam Chair, members of the committee. I'm Melvin Thompson. I represent the Restaurant Association of Maryland, and we're also opposed to this legislation. And of course, I'm sorry for Carol McDermott's loss of her husband. And I've also had conversations with the sponsor about this bill, and we'll continue to have some conversations. But an estimated 7,800 of Maryland's 11,000 restaurants have gross annual sales over $400,000 and would have to comply with this mandate. And in a 2017 Maryland Institute of Emergency Medical Services Systems report to the General Assembly, the incidence of cardiac arrest at restaurants is very low compared to other ranked location types in the report. Restaurants rank at number 26 out of 31 location types in Table 1 of the report. And in Table 2 of that report, restaurants are at 23 out of 26 ranked location types. And also, as noted in that report, knowing how probable it would be to experience an arrest while in a given location type is important to to consider when trying to determine where to install and provide education for the use of AEDs. And as also mentioned in a similar 2007 task force report for the General Assembly, they also noted that programs that place AEDs at locations that are low risk are unlikely to be cost effective since there is a smaller likelihood that the AED device will ever be used. And these devices cost anywhere from $880 to $1,700 per device, and that would be a significant cost to restaurants. And we could find no other states that had an AED mandate specifically for the restaurant and food service industry. And as Kaylee mentioned, the program would also require CPR and AED training, which can cost anywhere from $75 to $115 per person. And so for those reasons and the relatively low incidence of cardiac arrest at restaurants, we don't think this bill would justify the potential cost on our industry, and for those reasons, we request an unfavorable report. Thank you.
Thank you for your testimony. Are there any questions for this panel? I have Delegate Hutchinson.
Thank you, Madam Chair. I was struck by the threshold of 400,000, but you're the professional. What type of margin do restaurants have? So if it was a $400,000 gross income, what are we looking at in terms of what their profits are?
That's a very good question, and generally, industry-wide, when you're considering full service and fast casual and quick service, our restaurants average about a 4% profit margin, so very narrow profit margin for our industry.
Grocery is 1% to 3%.
Any other questions? Seeing none, thank you so much for
Thank
your
you.
testimony. We really appreciate it. And this will actually conclude the bill hearing on House Bill 288. I would like to thank our colleagues from Economic Matters for being with us, and you're welcome anytime. Our pleasure. Next, we have House Bill 82, Delegate Charkoudian. Will you come up with your panel, please? Maryland Medical Assistance and Children's Health Insurance Programs, School-Based Behavioral Health Services Reimbursement. Absolutely.
You know who you are.
And you can get started.
Thank you. Madam Chair, colleagues, for the record, Delegate Lorig Charkoudian, you're asking for a favorable report on House Bill 82. I think to some extent this goes without saying, but I'll just, as the preface, I think all of us have watched with absolute devastation and heartbreak as the teen mental health crisis has deepened and gotten worse and worse for our children, for our communities, across the state and across the country. You've probably heard about the recent CDC report that just came out that has some shocking data in it, especially with regard to teenage girls, but overall in terms of the crisis of mental health for teenagers. And so I think that we're called on as policymakers to basically bring every tool in our toolbox, everything that we have, mix up my metaphors, leave it all on the field. Like we have to make major changes, and we have to make major changes as quickly as possible because the crisis we're facing is not only devastating for the students, for children, for adolescents right now, but it has colossal implications for their ability to function long-term in society. And so this bill is one of what I hope will be many bills that we'll look at this session to address the mental health crisis among young people. And what this bill essentially does is it directs the Maryland Department of Health to adjust the Medicaid plan so that we are using Medicaid to reimburse school systems for school-based mental health services, either provided by school staff or provided by community-based mental health service providers in school settings. There are 18 other states that do this. In 2014, Federal rules changed, allowing states to be able to include this in their plan, and for whatever reason, Maryland hasn't. There's some specifics that have to get worked out in terms of what that plan looks like and how we do it, but it's absolutely possible to do. And I would say that it is incumbent on us to find the path to do it, given the crisis that we're facing. The idea is that children spend the vast majority of their time at school. Almost all children go to school. And so while we need to continue to support and increase services in communities, anything we can do that meets children exactly where they are and brings as much as possible in terms of mental health services to them is crucial. I think sort of a parallel piece that I just want to highlight is we've essentially, without sufficient mental health services in schools, we've been asking our teachers and administrators to do double duty, triple duty in already understaffed schools. They're dealing not only with teaching children who have experienced trauma and have struggled with gone through COVID and have not had the normal developmental opportunities because of the isolation during COVID. But now, in addition to having to deal with all those challenges that are straight up related to teaching, they're also dealing with mental health crises. And so we're asking our teachers, without bringing in the resources that are necessary, it's really unfair to our teachers to be handling these crises as well, as they're dealing with all the other challenges and the adult mental health challenges that we're facing. So with that, I'll pass it to my panel here, who I think can add a good bit, and I'll look forward to questions and working with the committee. I urge a favorable report on House Bill 82.
Thank you. Who will be next?
You're next.
Sure. Good afternoon, members. My name is Justin Dayhoff, Assistant State Superintendent at the Maryland State Department of Education. I'm here today on behalf of State Superintendent Chaudhary and the department to urge a favorable report from the committee on House Bill 82. The bill gives Maryland the opportunity to expand the number of students eligible for services that qualify for Medicaid reimbursement and expand the types of services eligible for Medicaid reimbursement. In 2014, the Centers for Medicare and Medicaid Services reversed its free care policy. That policy limited Medicaid billing to students with IEPs or IFSPs. These are also students who generate Blueprint special education funding in the Blueprint formula. Students who otherwise require mental or behavioral health support, who did not have an IEP or an IFSP, and whose family could not afford care had few options. Under the new CMS policy, state plans could allow for any student qualifying for Medicaid to be eligible for Medicaid reimbursement for school-based services, even if they did not have an IEP. This opened up an important policy window, and since then, as Delegate Morg said, 18 states have stepped through. Maryland has not. It is time for Maryland to catch up. House Bill 82 requires the Maryland Department of Health to amend the state's plan to leverage the new CMS policy as updated in 2014, and with that amendment, allow for Medicaid participating students to receive school-based services eligible for Medicaid reimbursement. House Bill 82 also expands the types of positions that can provide covered services that students receive, for which LEAs would then be eligible for Medicaid reimbursement, including school-based social workers, nurses, counselors, and psychologists. This expansion also allows local education agencies to bill for the school-based administrative costs, which include marketing and direct costs for billing and administering the program, including paying for the staff to do so. And to illustrate the potential of this program, Massachusetts has a comparable number of public school enrolled students. In 2016, CMS noted that Massachusetts sought reimbursement for $188 million in school-based services and administration. Compare that to Maryland's $78 million. The difference is substantial. This bill has the opportunity to expand services to many of Maryland's highest needs children at no cost to the state. It is a win-win for Maryland's children, and we respectfully urge a favorable report.
Thank you. Who will be next?
Would you like to go next?
Good afternoon, Madam Chair and members of the Health Government Operations Committee. My name is Labrina Hopkins, and I'm a certified special educator. I have served as a self-contained special education teacher, resource teacher, and IEP chair during my 22 years with Baltimore City Public Schools. I am also the Secretary-Treasurer of AFT Maryland and a member of the Baltimore Teachers Union AFT Local 340. As an educator, I ask this committee for a favorable report for House Bill 82. You have my written testimony, so let me just highlight a few points. In Baltimore City, we have a very diverse population of students with a diverse array of needs. Our schools have a large number of students that have required mental health services through an IEP or an individualized education program. Districts are able to bill medical assistance for these students. Much of these funds go to staffing of related service providers. However, we in the city have a large number of students, and I'm certain there are numerous students in a similar situation throughout the state that need mental health and behavioral services that do not meet the criteria for an IEP. Under current state law, districts are permitted to bill for services for students that do not have an IEP, even though the federal government says these students are eligible. If we change this law, districts will be able to bill for students without IEPs, and they would have access to federal revenue streams that would allow them to be able to hire additional mental health providers to render these services. Members of the committee, every student in the state has a constitutional right to a high-quality educational program. As it stands right now, Maryland is leaving money on the table in the form of federal dollars that are meant for students with varying needs. Again, I call for a favorable report for HB 82. Thank you for your time.
Thank you for being with us. Who will be next?
Thank you, Madam Chair and members of the committee. Rob Garagiola with Compass Advocacy, here on behalf of NAMI Maryland, enthusiastically urging a favorable committee report for House Bill 82. I want to thank the sponsors, Delegate Charkoudian and Delegate Cullison, for leading the effort on this. This is a very important bill. Obviously, the need is great. Nearly 1 in 6 children between the age of 6 and 17 experience a mental health disorder. That's an incredible number. And COVID exacerbated that. And what we know is that intervention and early intervention in particular is critical. Nearly half of all mental health conditions begin by age 14. There are some mental health services that are currently provided in the school system today with Medicaid dollars, but the family or the student need an IEP or IFSP in order to access that. What this bill does is this unlocks access to all children in our schools. And as was mentioned earlier by the sponsor, I believe 18 states are already doing this. 18 states have been doing this since the federal government changed its policy in 2014. Honestly, Maryland should have been leading this effort. We still can be in the middle of the pack, so to speak, but I would urge us not to leave federal dollars on the table. For every dollar that we would put in, the federal government would essentially be matching that. The bill, as was mentioned, would require the state to apply for a Medicaid state plan amendment. And as I said, it would leverage federal dollars. The last thing I would say is I understand that Catholic Charities and I believe CBH may have provided an amendment to this committee to ensure that these new funds wouldn't supplant current spending for community-based providers. NAMI Maryland supports that amendment as well. And with that, would urge a favorable committee report.
Thank you. Is Donna Christie here? She signed up to testify from MSCA, no? All right. We do have a virtual witness, Ms. Angela Kimball. Good afternoon. How are you? You can unmute yourself, please.
Yes, thank
Thank
you,
you.
Chairwoman and members of the committee. My name is Angela Kimball, and I'm the Senior Vice President for Policy and Advocacy at Inseparable, a growing movement of people working to advance policy solutions that reflect the belief that the health of our minds cannot be separate from the health of our bodies. One of our top areas of focus is getting youth help early, especially through school mental health services. I'm grateful for the opportunity to testify in favor of this bill today because Maryland and across the country, children and youth are struggling with mental health challenges that are affecting them not only at school, but also at home and even costing them their lives. As Delegate Charkoudian mentioned, newly released CDC data shows extraordinarily high needs for mental health care among youth, yet most go without. In Maryland, nearly half of youth with depression did not receive any care in the prior year. Yet one of the best ways to help our youth get the care that they need is to provide it where they are in schools. School-based mental health services reduce barriers to accessing care, and they also help normalize care and reduce inequities. In fact, the role of school-based mental health services is so important that the Federal Centers for Medicaid and CHIP Services encourages states to take advantage of billing Medicaid for school-based mental health services for all Medicaid enrolled students. With your favorable report, Maryland will move forward to do so and leverage more federal funding to support our youth. Inseparable supports amendments that would clarify that school-based services provided by licensed community professionals and paraprofessionals should be Medicaid billable, and that this funding is not intended to reduce or replace existing contracts for school-based services. Thank you for allowing me to testify on this bill.
Thank you for being with us. I'm going to call again before I turn to question. Donna Christie. All right. Good afternoon.
Good afternoon. My apologies.
It's okay. It happens. Thank you for being here.
Thank you. All right, Madam Chair, Madam Vice Chair, and members of the committee, thank you for having me today. I'm Dr. Donna Christie. I'm a school psychologist in Maryland for 25 years, and I currently serve as president of the Prince George's County Educators Association. And I first want to clarify that school-based services are not meant to supplant community-based services. It's a cooperative relationship, not a competitive one.
Take your time.
Sorry, I gotta catch my breath. I ran up the stairs.
Take your time. It's okay.
All right. In my work, I have seen firsthand the critical role that behavioral health interventions at school play in student success. We intervene in the real world, where challenges are most often experienced. My peers and I provide essential services that help students learn and thrive by connecting their behavioral supports with their academic programs. These services can be billed to Medicaid when we support eligible students as part of the IEP process. But regardless of whether a student has an IEP or not, they still need behavioral health services. And you shouldn't have to wait to have a disability to get those services. Early intervention services can prevent a condition that's short-term from becoming a long-term problem. At least 21 states have already taken steps to expand school Medicaid or are currently in the process of doing so. Maryland should be next. Further, the legislation offers an opportunity to address discrepancies in state Medicaid reimbursement by ensuring that MSDE certified school psychologists are eligible along with state licensed psychologists. Passing this legislation and the ensuing state plan amendment will increase much needed funds for local education agencies and highlight the critical role behavioral health plays in schools. By failing to take full advantage of school-based Medicaid, Maryland is leaving millions of dollars in federal funding on the table and shortchanging our schools. So I urge a favorable report.
You did it. Have a little bit of water. Okay, we're going to take your time. We're going to open it up for question because this was the sponsor panel. Are there any questions? I do see some. I'm going to start with Delegate Taveras, followed by Delegate Shalega, followed by Delegate Johnson.
Thank you. Thank you so much, Madam Chair. This is a hugely important issue, and I thank you so much, Delegate Shakudia, for bringing it forward. And as you may or may not know, we've had several suicides in my district over the last couple of years by children, 10 years old, one a 12-year-old attempted, and so on. So we've had a lot of challenges over these last couple of years. But in these 21 states that have adopted this legislation, have we seen an increase of service providers within the schools? Because the reason why I ask is there's a huge discrepancy within Prince George's County, particularly regarding the ratio of how many school psychologists we have and how many students they serve. If that type of gap is closed, then this is something that's definitely needed more sooner rather than later. Thank you.
Do you know, Justin, or Angela may know?
One person who can answer it?
Okay, yes, Justin.
Thank you.
Since the passage in 2014, and since the 18 states who've adopted it so far, and then the several others who are in the process of amending it, what we have seen are substantial increases in the Medicaid billing and reimbursement for those for those states that go down to the schools as they hire and bring on more personnel to do this, because it's the service delivery, but they also are able to reimburse the cost for the administration of it. So they're able to hire the personnel to also help with the billing processes and the other pieces of administering and marketing the program as well.
Tricks of all that for these 18 states?
We could probably find that.
Can you
Yes, I
please send it, if I may, send it to the committee, please? And the committee will make sure that the members get it.
Madam
Thank you.
Chair, may I just, one sentence. The federal government recently, I think it was.
We usually only allow one, but I'm going to go ahead and allow it. Go ahead.
Thank you, Madam Chair. The Bipartisan Safer Communities Act provides about $1 billion for mental health professionals, and that money is going to be coming forward to the states that they can take advantage to try to address some of those issues as well.
When is it anticipated?
The legislation was enacted last year. I don't know when, soon. I mean, I think the Department of Education is kind of putting together the grant program, and I believe, potentially this year, some of those dollars are going to be available for states.
Thank you. I'm glad I allowed the comment.
Thank you,
Okay.
Madam Chair.
So next we have Delegate Shalega, followed by Delegate Johnson.
Thank you, Madam Chair. Thank you all for being here. Of course, we're all concerned about the mental health of our kids. And just passing comment, you had said marketing. I don't think we need to market mental health services. So hopefully you didn't mean that you were going to put flyers in kids' mailboxes. But my real question is twofold. One, in the other 18 states where this is set up, is it taking away from classroom instruction, or are we able to find time for kids to get mental health services? I mean, we have 23 schools in Baltimore City where 0 kids are proficient in math, and I certainly, know mental health is critical, but we can't take away from classroom instruction.
So I can't speak to the 18 states, but I do know that people's mental health affects their ability to engage in learning. So,
Thank you. So maybe not, is what you're saying.
So as a school-based practitioner myself, I could answer that question.
So I'm going to allow it, but can you make sure, Delegate Shakoudian, that whoever has the answer can give the answer, okay? So go ahead.
Thank you. So 25 years of providing services in schools, you work with the student schedule to find the best time where it's good to pull them out. A lot of districts have blocks of time where kids can go for different intervention time. It's just like pulling a student out for other services. They can access you. If they're not mentally available to learn because they are in need of support services, better to let them miss class for a few minutes, get the situation resolved, and go back, and they're more prepared to learn. So sometimes they might miss some instruction, but it's very minimal, and you can work with the student schedule to work around it.
After school, if it's a school-based health center. But
Sometimes, yeah.
finally, the question would be, is there parental consent involved? I'm concerned there's some testimony that we've seen that unfavorable because of the concern about parental involvement in this mental health services.
So yes, as a school psychologist, I can see a student one time in a crisis situation. You should always inform the parent afterwards. After that, you need to get parent consent for any kind of services. Parents have the right to consent to all services.
Thank you.
Thank you. Any other questions? Actually, hold on a second. I had Delegate Johnson. Oh, wonderful. Thank you. Great minds think alike. Delegate Bandari.
Yeah, thank you, Madam Chair. It's very important bill. And one of the bill's mandate that Maryland Department of Health is required to provide training and technical assistance to schools and mental health professional on program enrollment, billing documentation, compliance, quality services, and so on and so forth. My question to Delegate Charkadian, did you see the department letter, the information?
I did, yeah. Is there something specific?
Do you want to comment on that?
In it that, well, so there's some specific pieces. I mean, I can say that the Department of Health I've had a lot of conversations with them over the last several months, and so the previous administration and then the new one. I know that they had an audit they were concerned about that happened back in 2002. Then the federal rules changed in 2014. It's subsequent to the 2014 rules change that these 18 states and the 3 that are working on it kind of have tried to move forward. And so some of this reflects, I think, pieces that were sort of issues before that time. They mentioned the fact that there have been efforts, the consortium and others, to move in this direction. That's true, and I think what this bill does is it says, like, okay, let's now move this forward, let's get this done. So I think that to that extent, their comments there, I don't want to interpret their comments, but I think they're saying this is where we're headed, and I'm glad, and now we can kind of finalize it and make sure it happens. The last point that I just want to make is that we did look into this question about school psychologists, and you found a path forward with the Attorney General's opinion and others to make sure that even though the qualifications are different for school-based providers, in this case school psychologists, and community-based providers, we did look into what is done in these other 18 states to where there are differences in the qualifications, to have a path that allows for those school-based providers to have their work be reimbursable. So there are paths and ways to address all of these things, and we've been working with folks in other states and in MSDE to address them.
Any other questions? Seeing none, thank you so much. And Dr. Christie, thank you for being with us today. Thank you. Next, we have a favorable with amendment panel, and we have 3 people: the Maryland Coalition of Families, Catholic Charities of Baltimore, and Robin Elliott. Will you all come up, please? And as soon as you sit, please give us your name and you can start testifying. Thank you.
Okay. Good afternoon. Robin Elliott. I'm here today on behalf of a long list: the Maryland Assembly of School-Based Health Centers, the OTs, the nurses, the professional counselors, and the school counselors, all favorable. Some have small technical amendments. They'll sound familiar to this committee. A lot around who actually licenses or certifies. And I think there might be a way to address that issue uniformly rather than spell out each individual practitioner. And I'd be happy to work with the subcommittee and the sponsors on that. Thank you.
Thank you. Who's next?
Hi, I'm Regan Vaughn with Catholic Charities. Thank you, Madam Chair and members of the committee. We're here in support with amendment of HB 82. For over 100 years, Catholic Charities has been offering care and services to Marylanders in need. And right now, that includes us offering school-based behavioral health services in over 100 public schools in Maryland, including Anne Arundel, Harford, Baltimore County, Baltimore City, and Frederick County. And I want to make the distinction between school-based and school-employed. This bill is about school-employed providers for the most part, or the possibility of contracting down. There are already school-based behavioral health services going on in the schools now where Medicaid is billed and non-IEP students are being served. And that's by 18 different providers, including Catholic Charities, in 909 public schools. So this is happening and Medicaid is being billed, but Medicaid is being billed through through outpatient clinics and then through the ASO. So it's not being counted as the school's billing Medicaid. So our model is we have a clinician who either full-time or part-time is assigned to a school and is there to see students that are referred to them by individuals in the school. We are able to provide those therapy appointments in the school and then refer them to the full services the clinic can offer, whether it's psychiatric care and med management, PRP, family therapy, and we can do that 12 months of the year because our clinics are open year-round. While we appreciate this bill and want to see school-based services expanded, we want to make sure it doesn't push out the community providers that can provide that wider range of services to students in the school. And our main concerns are, one, we're always fighting over workforce. We don't want to fight over caseload, and we have difficult Medicaid billing rules we're dealing with. So we look forward to working with the sponsor. My amendments are in our written testimony, and we hope that we can make this work for Maryland. Thank you.
Thank you. Is Ann Gittes here for the Maryland Coalition of Families?
I think she's testifying across the street right now.
Okay. There is a letter here, and I should have asked the sponsor, but since I'm not able to, I'm going to ask both of you. It's from the Maryland Department of Health, and it states that a 2018 report published by the U.S. Department of Health and Human Services outlined the audit risk associated with administrative service claiming. And in August 2022, CMS indicated guidance on administrative claiming is forthcoming. And basically, they said that until this guidance is released, it is not feasible for MDH to accurately assess the feasibility, cost, potential savings, or timeline to implement an administrative claiming program. Additionally, MDH notes that one of the duties of the Maryland Consortium on Coordinated Community Support is to develop a model for expanding available behavioral health services and support to all students through the maximization of public funding through the Maryland Medical Assistant Program. Have you seen this at all?
I have not seen the letter. I am aware of the work of the consortium. They were budgeted with $125 million to grant out to help build up school-based behavioral health, and I think are working with us to find the balance between school-employed and community-employed practitioners in the school.
And then they also have another concern that says, federal guidance mandates that school-based providers and professionals must have the same credentials as those held by a community provider, in addition to meeting other record-keeping requirements to be eligible for reimbursement through Medicaid. Given this requirement, certain provider types included in the bill language would not be eligible for reimbursement, such as school psychologists who are currently not required to meet the state's licensing certification and other applicable qualifying criteria. So I would ask, I know that the sponsor of the bill is still here with us, and thank you for staying. If you're able to talk to Tricia Rowdy from Medicaid, that would be wonderful. Okay, thank you very much. Are there any questions? Seeing none, thank you for being with us today. Now we have a panel of unfavorable, and that is the Love Maryland PAC, Jenna Butler, and the USAF veteran, Dana Schultz. Will you come up, please? Are you here? Jenna Butler? She's virtual? Okay. Wonderful. Will you be so kind and unmute yourself? Not able to hear you. It's okay.
There we go. Thank you.
My pleasure. Good afternoon. How are you?
Good. Thank you. How are you?
Good. You can get started.
Okay. Good afternoon. Good afternoon, committee members, Chair Pina Melnick and Vice Chair Kelly, and thank you for your time today. My name is Jenna Butler, and I'm here representing the Love Maryland PAC. We are requesting an unfavorable report for HB 82. We are opposed to the state paying for services that parents are not notified of. As many of us are familiar with, pediatric care and especially behavioral health care can be very complex. It may require different therapies, different services, several different providers, all working in concert together. When a parent is not aware of behavioral health services that their child is getting at school and that are then being paid for by the state, this can create conflicts or gaps in care. This is not set up optimally for safety or for successful treatment outcomes. The best care for children is a result of providers and parents working together, making sure all the bases are covered and that there are no overlaps and there are no gaps. HB 82 is also unnecessary because we already have a process to solve this problem. An IEP in the school system would make sure that parents have knowledge of any services that their child is receiving and that the services would still be paid for. This is the ideal way for families to be aware of their child's treatment plan and to access financial support to get their child any needed services. I know that is a goal that we can all support. Thank you.
Thank you. Are there any questions? Seeing none, thank you for being with us today. And then we have another virtual witness, Ms. Dana Schultz. Just give us a minute. She's not there? Not in the waiting list? In the waiting room? Okay. So she's not in the waiting room, so we did call her. So this actually concludes the bill hearing on House Bill 82. Thank you, Delegate Sharkoudian, for being with us. And please work with the subcommittee and counsel for the committee. Thank you. And thank you for the witnesses. Next, we have House Bill 318, Delegate Bagnall, Maryland Medical Assistance Program, Provider Agencies and Personal Care Aides, Reimbursement and Wages. Delegate Bagnall, will you be so kind and call your panel? And as soon as you sit, will you be so kind and get started?
Good afternoon, Madam Chair and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here on behalf of House Bill 318. You have my written testimony, so I will summarize. Many in this committee have heard about the challenges in the workforce for home health care. Older adults and individuals with disabilities often require specialized care that may be provided either on-site at a long-term nursing home or at a residential home through the help of a personal care aide. Increasingly, we are seeing a desire for home care over other types of long-term care, with Marylanders demonstrating a desire to age in place, resulting in increased demand for personal care aides. Despite this increase in need for home care workers, the number of personal care aides available to work in the state, with studies demonstrating a potential increased need of 40% over the next 10 years, has not grown to meet the demand. Though the work is rewarding, it is also difficult. And residential service agencies, or RSAs, have experienced very high turnover rates and have requested reconsideration of the Medicaid reimbursement rates. Many personal care aides find themselves leaving the field altogether in search of more competitive wages, as current law does not require that rate increases be passed on to employees. House Bill 318 provides a solution to this issue by increasing compensation for personal care aides, incentivizing them to stay in the workforce, while increasing the reimbursement rate for RSAs as well. House Bill 318 provides greater compensation for personal care aides in two ways: raising Medicaid reimbursement rates and increasing provider agency wages. Medicaid reimbursement rates will raise from $23 to $25, increasing income and retention among aides compensated through Medicaid. For home care workers who are not reimbursed under Medicaid, House Bill 318 increases the minimum wage required of provider agencies to the greater of $16 per hour, or 64% of payments RSAs receive. Both of these changes not only provide frontline home care workers a deserved raise, but also a much-needed incentive for personal care aides to remain in the workforce. Competitive income will draw personal care aid, will also draw more people to home care work, increasing the number of aides available in the workforce and closing the gap on the demand for the profession. We have an obligation to meet the needs of Marylanders receiving home care by providing them a full-fledged and robust workforce capable of helping them. You will hear concerns from some of the stakeholders about increased costs to RSAs with the wage increase and administrative burden, but we believe this does not reflect the cost savings and administrative reduction which results from reducing the constant staff turnover. Policies like this have been implemented in states across the country. The wage issue is also a significant equity issue. Personal care aides in Maryland are mostly women of color. About 90% are women, about 70% are Black women. Maryland's low Medicaid reimbursement rates and lack of any wage floor other than minimum wage trap workers in poverty, creating this turnstile effect on the workforce. Higher rates and wages will help move Maryland closer to race and gender equity and prepare us to meet the growing need for at-home services, provide greater consumer choice. Additionally, we've requested a meeting with the department to further understand some of the concerns that they outlined in their letter. And for all these reasons, I respectfully request a favorable report on House Bill 318.
Thank you. Who will be next?
Good afternoon, Madam Chair, members of the committee. My name is David Rodwin. I lead the Public Justice Center's Workplace Justice Project. We thank Delegate Bagnall for introducing this important bill, which is really about making sure that the workers who provide the care, who do the Medicaid-funded work, get a fair share of the money that the state is spending on it. I just want to highlight 3 data points in our written testimony. The first is shown in a chart from a recent report. That chart shows that the population growth projected for Marylanders 85 and above is skyrocketing over the next decades. And we simply do not have anything close to the home care workers that we're going to need to meet that growing demand that goes along with that demographic change. The second is a brand new report by the Economic Policy Institute and New America, finding that Maryland ranks 49th out of 50 states, the second worst, in the difference between home care workers' actual wages and what's needed to attract and retain enough workers to meet the state's need. The third is a recent study by Washington, D.C.'s Long-Term Care Coalition, finding that up to 70% of the district's home care workers live in Maryland. And that's because, obviously, workers aren't getting paid enough in Maryland, so they're going to the district where they're getting paid more. What this bill does is it increases Medicaid reimbursement rates going to home care agencies while making sure that a fair share of those rates actually reaches workers. At the same time, the Commission to Study the Healthcare Workforce Crisis in Maryland has really shown a light on the lack of data that we have about Medicaid-funded home care. So what this bill does is it requires annual cost reports. This is something that lots of states do. We have not, but New York does it, for example, and it works really well to show data about this workforce. We think that it will not be as expensive as articulated in the fiscal note, which makes some assumptions we disagree with. And for all of these reasons, we ask for a favorable report. Thank you.
Thank you. That was excellent. Can you follow that?
Can I follow it?
Yes.
I'm not sure. I don't think I can follow anything that David does because he's a rock star in my book. Madam Chair, it's a pleasure to be before the Health and Government Operations Committee this afternoon, sorry. My name is Tammy Bresnahan. I'm the Director of Advocacy for AARP Maryland, and we are a proud member of the Carrying Across Maryland Coalition. We've worked with David and other organizations like Alzheimer's for the last 5 years to highlight this industry, to highlight the long-term care services that are provided to our seniors and to others in Maryland. AARP believes that living wages and salaries should be commensurate with comparable salaries in the state and with the time, skill, and effort required to render high-quality services and supports. Medicaid reimbursement rates should be rebased and updated regularly to consider relevant economic, financial information, including provider cost. State government should require pass-throughs using additional LTSS or long-term services funding or other mechanisms to increase compensation for direct care workers. In addition, like David, we agree that accountability procedures such as audits to ensure that reimbursement increases designated for staff costs are used for that purpose. So with that, you have my written testimony. There's a little bit more detail in there. We really appreciate the time and your consideration of this important bill, and we ask for a favorable report for House Bill 318, and we thank Delegate Bagnall for bringing this to the committee and to the legislature because this is a very important issue. Thank you.
Tommy, you did better than he did. Go ahead.
Chair Peña-Melek, members of the committee, Eric Colchimero, for the record, Alzheimer's Association, here in support of House Bill 318. Alzheimer's, the most common form of dementia, is a disease that gets progressively worse over time. It's typically characterized by 3 stages. In the early stage, symptoms include trouble with planning, coming up with the right word or name. In the moderate stage, people can have trouble even getting dressed. And as it progresses to the latest stages, people can have difficulty communicating and eating and require around-the-clock care. It becomes an extraordinary challenge for dementia caregivers, which wears on their mental and physical health. And at some point, frankly, it becomes too much, and they require a home health aide to assist with their loved ones. This legislation is important, and I am pleased that the Maryland National Capital Home Care Association supports the intent of the bill. There are many good actors in the home care industry, yet there are, unfortunately, those who are not paying their workers a living wage, those who are misclassifying their workers as independent contractors. With this bill, we get toward a solution, and yet I'm frankly disappointed that we're not seeing a favorable with amendments testimony from the industry about a solution. We need a solution about how to help this essential workforce. This bill presents a solution to address the concerns about a living wage, to address transparency in the industry. It may need an amendment or two, but it gets us toward a solution to address living wages and bad actors. I urge a favorable report.
Thank you. Is Lorraine Aricott here?
Here, Lorraine.
Will you come up, please? And also, if I may, Audrey Sellers, will you be so kind and come up as well? Because this will be the sponsor panel, and then we can open it up for questions, okay? Who would like to get started?
I can. Thank you, Chair Peña-Melnick and members of the committee. My name is Lorraine Aricott. I'm the Senior Policy Analyst with 1199 SEIU, United Healthcare Workers East. 1199 supports HB 318 because we believe the state needs to invest in the care workforce. 1199 SEIU are members of a larger coalition called Caring Across Maryland. This coalition is building a care movement powered by those directly impacted by our broken long-term care system. The voices of care workers, loved ones, advocates, patients are calling for the state to pay attention to our most vulnerable and devalued care workers, who are predominantly women of color. Nearly 1 in 10 personal care aides are living in poverty in Maryland. Higher wages means personal care aides are relying less on public assistance. 1199 is at the forefront of managing a staffing crisis across the healthcare industry. Better pay translates to higher retention, lower turnover, increased quality of care, which benefits both employers, patients, and care workers. We have a home care worker who could not be here today because she could not find childcare. Fatima is a single mom and proud immigrant from Gambia. She's raising 3 children on her own. As a home care worker, she's earning $15 an hour, and the agency she works for does not give her enough hours to make ends meet. Last year, Fatima was fighting eviction because she could not pay rent after an injury at work caused her to go to the hospital. Higher wages means well-supported workers. Well-supported workers means quality care for our loved ones. Because care can't wait, we request a favorable report on HB 318. Thank you.
Thank you for being with us and for the work you do. Next, please.
Hi, my name is Audrey Sellers. I'm an advocate with Disability Rights Maryland and also a part-time caregiver for my friend Brennan, who has a traumatic brain injury and receives 96 hours a week through the Maryland's Brain Injury Waiver and Community First Choice programs. While he receives 96 hours per week, he has 20 of them staffed and has only had 20 of them per week staffed since he started being authorized to receive services in 2019. This means that he can't have a job, he can't truly live out, the promises of the Olmstead decision, living in a non-segregated, environment, included in the community, really part of everyday life. He's essentially just as shut away as he would have been in a nursing facility. With the End the Waitlist Act passing last session, there's going to be a huge demand for Medicaid-funded care in the future through these programs. We have no way to fulfill those promises and are basically, I think, just committing to making the promise, without passing some kind of legislation that would make being a personal care aide or a PCA, a livable job with, benefits and a living wage. We're just going to make a bunch of empty promises that really hurt people with disabilities in Maryland. If you have any questions, I would be happy to answer them. Thank you for your time.
Thank you. And you're a good friend.
Thank you.
Are there any questions for the sponsor and her panel? Delegate Hutchinson?
Thank you, Madam Chair. My question is to the gentleman at the table. I didn't get your name, so I'm sorry about that. You had indicated that you did not think the fiscal note was accurate. Had you done your own analysis, and if so, could you share that with the committee?
Yes, I will. Yeah, and I can do it in writing, and also briefly, we anticipate additional rate increases independent of this bill. And so this bill, the fiscal note, as I read it, assumes that there won't necessarily be those rate increases. over the last 15 years or so, rates have only gone one way, and that's up. And the assumption that they'll remain static, I don't think is a reasonable one.
Delegate Taveras.
Thank you. Well, last time I recall, when we made assumptions regarding static pricing, we ended up with a movie called Marginal Recall and a housing bubble bursting, but, you know, I don't know if y'all remember the inherent assumption of assuming that all housing was only going to go up. I have a question with regards to this particular bill. It seems, if I recall correctly, there was a, you all are all advocating for $16 per hour, to increase it to $16 an hour, correct? Nobody can live off of that. That's not living. I don't know why are y'all not advocating for something higher that's more sustainable. I mean, I think that the market was like at $17.25, and I mean, anybody can make that on the street. And the reality is that if you're looking at a living wage, that's like actually $26 an hour. So I don't know why
What is the question, why?
I don't understand why they're so low.
All right, can you answer that question, please?
Thank you for that question, Delegate. I wish we could go higher. For every dollar an hour that you increase the reimbursement rate, it increases the fiscal note quite a bit. And we all see what the fiscal note is with $16 an hour as the wage floor for these workers. The thinking is it's better to do something than nothing. It's not quite, candidly, I don't think it's a living wage, but it's something closer to what workers are getting now, which is about $13.50 an hour. And it also attaches a requirement that workers get as their wage rate 64% of whatever the home care agencies receive from Medicaid as their reimbursement rate. So the idea is $16 an hour is 64% of $25 an hour. So if you just stay with me for a moment, the reimbursement rate's 25, the worker gets 16, that's 64%. So as reimbursement rates continue to increase over time, workers would continue to get at least 64% of that reimbursement rate as their wages. So as the rates increase, it'll become something closer to a living wage, which is an attempt to make the bill more sustainable so we don't need to come back every year. But I appreciate the question, and I agree.
Attachment to performance?
I'm sorry, an attachment to performance? If I might just clarify, in other words, the home care agencies receive the money only if we ensure that they're paying the wage floor?
No, that the client is improving or see some.
I see. So a sort of paper performance. I think in this model, generally speaking, it's a little bit difficult to measure. However, as Ms. Sellers was describing, the problem that we're seeing now is this issue of what we call unstaffed hours. So individuals are getting hours allotted to them by the Department of Health. In other words, there's a needs assessment. They're being assessed to need a certain number of hours in order to maintain their independence in their homes. They're not finding workers to do the work to do those hours because the pay is so low.
All right, thank you. And if I may, because I know we have, some new members on the committee, a lot of these bills, it's the right thing to do, right? But they all come with a fiscal note. And we have so many programs. Like today, we have a lot of Medicaid expenses and expansion, but we can't do it every day because the budget is limited. We just can't pass them all, I meant to say. So you make choices, and that is the reason why they're not able to ask for what you really want. So in any event, it's choices that we make every day to balance our budget as well and do it in a smart way. Thank you for, I don't see any other questions for you. I have another panel I'm going to call. Thank you for your work, because I know the work you do is not easy. Thank you very much. Next, we have a favorable panel, and that is actually Job Opportunity, the Job Opportunity Task Force, Ms. Iona Stoica, Fatima Yalo, and Wendy Wiley. Will you be so kind and come up, please, together? And as soon as you sit, will you be so kind and get started?
Sure.
Thank you so much.
Good afternoon, Chair Peña-Melnick and members of the committee. My name is Ioana Stoica, and I'm a policy advocate with the Job Opportunities Task Force, a nonprofit organization that advocates for low-income workers, which is why we are here in support of this important bill that will improve job quality for thousands of workers who have been woefully underpaid for the laborious work they perform. Home health aides are some of the lowest paid, yet it's one of the most extremely demanding positions. The median annual wage for this profession is just over $29,000. At this wage, someone would have to work 78 hours a week in order to afford a one-bedroom rental home at fair market rent. This is how we treat workers tasked with a sensitive job to care for our loved ones and some of our most vulnerable community members, including seniors and individuals with disabilities. And this is how we treat workers in a profession who are predominantly women and people of color. In Maryland, it is estimated that 90% of these individuals are women and that 60% of them are Black. Raising wages would ensure that this work is appropriately valued and also would play a critical role in addressing the racial and gender wage gaps. Systemically, we also need these reforms in order to address recruitment and retention in one of the fastest growing fields in our current economy, with one of the highest turnover rates of all professions. Employment in this field is projected to grow at 25% over the next 10 years, which is much higher than the average of 5% for all professions. Meanwhile, the turnover rate is 65%. If we don't address the problem, we are going to reinforce the creation of a two-tiered system in which individuals with means are able to afford care, while the rest of us are left to fend for ourselves. Treating our healthcare workers with the respect of wages commensurate with the work that they perform translates into treating ourselves and our families and our loved ones to the care that we deserve, which is why we strongly urge a favorable report. Thank you.
Thank you. Next, please.
Good afternoon. My name is Nadira Wiley, and I've been a home health aide provider for a little over 30 years. In order for me to be able to survive from that salary, I also teach phlebotomy, and I'm also a lab technician. I've always loved being a caregiver. When I was like a child, my mom was a private duty nurse, and she taught me what to do to help care for other people. But I'm here today to advocate for all home health care workers. We are doing some of the most, I don't know how to put it, some of the jobs that people would never want to do, and we're not compensated adequately for it. I once had an experience with one of my patients. She weighed over 400 pounds, and it was always very difficult to bathe her. And she became afraid of the Hoyer lifts that you use to pick them up, to bring them to the bath. And because she was afraid of it, she struggled, and the Hoyer lift fell, and it broke my shoulder. I had a rotator cuff repair done on that, which rendered me unable to work for about 3 months with no compensation, no workman's comp, no paid leave. I actually have not had a vacation since 2004. I would love to go on vacation. I have 21 grandchildren and great-grandchildren mixed. I would love to be able to visit some of them. I'm here today because home health care workers, we don't have a voice. Thank God we have some today. But normally, speaking with other agencies, when you talk to your providers, they tell you that they can't raise your pay. They're already at the max. $15 is a max. And that's what they give me, and I'm 62 years old. One day I might need a provider myself. I've had brain surgery. I've had 2 brain tumors, aneurysms, and I've suffered 2 strokes. And if it wasn't for loved ones of mine that are personal caregivers, I don't know where I would be at this point today. Again, I'm asking for everyone to respectfully, I request for you to give the honorable report for HB. Thank you.
And thank you for your work. We really appreciate it.
Thank you.
We have one more person that I call, and she did not come up. I'm going to call again and see if she's able to come up. is it Wendy?
I'm Wendy,
I
I'm
thought you're
sorry.
Wendy.
Yeah, I'm Wendy.
Fatima? Fatima
couldn't make
Jallo?
it today.
She's not here? Okay. So again, Wendy, thank you for the work you do, okay? We
Yes.
really appreciate it, and we appreciate your testimony today, like, we're listening.
Thank you.
Next, my pleasure. Are there any questions for these two witnesses? Seeing none, thank you for being with us, and thank you for your patience as you waited. Next, we have an unfavorable testimony from Dana Kaufman. Dana Kaufman? No? Okay, one more time, Dana Kaufman. All right, we're going to go to a virtual favorable, so we have two virtual oral favorable testimony. The first one by Ms. Geneva Stone. And if we can just wait a minute. Followed by Ms. Esther Ward. Good afternoon, Ms. Stone. How are you?
Yes, I'm fine, thank you. Sorry, I couldn't hear any audio for a second.
It's okay. You can get started.
Okay, thank you. Dear Chair Pena-Melnick, Vice Chair Kelly, and members of the HGO Committee, I'm Geneva Stone, an author, advocate, and mother. My son, Rob Stone, an artist and advocate, has disabilities and complex medical needs. He has had home care supports through the DDA since 2006.
Can you speak up a little bit? Or a
Yes.
little closer? Thank you.
Yes, he has had DDA, home care supports through the DDA since 2006 and REM since 2012. I support HB 318 because my family's livelihood depends on home care for Rob. In 2006, I was trying to re-enter the workforce after years as Rob's primary caregiver. I have a PhD and estimate that my family had lost nearly $500,000 in income at that point. We also struggled to keep our health insurance and stave off bankruptcy. Rob didn't qualify for Maryland Medicaid through REM until 2012. I found a part-time federal job that offered health insurance. I held on to that job for 6 years only because my boxes were beyond flexible. Our RSA couldn't keep staff in place. At one point, the turnover was every 2 weeks, and we had long gaps without workers. I could change the days I came into the office, I could work from home, but eventually, when the advisory committee's budget was reduced, my job was cut. My boss said it was because it was clear I couldn't work full-time. That was the last job I had outside the home. I realized I could never be a reliable on-site worker because the workforce that supported my efforts couldn't be reliable. The RSA paid only $10 to $11 an hour to care for a boy with mobility, communication, and health needs. The pandemic has only made things worse. Worker retention depends on higher pay, workforce training and development, and a state system that protects job quality and quality of care. When home care workers cobble together a living, workers like me have to cobble together a living. There's the domino effect. My family has lost nearly $1 million in income because of the failures of Maryland's home care system. That's tens of thousands of dollars in state taxes. I value my son's home care workers, and it's time the state does too. I urge you to issue a favorable report on HB 318. Thank you very much.
Are there any, are there any questions for Ms. Stone? Thank you for being with us, and tell Rob thank you for being with us. I know he was with us earlier, okay? We appreciate your advocacy.
Thank you very much.
You're welcome. Next, we have Ms. Esther Ward, and we'll wait for her to come virtually.
$1 million in income because of the failures of Maryland's home care system. That's tens of thousands of dollars in state taxes. I value my son's home care workers, and it's time the state does too. I urge you to issue a favorable report.
Ms. Esther Ward, will you be so kind and just disconnect from the YouTube and give us your testimony.
Thank you for being.
Not a problem. You can get started if you like. You want to get started? You are muted. You can get started with your testimony. You can start talking. Are you able to hear me, Ms. Ward?
Now I can hear you. I apologize. Are you ready for me to begin?
Yes, we are.
Thank you.
You're welcome.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Esther Ward, and I serve on the Maryland Commission on Caregiving as a family caregiver. The Maryland Commission on Caregiving is charged with recommending policies that positively impact family caregivers. Following that charge, I am here to testify on behalf of the Commission in support of HB 318. House Bill 318 will increase the hourly reimbursement rate for certain personal assistance services under the Maryland's Medical Assistance Program to a minimum of $25 per hour. My own daughter is entitled to several hours of services from an aide under the Community First Choice program. However, due to the current low hourly reimbursement rates, she has not had an aide under that program since March of 2020. Fortunately, my daughter is also eligible for the DDA's self-directed service model. In this service, the hourly rate for an aide exceeds $30 per hour. Obtaining an aide under the service is easier. I serve as a support broker for other participants of self-directed services, and in fact, many individuals are only utilizing their higher-priced DDA hours for this reason. By raising the rates to make them more level across the different services, it would enable individuals to utilize the different services for which they're eligible. The enhanced reimbursement rate to the state would allow more people to be served. HB 318 would serve both the individuals meant to be served, as well as the direct support professionals providing the care. The Commission strongly urges a favorable report. I thank you.
Thank you for serving the state of Maryland and for your testimony. Are there any questions for this witness? Seeing none, thank you for your time and for your patience as you waited. I know I called earlier Dana Kaufman. I'm going to give you an opportunity to come up since you signed up.
Thank you. Thank you,
can
Madam
get started,
Chair.
please. You're welcome.
And I apologize. Luck of the draw, two bills called at the exact same time. For the record, Dana Kaufman, I'm here on behalf of the Maryland National Capital Home Care Association. And unfortunately, we are opposing this bill, and it's really just a matter of making the balance sheet work. And at $25 reimbursement, it does not cover the agency's cost to pay the $16 minimum wage. I think that there's a bigger issue that we have to take a look at though overall. We have this bill, you're going to hear other bills about Medicaid pass-throughs, but the bigger issue too that we all have to be looking at and considering isn't looking at each industry, but looking at Medicaid as a whole. I've been around for 20 years. We've seen all the different studies on trying to, ensure that reimbursement rates cover the costs of care and things along those lines. And unfortunately, Medicaid has never been a good payer. And for example, for the residential service agencies, one point to keep in mind is they are required to have registered nurses on contract, but they don't receive actual reimbursement for those registered nurses. So that's a cost that they have to absorb within their full rate, but it's not built into their rate. I think we need to take a look at our Medicaid program and how we want to go forward as a state so that we can ensure that those workers that are caring for Medicaid recipients are adequately reimbursed, but we can't forsake the agencies who are hiring them if the reimbursement won't cover the cost. So we're happy to continue to have conversations and look, we all want a robust workforce. We need a robust workforce. I don't think you can hear any more about the crisis in healthcare staffing. So with that, I will conclude and thank you for the opportunity to come to the table.
Thank you. I did see a letter from the Maryland Department of Health, actually with a letter of opposition, and I don't know if the sponsor of the bill saw the fiscal note. in there as well. Are there any questions for Ms. Kaufman? Delegate Johnson.
Ms. Kaufman, can you tell me, at $23 reimbursement right now, 64% of that comes to about $14.72. So at 64% of $25 reimbursement would be $16. So you're only talking about a very minute difference in relativity of what it is now. So are you telling us that they could not survive paying that minute difference?
So when we were, I'm sorry.
No.
When we were looking at this over the interim, we had many conversations with Public Justice, and the number that I had for us to break even, when we looked at the payroll taxes, workers' comps premiums that have increased and things along those lines, it was $26.52.
In reimbursement, it would only be a difference of a couple cents.
The $2
The $2 increase to $25 an hour for the home health company versus the 23 they're getting now, you're talking pennies difference.
Are you looking from the fiscal note?
No, I'm looking at what they get now, the $23 reimbursement. 64% of the $23 reimbursement comes to $14.72. So if 64% of an increased $25 reimbursement would come to $16, but they're getting a $2 increase, so they would actually be making more money.
But it's the greater of.
Correct.
So it's the $16. So I can get back with you on the math. I had just grabbed what our cost analysis was. But I have to be honest, you're losing me a little bit on all the figures, but I'm happy to sit back down with you at that point.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Taveras, you have a question?
No, I think well, I thought Mr. Johnson addressed one of them, but the thing is, what is for her, you're saying that it's a issue of balancing out the sheet. So what is the delta for you?
When we looked at the analysis, we looked at how do the residential service agencies stay whole? How do we be able to pay? What would we need to stay at a level playing field where we don't lose any money? Not looking to gain it, but how do we just stay level? And when we calculated and we based it on a $16, we came to $26.52. And that was based on looking at payroll taxes, workers' comp, some of the additional increases from Maryland Sick and Safe Leave, and unemployment benefits. And that's the number. I'm happy to sit down with you and show you those. We were very transparent when we sat with the Public Justice over the interim.
If I may, for the committee members to explain it a bit more, look at the Maryland Department of Health letter. It does reference all the numbers there, and you will be able to understand it.
And I haven't seen that.
Yes, Delegate Hill.
Thank you, Madam Chair. Dana, I guess the question was asked from the first panel, why is this not unfavorable or favorable with an amendment? Why is there no counter proposal from you all of what would work?
So last year when the bill came in, it came in at 15, they did it by percentages, and it was 15%. The 15% did not meet the needs for what I was saying, so we did come in with a counter proposal and said that, and I can't remember what the percentage was at that time, I think it was like around 21%. This time, and that's because of the rate increases we had received when we did the calculations. 15% would meet where we needed to be. They took another turn and they did the actual dollars amount, Any way I come in is going to increase the fiscal note. So we're happy to give you the figure that we would need to keep ourselves whole, but it will increase the fiscal note. It is higher than what is in this bill right now.
Any other questions? Seeing no other questions, I want to thank you for your testimony today. And for colleagues, this will conclude the testimony on House Bill 318. Next, we have House Bill 290, and it's Delegate Bagnall, again, Public Health, Dental Services, Access, and we're jointly assigned with Ways and Means. We have Delegate Wood, Delegate Miller, and Delegate Vogel. Welcome to HGO. And if you have any questions, please let me know. Delegate Bagnall, you can get started, and please call your entire panel. Thank you.
Good afternoon, Madam Chair and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here on behalf of House Bill 290, Dental Services Access. You have my written testimony, so I will summarize. Members of this committee will recall 2 years ago we passed a bill to establish the Oral Health Task Force to study the accessibility of dental health services across Maryland, with a focus on preventative dental health accessibility for people across socioeconomic status, race, ethnicity, age, and disability. The task force published their results of that study on December the 1st of last year and found that while Maryland has a robust support system for those seeking dental health treatment, there still exist disparities in how people of different communities may access that treatment. The Oral Health Task Force, in their final report, made a number of recommendations across a broad spectrum of concerns. Taking a page from our chair, who charged us, those of us working in the behavioral health space, to think strategically and create a multi-year plan of effort, I asked the proponents to prioritize their recommendations and to bear in mind that we passed a significant investment in adult dental care through Medicaid last year, thanks to the hard work of Delegate Cullison and this committee. The proponents identified 4 buckets of priority, focusing on pediatric preventative screenings, workforce expansion, reducing non-medical barriers to care, and better identification and utilization of mobile services. HB 290 establishes a searchable resource for licensed dentists and dental hygienists across the state who provide mobile services and creates a mechanism through the license and renewal process for providers to self-identify as providing mobile care. Mobile services allow providers to travel to locations more accessible to patients, allowing those who could not otherwise travel to dental services the ability to access care. Second, this bill expands eligibility for the Maryland Dent Care Program, a program for higher education loan assistance grants to dental hygienists. Grants to the program are currently only available to dentists and are intended to encourage a broader range of students to pursue dentistry across the state. Expanding this program to provide loan assistance for dental hygienists will increase the amount of hygienists providing care in Maryland, in turn increasing access to the first line of care in dental treatment. Additionally, HB 290 establishes a stakeholders group to look at potential grant programs to also incentivize providers to provide services in underserved communities. Third, this bill requires the Department of Health to create and distribute plain language materials to dental practices across the state, explaining the details of dental procedures and the importance of care. Medical jargon and misunderstandings about treatment can cause individuals to avoid seeking dental care altogether, a practice that's already a little intimidating for many people. Putting that information in terms that the average person can more easily understand will increase willingness to seek treatment across the state. Additionally, this bill establishes a framework for providing dental screening to students through the public school system and prevents citizenship status from disqualifying a person from dental care through the Maryland Medical Assistance Program. These provisions ensure that Maryland's youngest and most vulnerable populations are able to receive proactive and complete care through our state's dental care systems. At a time when dental services are becoming more and more comprehensive across the state, it is also important that we expand access to those necessary services. This bill takes strong strides to provide that accessibility to Marylanders who need it. We've been working with multiple stakeholders to address concerns, especially as concerning the early childhood screenings, as we do not want to create a chilling effect on enrollment. So we will be amending based on the contributions of some of our stakeholders. There are amendments which we provided to change the shall to a may, to move the timeline of implementation, but we also have gotten some recommendations from the Maryland Dental Action Coalition, the Maryland Community Health System, and Policy Justice Center, which will establish a partnership between the Maryland Department of Health and Department of Ed to create educational material in that plain language through the Consumer Health Information Hub, and to establish a study of required reports for dental screenings for children in public schools and child care centers to best determine how to identify populations which would benefit from mobile and in-school services. We also are recommending, regardless of how the committee considers dental reimbursement of community health workers, that we need a study of reimbursement as community health workers provide more than dental services. Another issue which was raised by the department was a concern about the low number of dentists which participate in Medicaid, and the proponents are continuing to meet with the agency to strategize how best to attract dentists to participate, but that does not need to be in statute, and we believe that a delayed implementation date we can increase the number of participating dentists to ensure we have enough participating in the Healthy Smiles program to provide both preventative screenings and follow-up care. But we need to start that education now. We're also working closely with our Senate partners to make sure that we keep both bills aligned. We believe the proposed amendments will address the concerns raised by the department, as well as those raised by the Disability Rights of Maryland, the ARC, and the Maryland Developmental Disabilities Council. Oral health is part of overall health care. Early prevention leads to better overall long-term health outcomes. We've made great strides in oral health expansion, but we need to do more. We need to meet people where they are, and we need to help educate the public on the importance of early screenings. And we need to build a workforce who can meet the growing needs of our pediatric population. For all these reasons, I respectfully request a favorable report on House Bill 290.
Thank you. Have you submitted the amendments to Michelle Berman?
I have submitted some of the amendments, but we're still working, so some are in concept, but I have also spoken with council and sort of.
Yeah, make sure that council has it, okay? Yep. Everyone, it's very important that we don't miss the amendments. Who's next?
I am, Madam Chair. Madam Chair, members of the committee, I'm Dan Doherty. I'm here representing the Maryland State Dental Association. I would initially like to thank Delegate Bagnall not only for sponsoring this bill, but for sponsoring the bill that set up the oral task force and for participating from beginning to end with that task force so she fully understood and had knowledge about what was presented to them and on what they based their findings. Secondly, I want to focus on the screenings and the plain language documentation. As the chair knows, we have been dealing for weeks with crises with children who have very severe acute infections who need to be treated in a hospital operating room setting, and there is no availability. These screenings would start at an age where we can prevent a lot of these children from getting to the stage where they're in that queue trying to get into an operating room. And accompanying that screening with educational materials will give the information the parents need, number one, to how to help the children maintain good dental health, and number two, to help the parents and the children understand the procedures that they're going to be facing at any point in time. We feel this prevention is critical to the long-term care of children and to the overall health of citizens of Maryland. For those reasons alone, I would urge a favorable report.
Thank you. Who's next?
Madam Chair, members of the committee, Charles Doring, General Dentist in Rockville, Maryland. I'm the Legislative Affairs Committee Chair for the Maryland State Dental Association, and I'm also a Medicaid Maryland Healthy Smiles provider, happy to say. And I was also a member of the Oral Health Care Task Force that helped create this document. It has a lot of good in here, and hope you all had a chance to read the task force report. And I want to focus just on a couple things. I do provide portable dental care. I'm on the staff at the Hebrew Home of Greater Washington, so it's a key that we think outside the box and provide care to our citizens who maybe can't come into the traditional dental office, and I teach other dentists how to provide that care as well. I want to address the early childhood exams. Dr. Tate from Children's Hospital will go more into that. But early prevention saves money for the families and the communities. Just in a document from the American Association of Pediatric Dentistry, a child's first dental visit is at 5 years old is nearly 20 times more to have dental decay than if their first visit is at 1. And just to give you an example, a little child, Lana, came into my office last week of Maryland Healthy Smiles at age 5, and she has decay like this on 10 of her teeth. And unfortunately, we didn't see her at age 1 with her parents to educate them on the importance of prevention. Other things to note on this, there are no penalties. People are worried, parents are worried about penalties for not getting these exams. And I just want to state American Association of Pediatric Dentistry's policy is to oppose regulations that would prevent a child from attending school due to non-compliance with the required dental exams. So these exams create an opportunity to have a dialogue with the parents and improve overall health outcomes for the child. So I ask for a favorable report on House Bill 290.
Next, please.
I'd first like to thank the chair and the committee members for the opportunity to speak in favor of House Bill 290. My name is Dr. Anu Tate. I received my master's in public health from Johns Hopkins School of Public Health, and I've been practicing at Children's National in Washington, D.C. for 20 years as a pediatric dentist, where I've really seen firsthand the impact of untreated dental decay, oral infections, avoidable hospital admissions, time away from school for kids, time away from work for parents. One of the most important parts of this bill is the opportunity to have early dental screening. As we've said before, this isn't a punitive thing. This is an opportunity to have a dialogue with the family, to build a relationship, an opportunity to talk about prevention, to have a guided conversation about dietary changes that they can make at home. As a former trustee to the American Academy of Pediatric Dentistry, I have advocated for this age 1 dental visit because it allows me to build trust with my families and give them the information that they need in order to create healthy lives at home. Young children with dental decay on their baby teeth are 3 times more likely to have decay on their permanent teeth. So this prevention is key. You know, we know that we can do a lot better by preventing a problem than trying to treat it. If we prevent the early disease state, we can save adults, young adolescents from having the pain and also the cost of having to manage dental disease. So I love seeing these kids in my practice. I love seeing the parents. They're full of energy and wonderful questions. We want kids to have a pain-free life in an environment where oral health care is really valued, and that parents are armed with the information they need and this knowledge to raise cavity-free kids. So with that, I look forward to a favorable report on House Bill 290. Thank you.
Who's next?
Good afternoon, Madam Chair and committee members. My name is Dr. Alexandra Fitzgerald. I'm a general dentist practicing in Frederick, Maryland, and I also have the privilege of serving as the president-elect of the Maryland State Dental Association. I would like to expand on the provisions to expand the Maryland Dent Care Loan Assistance Repayment Program. To my written testimony, I attached an article from the Journal of the American Dental Association that looked at the correlation and the impact of student debt on postgraduate decisions, whether that be a practice modality. Are you going to go into private practice, a DSO, academia, in a federally qualified health center, general life decisions, having children, buying a house, et cetera, and then participation in dental insurance and Medicaid programs. When I started dental school, I attended the University of Maryland, and I graduated in 2018. So when I started in 2014, in-state tuition was about $15,000 a year. And when I looked at the tuition today, I saw that it had risen by 50%. It's now over $23,000. Looking at the 2019 numbers, the average dental student at the University of Maryland had graduated with $253,000 of student loan debt. For comparison, the medical school was $151,000, so that's over a $100,000 difference for a four-year program. The other four-year program at the school is pharmacy, and I believe that that was about $159,000. The expansion of the Dent Care Loan Assistance Program would uplift dentistry to the same standards that we have for medicine. Currently, medical physicians receive up to $50,000 per year with a 2-year obligation, and the legislation proposed would raise dentistry to $50,000 with a 3-year commitment. Additionally, expanding this program to a hygienist is going to allow our colleagues and attract them to potentially go to areas that they may not be currently attracted to at the moment. For these reasons, I request a favorable report. Thank you.
Excellent timing. May I have Ms. Caitlin McDonough? Will you come up? Can someone please sit in the back? Thank you.
Good afternoon, Madam Chair and members of the committee. Caitlin McDonough with Harris Jones and Malone here in support of House Bill 290. I apologize, I just came from the Senate hearing. And today representing the Maryland Dental Hygienist Association and also Benefits, which is a dental support organization that supports 9 majority Medicaid practices here in the state, primarily on behalf of MDHA, though. We support the broad, multifaceted approach of this bill to create parity between oral health and kind of as a big part of overall health, We're excited to have more opportunities for hygienists in the loan repayment process. And we're also very excited about the potential of increasing our investment in our Medicaid providers. The cost of providing Medicaid dental services has gone up significantly in recent years, but we have seen rate reimbursement lag behind. We did have a small rate increase last year, and that was the first one we'd seen in about a decade. That is essential to not only attracting dentists to serving Medicaid patients, but also for them to be able to have high-quality hygienists serving in and high-quality staff serving in those practices. I think all the elements of this bill work together to increase access, to increase the number of providers going into service and service in the right areas of the state, and also, again, that parity between oral health and overall health. I know there's some amendments out there to kind of correct or to address some of the concerns with the bill. We're happy to work with the committee on any amendments and bring that dental hygiene perspective to the bill. So thank you, and I'm happy to answer any questions.
Thank you. For the committee, are there any questions for the sponsor and her panel? Yes. Can you move up right here? Yes. Thank you.
Thank you, and thank you for bringing this forward. Thank you, Madam Chair, and thank you for the warm welcome. I'm Delegate Miller. For those of you who don't know me, I'm from Ways and Means. I just wanted to know, how does this correlate with the dental and the dental clinic programs and screenings that are prescribed in the blueprint, especially at our community schools, of which, quite a lot of them are going to be named as, particularly with the Medicaid new numbers with the reimbursement numbers, and then the availability of the clinic at the community schools for our early childhood screenings that you talked about. Is that going to be a possibility? So, thank you.
Absolutely. Thank you for the question. I would like to model this after 2 successful programs already existing in the state of Maryland. If we look at Dr. Lucy Passatini's program through Anne Arundel. She's the dental director at Anne Arundel Department of Health. And she, with her crew of dentists and dental hygienists, go to many of the schools in Anne Arundel County. And it is actually a requirement that these kids be screened in Head Start. Another shout out to Sarah Cruz. She's a registered dental hygienist. She works for Chop Tank Community Health Systems, where they also provide screening exams for children and early adolescents. So these are things that I think our Maryland State Dental Association is committed to work with our members, public health dentists, dental directors in each county in Baltimore City to get this done.
I have next Delegate Hutchinson, followed by Delegate Rosenberg.
Thank you, Madam Chair. And Delegate Bagnall, I think it may be Mr. Doring may be the best one to answer this. when I was here in December for our orientation, I remember the Speaker's Chief of Staff saying, get your life in order, go see your doctor, take care of everything. So I thought, I got to do my dental checkup. So on December 5th, I live on the Eastern Shore. I called my dentist, and I got an appointment for September 9th. Do we really have enough dentists that we can cover this throughout the state? And then what would the penalty be to a parent if they weren't able to get the care as provided in the bill?
Do you want to speak for it?
With respect, are there enough dentists? One of the things you will see in the report that the task force issued is there are areas around the state, and unfortunately the lower shore tends to be one of them, where there are shortages of dental providers. And the provisions relating to the dent care incentives of providing relief from tuition costs in return for a 3-year commitment to deal with underserved areas is part of the answer to try and increase that. I'm sorry, what was the second part of your question?
What if a parent can't get
Oh,
the care?
it's not intended to be punitive. The American Association of Pediatric Dentists advocate that no requirement that for screenings in any level of school should have punitive ramifications, whether it's exclusion from attending school or any other kind of penalties. That's one of the issues that's been raised. We are committed with the sponsor and everyone else to try and work with all stakeholders to try and do the wordsmithing to accomplish the intent of the bill with getting a lot of the concerns about the bill clarified.
Delegate Rosenberg.
I'm reading the witness list correctly. We have say 2 pages of individuals who are prepared to testify against the bill. Are you aware of what their concerns are, and have there been any discussions, if you are, to address their concerns?
We're not aware, and we just had the hearing in the Senate, and none of those individuals testified.
Are there any other questions from the, no? Okay. I do have actually a question, Delegate Bagnall. Have you seen the letter from the Maryland Department of Health? I know that some of it, the second paragraph, I understand some of that stuff is coming out through amendments. But what concerns me is the third paragraph. They estimated the bill will require $327 million to implement in FY 2024, with $183.8 million coming from federal funds and $143.2 million from the general funds. But what's interesting is their estimate, and then if you look at the fiscal note, there's a big difference between the fiscal note and between the department. So we know that the truth is somewhere in there in between, right? My grandmother used to say there's always 3 stories, right? So just wanted to flag it. I don't know if you're ready to address that.
Trying to determine what that discrepancy is. We think it might be in the interpretation of the bill, and with the original language of the bill, and that we have actually stripped out a good portion of where the department was seeing that fiscal note.
I'm going to give you some homework. Will you contact the department?
Yep.
Share the amendments that you have, and ask them for a new letter, please.
I will do that. Thank you.
Okay? Thank you. Any questions? Any other questions? All right. Seeing none, I thank you so much.
Thank you, Madam Chair.
So this was the, thank you. Actually, we have 3 more witnesses. This was the sponsor panel. We have a witness favorable with amendment, Robin Elliott. Will you be so kind and come up, please? And then we have 1 virtual witness left. Thank you for your patience. And I know we have 2 more bills left. Those of you that are waiting, we are so grateful for your patience. And we're doing pretty good, actually. It's 3:50. Okay? I can drive this, no? Just kidding. Go ahead. Go ahead.
Good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Dental Action Coalition. I want to start off by thanking Delegate Cullison, Delegate Bagnall, and all the members of HGO. Last year, you all made the biggest difference I've seen in the lives of Marylanders by passing Senate Bill 150, which brought adult dental coverage to 800,000 people who all of a sudden are receiving dental coverage as of the beginning of this year. So we know that the Department of Health has a lot on its plate. They have been great partners, the Medicaid program, in getting adult dental up and running. And we know Delegate Bagnall's been working very hard to figure out how to prioritize the items in the bill. We just wanted to lift up a couple of items in particular of interest. One is the Loan Assistance Repayment Program. You heard about that from the prior panel. We really think this is critical. You all are doing many good initiatives with nursing shortages and others, and we think it is very reasonable to get a focus on the dental provider workforce. We will flag that there's a question or an opportunity to also look at dental assistance. That might not necessarily be in the bill, could be a letter to the existing Workforce Shortage Commission. And just wanted to highlight, we'd like to also think about how to do something to support our safety net provider workforce, the community health centers all across the state that really are an underpinning of our Medicaid program. So with that, thank you very much. And again, thank you for Senate Bill 150 from last year.
Thank you, Robin, and thank you for your advocacy. You helped tremendously in Delegate Collison and others. But we really appreciate your work in this committee. Are there any questions for Ms. Elliott? Okay, seeing none, thank you so much for being with us. We have one last witness, and that is a virtual witness, and is Dean Mark Reynolds from the University of, Mark Reynolds, he's the Dean from the University of Maryland School of Dentistry. And if you just be patient, 1 second. This virtual thing is working out, I think, sometimes. But staff is doing great. Dean Reynolds, will you be so kind and turn off the YouTube and you can start talking?
Good afternoon.
Good afternoon. How are you?
Fine, thank you. I'm a bit with a cold, so I apologize for the raspy voice. Thank you and members of the committee. My name again is Mark Reynolds. I serve as Dean of the University of Maryland School of Dentistry. Over the past year, I served as co-chair of the Task Force on Oral Health in Maryland. I would also like to extend my thanks to Delegate Bagnall for her strong commitment to advancing the oral health of Maryland residents. As co-chair of the task force, I want to extend my strong support of House Bill 290, which aligns closely with the recommendations found in the report. Among the most consequential recommendations proposed by the task force relative to pediatric oral health is the implementation of a statewide mandatory dental screenings for children. Equally aligned components of the bill include increased public education on the importance of oral health for children and adults, addressing Medicaid reimbursable procedures and services, and expanding the Maryland Dent Care Loan Assistance Repayment Program to include dental hygienists. While Maryland has made much progress in the last decade to improve the oral health status of its residents, access to care remains a significant concern. As you've heard, oral health is a critical component of overall health, and sustainable strategies to improve access to oral health care remain an imperative. This bill offers important strides to help improve access to oral health care and reduce the substantial burden of oral infection. Thank you for your consideration.
Thank you for your work for the state of Maryland and for being here today. Are there any questions for the Dean? Seeing none, thank you for being with us. We really appreciate your testimony. This actually concludes the testimony on House Bill 290. I'd like to take a second to just say thank you to the Ways and Means Committee members. We really appreciate it, and you're welcome anytime, okay? Take care. Next, we have House Bill 283, Delegate Kaiser. And will you be so kind and bring your panel with you? It's the Maryland Medical Assistance Program, Gender Affirming Treatment, the Trans Health Equity Act.
Thank you, Madam Chair. I think my sponsor panel is joining me up here. Thank you all.
Yeah, good afternoon, everyone, and happy Valentine's Day.
All right. Thank you, Madam Chair and members of the committee, and thank you for having my sponsor panel up here. It's my pleasure, my honor, really, to be a part of this legislation in advancing House Bill 283, the Maryland Medical Assistance Program, Gender Affirming Treatment, Trans Health, otherwise known as the Trans Health Equity Act. This bill will modernize coverage for dealing with gender dysphoria. I want to thank my sponsor panel and to all of the others, to the nearly 100 people who have signed up in favor or favorable with amendment. I would ask, I know that we have a lot of people testifying today orally, I'd ask them not to repeat, the chair might appreciate, not to repeat everything that others have said, but to speak from the heart on this bill. I just want to briefly describe what this bill will do. It will require Maryland Medicaid to cover an array of gender-affirming treatment in a non-discriminatory way to deal with gender dysphoria. As noted in the fiscal note, I'm talking about medically necessary treatment consistent with current clinical standards of care prescribed by a licensed healthcare provider for the treatment of a condition related to the individual's gender identity. This bill only permits coverage for health care that is medically necessary. As I see my colleagues nodding their heads, I feel the need to repeat, this is only for coverage for treatment that is considered medically necessary. As with the bill last year, this bill is a result of consultation with the Maryland Department of Health, as well as collaboration with medical professionals at Johns Hopkins, MedStar Health, Chase Brexton Healthcare, and many other medical institutions. Based on old standards, Maryland denies coverage for 31 gender-affirming procedures, such as hair, voice, and facial procedures. And by including these, we can improve the standard of care for transgender Marylanders, as so many of our neighboring states have done. I did provide an amendment in the packet that the advocates will explain about shielding, and that will come up later. Madam Chair, I'd like to take this moment as part of my testimony, knowing that people are watching, to wish a happy Valentine's Day to Maryland's transgender community and let them know you are so very loved. What I want you to remember in listening to this hearing today, it's not just me sponsoring this bill. I'm joined by 56 of my colleagues as co-sponsors. More than a dozen other of my colleagues have promised their support, and there's countless other people and organizations providing supportive testimony. What I want you to also do as you listen to all this testimony today is to try to ignore the opposition that will talk about the constitutionality. Our Attorney General has spoken. That's the voice I listen to when it comes to the constitutionality. A lot of my colleagues may say they have trouble with this bill because they want parents involved in treatment. Parents are involved in treatment. So if you say that's important on other bills, it's probably important here too. And worse yet, Madam Chair, and this breaks my heart, and I know it breaks yours as well, some people will make up stories about the people sitting with me and talk about something called grooming. And Madam Chair, those lies say more about them than they do about any of the people supporting this bill today. We in the LGBTQ+ community will rise above, as we always do. Over 15 years ago, it was unimaginable that Maryland voters would be the first in the nation to vote in favor of marriage equality, but they did. Even just 5 years ago, it was unimaginable that the federal government would pass a law that codified marriage equality on the federal level, but it did. And my wife and I, with 2 former colleagues, went down to Washington, D.C. to watch President Biden to sign it into law. I recognize that some people, even some progressive people, still have some discomfort with the idea that a person could be essentially born into the wrong gender and want to take corrective action to change it. No doubt, this is a big, complex issue for transgender people and their families to grapple with, and no one here takes it lightly. If you haven't already, take the opportunity, one-on-one, heart-to-heart, talk with a trans person, and you will then be met with their unmistakable humanity. And then I ask you to vote with your heart and your head. Again, I want to wish a happy Valentine's Day to all transgender individuals in Maryland. And Madam Chair, I urge your support for House Bill 283. Thank you.
My pleasure. Who will be next?
I will, Madam Chair.
How are you?
I'm good. How are you?
Good. Nice seeing you. You can
Good
get
to see you.
started.
Yes. Thank you, Chair Pena-Melnick, Vice Chair Kelly, and members of the committee for the opportunity to express my support for HB 283. And thank you to the 10 co-sponsors that we have here in the room. My name is Sam Williamson. My pronouns are they, them, and I'm a lawyer with Disability Rights Maryland. You may remember this bill from last year when the committee issued a favorable report and when it passed the Senate. This year, we have the support of Maryland's governor and the Department of Health. This bill solves the problem of an outdated Medicaid policy that excludes medically necessary healthcare treatments for gender dysphoria. Several federal courts have found that excluding gender-affirming care violates the Affordable Care Act and federal Medicaid regulations. This bill brings Maryland into compliance by ensuring that Medicaid covers gender-affirming care when that care is medically necessary, prescribed by a licensed healthcare provider, and in accordance with current non-discriminatory medical standards. We do have an amendment to the bill. This is the only substantive change from last year. This will enhance the privacy of our healthcare providers. The bill has a reporting requirement that enables Medicaid participants to know which providers are in network with which managed care organizations. Because of the increased harassment against gender-affirming care providers across the country, we are making that report optional for providers. For all the benefits of providing this necessary health care, it will only cost 1/2 of 0.01% of Maryland's Medicaid budget. All of these procedures are federally reimbursable. We'll also see a huge cost savings. Because we are failing to cover medically necessary care, 39% of transgender individuals have one or more disabilities, as compared to only 15% of the general population. We will save costs by addressing these healthcare needs at the root, rather than through Band-Aid solutions and costly ER visits. This bill makes medical, legal, and fiscal sense, and I urge you to issue a favorable report on HB 283, just as you did last year. Thank you.
Excellent timing, Sam. And thank you for your patience as we work through this, okay? Who's next?
Thank you to the committee for the opportunity to speak today. My name is Dr. Hedian. I am an internal medicine physician who provides primary care at Johns Hopkins. I am here today representing Johns Hopkins University and medicine. A large portion of my panel is transgender or non-binary. I provide gender-affirming care for them, including hormone prescribing. I have met and cared for hundreds of transgender people. You may have noticed that public conversations about transgender people are more common today than they were 10 or 20 years ago. You may have assumed, therefore, that it is a new thing to be transgender. It is not. Transgender and gender-diverse people exist around the world and identify in many different culturally diverse ways, too many to name here. In fact, there are scientifically rigorous international medical guidelines published by WPATH, the World Professional Association for Transgender Health, which healthcare professionals such as myself use to provide medically necessary medical and surgical care. When we refer to the standards of care, this is what we are referencing. And this is what we are seeking to align our healthcare coverage with in the state of Maryland. Not the opinion of this doctor, or even of Johns Hopkins University and medicine, but with the international standards of care. According to the international standards of care, the procedures outlined in this bill are medically necessary procedures. They are not cosmetic, and they are not elective. I have a patient who never speaks in public if she can help it, because the moment she does, some people treat her differently. Even on the elevator, on her way to an appointment to see me, her doctor, she points at the elevator button and does not speak. Her voice is a constant reminder, a constant trigger, and a constant distress. Each person is unique. Not every transgender person will need or use all of the services listed here, but passing this bill will make a dramatic improvement on the lives of people who need and deserve this care, and I urge you to issue a favorable report for HB 283. Thank you for your time.
Thank you for your work. Who's next?
I am.
Thank you, Chair Pena-Melnick. My name is Jamie Grace Alexander, and I work at Free State Justice, which is Maryland's legal and advocacy organization for the LGBT community. I'm also here representing Maryland's Black trans community, and I wanted to start by saying that this healthcare is anything but frivolous and elective. To trans people, gender affirmative care can take precedent to basic needs like food and housing. And the access to gender affirmative care can open the door to opportunities that they might not have otherwise. Currently, many trans people have to fundraise to meet the needs that this bill would cover. That leads to a financial strain on our community as we pass the same $5 around to each other every time somebody needs a gender-affirming procedure. These gender-affirming procedures also open up job access for people who might not otherwise have the confidence or look for the right job to fit them. And I wanted to end my testimony with a story from Tamar Jones at Baltimore Safe Haven. She was suffering from active addiction, experiencing homelessness and incarceration, and forced to do survival sex work to make ends meet. She made contact with Healthcare for the Homeless mobile van, which helped connect her to gender affirmative care. She was able to get on hormone replacement therapy, begin to take care of her diabetes, and eventually access stable housing. She now has a girlfriend, is an active member of the community, and is working to start a nonprofit to help other people who have been where she was. I wouldn't have known about hormone therapy if I wasn't in LGBT spaces. My dream now is to help other trans people and to help everyone I can. Thank you.
Thank you. And can you give me your name again?
Jamie Alexander. I work
Yeah,
at Free State Justice.
Yeah, I don't see your name on the sign-up sheet, but that's okay. I know my,
We spoke with Michelle about changing her out with Tamar Jones.
okay. Okay, great. Just want to make sure for the record that we have it.
Thank you.
Thank you, and thank you for your testimony and your work. Who's next?
I'll go ahead. Thank you, Chair Pena-Melnick, Vice Chair Kelly, members of this committee. We appreciate all of you making the time to hear from us today. My name is Margot Quinlan. My pronouns are she and they. I'm with the Mental Health Association of Maryland. This is a priority bill for us at the Mental Health Association. Your packets have testimony from hundreds of Marylanders in support of this bill. You're going to hear from a lot of us today, experts and doctors, parents who just want what's best for their kids, and members of our community, like myself, who likely would not be with you today were it not for our access to gender-affirming care. You will also hear from a small but vocal group of people who have politicized our healthcare and who will share a number of mistruths about gender-affirming care. I would like to talk through some of their arguments now. First, is this bill discriminatory when non-transgender or cisgender people cannot access these treatments? This is false, and as the delegates mentioned, Attorney General Frosch has already weighed in on this matter. This is not discriminatory, right? The law already recognizes the degree to which gender is important to cisgender people. Anything that's medically necessary for cisgender people is already covered. For example, breast reconstruction after a mastectomy. It is only when talking about transgender people that we see these carve-outs for medical care. Two, don't most people who transition end up regretting it? Again, this is overwhelmingly false. Rates of transition regret are actually extremely rare. Studies show that less than 1% of trans people regret certain medical decisions, less than 1%. Alternatively, other surgeries, like a knee surgery, have a 30% regret rate. Prostate surgery, 20% regret rate. And trans healthcare has less than a 1% regret rate. This is remarkable. Three, this bill would have Maryland doctors operating on children. I want to be clear. This bill does not change Maryland Medicaid's policy for transgender youth. Youth are not given surgeries. Youth care includes puberty blockers, which are safe, effective, and fully reversible, and hormone treatment. All healthcare decisions for transgender youth in Maryland require parental consent. This bill does not change that. Again, this bill does not change that. You will hear testimony from several parents today who credit gender-affirming healthcare with saving their children's lives. I would beg you to listen to their stories. Our care is life-saving, it is medically necessary, and it must be made accessible to all who need it, especially for low-income transgender Marylanders. Our lives depend on it. For these reasons, we urge this committee to vote favorably on this bill. Thank you.
Excellent timing. Who's next?
That would be me.
We'll see if you could beat that.
Okay. It's hard to follow up. So my name is Ashley Black. Good afternoon, Chair, Vice Chair, and members of the committee. I lead the Public Justice Center's Health and Benefits Equity Project. I'm our lead attorney. We strongly support the Trans Health Equity Act, which would essentially modernize Medicaid's gender-affirming care coverage, which the previous administration did not update on its own, despite the relatively small costs to cover transgender beneficiaries. Just to highlight from the fiscal note, we have about 6,000 folks in Medicaid who identify as transgender, and then only 98 sought care in gender-affirming care in 2022. So we're not expecting this bill to open the floodgates. Simply put, this bill would require Medicaid to do three key things. First, to trust the recommendations of medical professionals who are recommending individualized care for their patients as they do for other care. Second, to end the discriminatory practice of holding categorical exclusions for gender-affirming care. And finally, to update our program to modern accepted standards for gender-affirming care. Nationally, we see that transgender adults are more likely to report poorer health outcomes and face greater barriers to accessing care due to the costs compared to their cisgender counterparts. The state's lack of coverage means that the health outcomes experienced by low-income transgender Marylanders who cannot afford to pay out-of-pocket costs for the categorically excluded care will not be the same as those who can, which creates health disparities within the transgender community. Access to individualized gender-affirming care is not only a pathway towards good physical and mental health outcomes for transgender Marylanders, but it's also a pathway towards safety. This bill would make a tremendous difference in the quality of life experience by Maryland's low-income transgender community, and we urge a favorable report. Thank you.
You did great.
Thank you.
Okay? You did great. Anyone else on your sponsor panel? Okay.
No, Madam Chair.
All right, great. We're going to open it up for question for the sponsor panel right now. We're going to start with Delegate Morgan.
Short.
Okay.
I'm respectful of the committee's time. Thank you for presenting the bill. My question was for the doctor on the panel. So you lean into the microphone. Could you take a time and maybe educate the committee on some of the gender affirming care that you've given?
So medically necessary gender affirming medical and surgical care can encompass a lot of different things. Medical care can include hormone therapy, feminizing and masculinizing hormone therapy. There are also an array of different surgeries that might be medically necessary for different patients. But the precise treatment for an individual person depends on who that person is, how they experience dysphoria, and is targeted at alleviating it for that particular person.
So you mentioned hormone therapy. There's no age limit in this bill. So what age are we talking about? When would something like that be started?
So this bill does not change care for minors in the state of Maryland. I would just say that up front. It does not change care for minors in the state of Maryland.
Okay, so when do you perform hormonal therapy for minors?
So that is a very individualized decision. And the primary people who are part of that decision are the patient, the parents, the healthcare professionals, and behavioral health specialists or mental health specialists who follow the international standards of care in making those decisions. I'm sorry, I'm not sure what you're asking.
Delegate Morgan, can you please get closer to the, okay, thank you.
Can you give me an example of some of the medication prescribed?
So for masculinizing therapy, testosterone is used. For feminizing therapy, estrogen can be used. That can be given in combination with androgen blockade or testosterone blockade, which can be given, accomplished through spironolactone or Lupron. Depending if we're talking about care for minors, which I think is what your question references, which again is not pertinent to this bill, but to sort of educate about care for minors generally. Depending on the pubertal stage, puberty blockers might be appropriate, followed by when it is developmentally appropriate, and in coordination with the whole care team, feminizing or masculinizing hormone therapy.
Gender affirming care, like you mentioned, have you ever prescribed, like for example, testosterone to a biological male? Have you ever confirmed gender to their natural gender?
So when you say biological male, I think what you're referring to is somebody who was assigned male at birth, who identifies as male, right, a cisgender male. Gender is a complicated subject. It is probably in part a biological process, and so referring to someone who's cisgender male as biological male is sort of glosses over that.
Yeah.
So your question is, have I ever prescribed testosterone, gender-affirming testosterone, to a cisgender
As an
male?
example, you talked about drugs that we're talking about more female hormone-producing drugs in your last answer. Have you ever prescribed them to female patients or vice versa for male patients?
In the appropriate medical context, a cisgender male who has hypogonadism, so their body does not produce enough testosterone, it might be appropriate for them to take testosterone. Again, in the appropriate context, a cisgender female who has gone through menopause and has significant symptoms can be prescribed feminizing hormone therapy.
But you've never prescribed.
I have. Yes.
So how long does it take for the effects of hormone blockers and puberty blockers to take effect?
That's a more complex question than maybe you realize. It depends on the dosing, it depends on the age of the patient, it depends on a lot of other factors.
Are we talking months or years? Or weeks?
Delegate Morgan, this will be your last question, and we'll allow others to ask questions, and maybe if your questions are not asked, 1 second, if your questions are not asked, then I will let you ask more questions, okay? Just to be fair to the others, and usually, just for everyone here involved, I usually only allow 1 question, maybe 2, but I think that we need to have a discussion and a sort of an education, and I'm allowing it. So this will be 1 question.
So you said that hormone blockers were reversible. If you put somebody, like, how long do they take to take effect? And if somebody got off of them, how long would it take for them to return back to their normal state?
Yeah, again, normal sort of grounds the cisgender. It's a longer conversation.
All right. Thank you. Next, my pleasure. We have Delegate Lewis, followed by Delegate Shalega. And again, if you have more than 1 question, maybe you want to wait and allow someone else an opportunity and see if your question has been asked. Then I'll come back, okay?
Thank you, Madam Chair. Thank you, Delegate Kaiser, for bringing this bill again this year. And thanks to all your panelists and folks who are courageous enough to share their stories. My question is this, just to make it clear for me, does this bill allow any medical treatment that's not considered medically necessary? And who? Delegate Kaiser.
And for the committee and for the witnesses, 1 person gets to answer. From the committee, try not to answer the questions, please. Okay, thank you.
I can answer, Delegate Lewis. It's a great question. No, this does not allow any care that is not deemed medically necessary by medical professionals, behavioral health specialists. None of this care is experimental. None of this care is particularly new. It is care that's being offered, as Delegate Morgan eloquently asked, for cisgender children who might go through precocious puberty. We'll take puberty blockers. These aren't new medications. And these are decisions that are made with family and with the care team and the medical experts. And hopefully not, the folks sitting at the Department of Health. So we appreciate that question, yeah.
My pleasure. Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here. My questions are for the physician as well. Dr. Hedian, is that correct?
Kedian.
Kedian, I'm sorry. So Delegate Morgan asked a question. I don't think he finally got to the answer. So tell us how young the youngest patient is that you've seen that you've prescribed puberty blockers for.
So puberty blockers are only prescribed for patients who, again, when it's medically appropriate, are at the onset of puberty. So for that age varies, but could range between 9 and 13.
So 9's the youngest that you 9's the youngest that you've prescribed, or have you prescribed younger?
So in my personal practice, I'm an internal medicine physician, so my license limits me to treating patients who are 18 and older. However, I work in close consultation with adolescent medicine and pediatric providers who do offer gender-affirming care for minors at Johns Hopkins and have developed multiple educational modules to train doctors on how to do this. So I'm familiar with it, but in terms of my professional license, I care for 18 and up.
And I have read a number of publications that say that puberty blockers can be non-reversible. I mean, I saw a report, a testimony by a man who was put on puberty blockers at a young age, and his penis never developed. And so there are other reports of, actual evidence. So would you verify or deny that puberty blockers, I mean, was that man lying?
So when someone takes puberty blockers, it essentially puts a pause on the body's own progression of puberty. Assuming that they don't have an underlying hormonal disorder, if they were to stop taking puberty blockers, then the body's own puberty would assert itself. I'm not familiar with the case that you referenced, so that's hard for me to speak to that particular case.
Thank you. And there was more than one, but my last question, Madam Chair, and thank you for the liberty of more than one question. I've also looked at WPATH's information, and I see that it's here on, in the bill on page 4 at the top, and the gender-affirming treatments that the bill suggests following are published by the World Professional Association for Transgender Health. Yet there's quite a bit of controversy over WPATH recently, with lawsuit from someone in the UK. Finland's broken with WPATH, advising for psychotherapy, not puberty blockers. Sweden's cut ties with WPATH, the growing pressure the Dutch have as well. What can you tell us about this, it seems like, controversial organization named in the bill by European nations that have been doing gender-affirming care for, longer than we have here in the States? That would be for anybody on the panel. So Delegate Kaiser, whoever.
Who's the best person to answer the question?
Every major medical organization is in agreement with WPATH guidelines. I think that speaks for itself.
Thank you. Delegate Hill.
Thank you, Madam Chair. I guess as doctor, you've been doing such a great job. Thank you for being here. I just got so confused. I just want to make sure I understand what this bill does. My understanding is this bill would allow people on public assistance to get coverage for medically indicated procedures and treatments that many, if not most, private health insurances provide. Is that correct?
Yes.
Oh, thank you. Okay.
Okay. Next, we have Delegate Chisholm, followed by Delegate Kelly, followed by Delegate Bagnall.
My question was asked by Delegate Schlegel, but maybe I can get confirmation, but I don't believe the doctor is able to answer. Back to the puberty blockers, is there any study that shows that it can, if you decide you want to reverse, that you can make 100% reversal? And I know you said it's very complex, but it seems to me when you stop puberty from happening, the human body is a very complex, amazing thing. Do we know that if somebody decides this was not what I expected, this is not what I wanted, can you go back to 100% of whatever your biological birth gender was? And is there studies to confirm that?
Delegate Chisholm, I'll have the doctor send you that information. I want to answer this question to say that this bill has nothing to do with puberty blockers for minors, and this bill does nothing to change care for minors. So it's outside the scope of this bill, but I believe Our doctor can, and we have the other medical experts who can provide the answer to your question.
Asked to define hormone therapy, puberty blockers was brought up. So maybe I misunderstood what.
I'm just saying that the care for minors is unchanged by this bill, and I'm just making sure that you understand that nothing in this bill changes the care for minors. So take a look.
All right. Delegate Kelly.
Thank you, Madam Chairman. And I think mine is a follow-up question to Delegate Hills, but it may get at a little bit at what Delegate Chisholm was asking, and I would like to direct it to Margot, because what I'm thinking about this as, you know, through the lens of the parent of a 15-year-old. Sorry, I'm going to cry when I think about it, because I think every parent of a teenager is terrified to think of self-harm and suicidal thoughts. I have friends who have gone through this situation with their children, and this committee cares deeply about preventing suicide, and particularly youth suicide. So, you know, I think about my 15-year-old child, and I think about my trans niece, and I think about the care that my trans niece is able to get in the private healthcare system. And the parent, my trans niece's parent, made a decision using their parental judgment to make sure to get the care that they felt their child needed for their child's health, and it was medically indicated, and it had positive impact on their mental health. So my question is, following up on Delegate Hill's question, if I'm a parent who has coverage through Medicaid, and my child has coverage through Medicaid, does this legislation fix an inequity that would allow me as a parent to fulfill my child's medically indicated needs and hopefully protect their mental health?
Thank you, Vice Chair Kelly, and thank you for sharing so personally. And just to quickly note from the Mental Health Association, that's why we're in such strong support of this, because 1 in 2 transgender youth have suicidal ideation, and that's not because of any mental health outcomes that live within our brains or our bodies. It's because of minority stress, which is a well-documented, well-researched experience of phenomena of discrimination, harassment, and abuse in medical settings, on the street, and otherwise. And so, no, this bill, all this bill does is codify current practices that are already happening. We're not making up new medical care here. This care is being offered in offices all across the country, all across the world. It is not new and it's not experimental. And so this codifies things, but this doesn't change things. And yes, this would, you know, for those on private insurance who are able to take, you know, might be more affluent and have some stability, are able to take care of their, you know, trans adolescents and keep them alive, keep them here with us, so they can grow into the next generation, which is what we want to see. For a lot of low-income Marylanders, their parents make hard decisions and they can't get that access. And so, you know, this just brings equity. This brings equity where there is not some already. And it's life-saving. So thank you for sharing. Yeah.
Delegate Bagnall, followed by Delegate Hill.
Thank you, Madam Chair, and thank you to the sponsor of the bill and the panel. I know we're having a broader conversation about transgender equity and transgender healthcare, but I want to make sure I'm bringing it back to the bill so I understand this. Whoever is best equipped to answer this question, can you speak to how this healthcare treats gender dysphoria?
Who's the person best to answer this question?
Thank you for that question. So it might be helpful to review a definition of gender dysphoria. Gender dysphoria requires 2 components. First of all, there must be a mismatch between one's gender identities, or their internal sense of self, and how they fit into the world from the perspective of gender, and their assigned sex at birth. That incongruence also needs to be accompanied by distress. Distress is a word that we throw around a lot in common parlance, but this is not sort of simple unhappiness. This is life-altering distress, which has been referenced on this panel, can cause many people to contemplate suicide. I have seen this manifest in many of my patients over time. I have seen a patient who came to me in her 30s, who had been chronically suicidal for her entire life, who finally said, I think I need to do this. I think I need to start hormone therapy. And I saw her a month later, and she said, I don't want to kill myself. And that's the first time I've been able to say that in 35 years. And she's enrolled in graduate school and doing really well. This is not unhappiness. This is severe. This is a medical diagnosis for which there are medical treatments guided by international standards of care.
I am going to go to Delegate Rosenberg only because Delegate Hill, you already had a bite. I'm going to come back to those that had a bite for second one, but let me go to the first ones, okay? Delegate Rosenberg,
Thank you,
followed by
Madam.
Delegate Collison.
Thank you, Madam Chair.
My pleasure.
A fundamental premise of our healthcare system in Maryland is that when you go to the hospital, it doesn't matter whether you're insured, uninsured, social, Medicare, Medicaid. Wouldn't this bill provide, consistent with that premise, that an individual who sought medical care, whether the reimbursement would be from insurance or from Medicaid, would receive the same treatment? Isn't that what this bill would do?
So this bill is, sorry for awkwardly standing, really only about Maryland's Medicaid program. It ensures that Maryland's Medicaid program operates in a non-discriminatory way and doesn't violate the Affordable Care Act's non-discrimination provisions. And it ensures that Maryland Medicaid would cover gender-affirming treatment, the full scope. But Maryland Medicaid does cover some gender-affirming treatment, it just doesn't cover the full scope. Does that answer your question?
Would the treatments covered under the bill also be covered under private insurance in Maryland?
Yes, absolutely. Most private insurers do cover much more comprehensively than Maryland Medicaid covers gender-affirming treatment. And we've looked at Blue Cross, we've looked at Aetna, and other Maryland insurers who do cover gender-affirming treatment more comprehensively than Maryland Medicaid does.
If this bill were enacted in its current form, how would the coverage compare to that provided by private insurers?
I believe that a lot of those private insurers would be comparable to what this bill would cover. There is not, because private insurers have such a range of different plans available through different employers. We don't have a fully comprehensive study to provide you. I wish we did, but it would be comparable.
Thank you.
Delegate Collison, followed by Delegate Hill.
Thank you, Madam Chair, and I think this question is for Margot. Why is this population that we're speaking about or speaking to with this bill, why is it so vulnerable, or what is the best benefit that can come out of this bill for that population?
Sure, thank you for that question. So, as has already been mentioned, to some extent, our community faces really disparately high rates of suicidal ideation, of disparate mental health outcomes. A lot of this is fueled from our lack of access to health care. As Jamie Grace sort of mentioned, we're forced to sort of fundraise and just support one another to sort of access the care that we need. There's a lot of sort of risks and harms in that. And then that also sort of fuels the discrimination that we face in, housing and employment, on the streets, right? And a lot of that, there are studies that show too that sort of public perception has had a huge impact. And the public perception of lawmakers across the country, as they've asked some of the questions that we're hearing asked today, has a huge deleterious impact on the mental well-being of trans youth. And so it's, again, the results of the stigma and harassment and bias. And for some transgender people too, access to this care gives us an increased access into society, right? And so it removes some of the stigmas. It allows us to move freely about the world without some of the mental health struggles that, Dr. Heating isn't my doctor, but she could have been talking about me as far as my ability to stop dealing with suicidal ideation as an adult, right, with access to gender-affirming care. It allows us to live and thrive and be robust members of society again. And so that is in large part, what removing these barriers to access to our healthcare allows us to thrive in society. And that's helps to reduce these disparities that we do pay for. Maryland does pay for, our ER visits and our hospitalizations, our funerals. And so this would help offset those costs significantly.
Delegate Riley.
Thank you, Madam Chair. Yes, just to I guess settle some confusion going around, because I've heard talk about teens, adolescents, the puberty blockers, and and the panel keeps saying, well, this isn't for minors. It doesn't change anything. This is for the adult. Just under current law, okay, just remind us what the age is currently for someone to go visit Dr. Heedy with and without parental consent. So when can a adolescent come to your office and under current law, just so that we get an idea, because this bill doesn't have an age in it. So just to clarify what age bracket we're talking about that can go to the doctor to, get this treatment. Currently, under law, what is the age with parental consent and what is the age that they can go without parental consent?
Who's the best person to answer that question?
I think I could take it.
Thank you.
There's no age restriction on going to your doctor. Gender-affirming care is not something that is only necessarily provided in specialty clinics. And this bill talks about medical and surgical gender-affirming care, but gender-affirming care, especially for youth, extends much beyond that. It involves offering the patient and the family mental health support. It talks about, it connects children with children of other families who are, and parents of other families who have children who are transgender and gender diverse. It can facilitate social transition, which really just involves using a different name and pronouns, but can have a dramatic impact in the mental health of that child. Having one single supportive adult in the life of a transgender child dramatically reduces their risk of suicidality by 40%. And I think what you're asking is, at what age can children access medical care? And there is no law legislating when children can access medical care, to my knowledge.
So,
Sure.
to follow up, then you're saying this bill, my daughter, say she's age of 12, so she can talk to maybe another parent or have a friend, and she can make an appointment and go see you, and you can actually treat her for this particular medical diagnosis that you treat patients for.
Because of my licensing restrictions, I treat patients who are 18 and up. But as I mentioned before, I collaborate closely with pediatric and adolescent providers at Johns Hopkins.
My pleasure. Now we're going to a second round, and we're going to start with Delegate Hill, who has been patient. Thank you very much, followed by Delegate Chisholm. Thank you so much.
Follow up with you. So my understanding is that when treatment options are offered, whether it's for this diagnosis, this population, or as a general rule, one of the professional requirements is that the risk, the benefits, the alternatives, the duration, whether something's going to be reversible or not reversible, what the cost could be, downside limitations, expectations are discussed with the patient, if it's a minor, with the patient's family, and that they then get to ask some of the questions that have been asked of this panel about what they've read, and if what they read is true, and if somebody's bad experience is likely to be their bad experience, or if somebody's good experience is likely to be their good experience. And then they can go in a back and forth with the doctor. They can come for a second visit. They can look for resources. But as a private medical situation, and with respecting the family autonomy, parental rights, patient rights, the judgments, they then get to take all that information in without government interference or interference from anybody else, and make a decision about whether it is the correct treatment. And they can sometimes say, maybe not now, let's try some other stuff. Am I wrong about that, or is that about right?
That's a very good summary.
All right, thank you.
Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
For a point of clarification, when we were talking about puberty blockers earlier, you said it's not in the bill, or if it's not pertaining to minors, but it is in the bill. It's on page 3, under gender-affirming treatments, line 7, hormone therapy, hormone blockers, and puberty blockers. And when we're talking about puberty blockers, it's just assumed that we're talking about minors because typically by the time you get out of 17, 18, you're no longer in puberty. But it is in the bill, so I don't know if you misunderstood what I was saying or...
Sure. So Delegate, I think it's a fair question just to better understand what this bill is doing. This bill isn't sort of creating new pathways for treatment. It's not allowing a 12-year-old and her friend to go access treatment without a parental consent, right? What this bill is doing is codifying practices that are already happening, that have been happening for decades, right? Puberty blockers, again, are not a new medication. They're not specific to transgender children. There are many cisgender children who use puberty blockers to help delay their puberty, and so when that's needed, right, when it's medically necessary. And so this is just codifying Medicaid policy to bring it into standard in with what is being done, with private insurance plans. So this isn't, I think it sounds like there's maybe some confusion that this is suddenly authorizing the underage treatment of children. These things are already, puberty blockers are already being given, and they are reversible, and there's a lot of research that can show that these are safe and effective interventions to help protect kids.
Medicaid, is that fair?
We're bringing Medicaid into alignment with what the feds are asking us to do and have pressured a lot of states to do, and we're bringing it into alignment with what needs to be done. It's for a lot of reasons, it's the right thing to do when low-income folks can't afford these treatments, these life-saving treatments, but wealthy people can. This is bringing us into that that alignment. Yes. Mm-hmm.
My pleasure. We have Delegate Woods, followed by Delegate Shalega.
Yes, thank you, Madam Speaker. My question is, does this bill open an opportunity to...
Madam Chair.
What did I say?
Yeah, I do not want the speaker's job. I'm very supportive of the speaker. Go ahead.
You've been speaking so much today, I just got a little off balance here. My apologies. Thank you, Madam Chair.
Thank you.
Thank you all for your presentation. My question is, does this bill open an opportunity to centralize care, particularly for the individual who may be in need, specific to the needs of the individual? Does that make sense?
Who's the best person?
To center the individual's care, if you will.
Sam?
Yes, so one of the major points of this bill, I think we hammered it better last year than we did this year, is that it allows medical care to be individualized. That's the point of this bill, is so that there's not going to be a categorical exclusion that says you can never get coverage for these set of procedures, but if it's medically necessary for an individual, that individual can get it so long as it's prescribed in accordance with the standards of care. It also, in terms of centralizing, there are, I'm thinking in particular of a surgeon who accepts Medicaid in Maryland and can perform some of the procedures that are currently covered by Maryland Medicaid. It would allow him to accept Medicaid for these other procedures, and then people could stick with the surgeon that they know and trust. So it would allow for some centralization in that way.
Delegate Shalega.
Thank you, Madam Chair.
Thank you.
Second bite at the apple here. So there's been, I think, some confusion. So this bill does apply to children because children get Medicaid. And so when you look at page 3, and the concerns of myself and many of us are that there are mastectomies being done on children. That's line 13. There are genital and gonad operations being done on minors. That's line 16. There are hormone therapy. These treatments that are in here are being done on minors, and there are states in this country that are passing laws right now that prohibit minors from having these treatments that sterilize them. So would you be the sponsor of the bill to put a limitation on here that would say minors under 18 may not have surgeries that would alter their body forever? Thank you.
Thank you, Delegate. I appreciate the question. Minors are not allowed to get surgery now, but I think to also answer your broader question, if we were not to pass this bill this year, the other procedures that you're concerned about related to puberty blockers and so forth are already happening and will continue to happen? But again, there's no need to put that amendment in here because there's nothing in here that allows those surgeries.
I think they may be being done at Hopkins. Perhaps I'll send a letter and ask. Thank you.
Well, I haven't heard that rumor, but I just know that the law doesn't allow it now, nor would this bill.
Thank you. And again, I'm allowing these questions, right? So that we can have an honest, respectful discussion. But this bill will be in subcommittee, and at that point, we will bring some other people to address some of these, like an adolescent doctor, right? To be able to address some of these issues as well. We have next Delegate Collison.
Thank you, Madam Chair, for that second bite. So I just, because I liked hearing the sponsor say it, but also maybe the doctor can respond. Anything that is done under the guidance or under the provisions of this bill must be medically necessary, even if it's in consultation with a parent around something that their child or their guardian, whomever they're the guardian for, and their medical provider has made a decision about. Is that, and made a decision that it is medically necessary. Is that right, Doctor?
So, if I could, that is correct. That is correct that adolescent treatment does require parental consent, that all of these treatments require to be medically necessary. A lot of them require, trans individuals to go through psychological evaluations. Some of them require us to see multiple psychiatrists in order to get multiple letters to approve these procedures. And so it is not just happening sort of fast and loose. And I think it sounds like there's a little bit of misunderstanding too about sort of the structure of the bill and the categories where it lists on page 3, where, a lot of your colleagues are referencing, there's not a subcategory of all of those surgeries are, under adolescent care. Those are individual bullets. And so hormone therapy, hormone blockers, and puberty blockers, all of those are prescribed, on a case-by-case basis. And Dr. Hedian could talk about that, but these are not like sort of lumps, buckets of care. These are all done in consultation with multiple providers and care teams. And again, the individual centers our autonomy and decision-making ability as individuals. Mm-hmm.
Any other questions from the committee? Delegate Gazzoni.
Thank you.
My pleasure.
So I just want to loop back around to make sure I got some solid clarity on a couple of the big things that have been talked about. This is not changing any sort of medical practices that are not already in place. It opens to patients covered by Medicaid services that are not currently able for them to be able to be accessing from financial issues.
Can you please give the answer? Ask one question and then please give the answer for the record.
I'm sorry, what is the question?
I just want to make sure, I got one other thing and then I'm done with my things. And that parental consent is required for any treatment of children that are underage.
That's correct.
Thanks.
Yeah.
That was the question. Thank you.
Just wanted to clarify those 3 big points. Thank you very much.
Thank you.
Delegate Morgan.
Thank you, Madam Chair. Just for clarification on this bill, while this bill may not be changing what is currently medically practiced by some providers, it is now opening up to that, and that practice may be disagreed upon by some members of this committee, including myself. But what this bill does is opening it up to a whole nother section of our public that is currently covered by Medicaid, and which is taxpayer funded. Isn't that so?
I appreciate your question, Delegate Morgan, and I think the poor people in Maryland deserve the same treatment that you and I have from our private insurance. So thank you for that question.
How many people are we actually talking about on Medicaid?
2,000. Transgender Marylanders. This is well under 0.1% of the full Medicaid budget, but to answer your original question, just that clarification, yes, we would be providing something to those on Medicaid that others already have.
So just for clarification, in the state of Maryland, there's 1.8 million people on Medicaid. However, if you look at the fiscal note, page 4, it actually states that there, in Maryland, there were 24,000 transgender adults in 2022 in Maryland. An estimated 6,000 of these adults are enrolled in Medicaid. It says the number of non-binary, intersex, two-spirited, and other gender-diverse individuals enrolled in Medicaid is not currently available. In calendar 2022, 98 individuals received gender-affirming treatment through Medicaid, 98. And then it also says that the bill is estimated to increase by approximately only 25 individuals per year. That's page 4 of the fiscal note. Why? Well, we get your point. It's debatable. It's a very small number. 98 only received treatment. It will only increase it by 25 people. Delegate Bagnall.
Chair, thank you for the second bite of the apple. Just want to make sure that I'm clear about what this bill does not do, because we are Health and Government Occupations. This does not change scope of practice. It does not change the health occupations licensure or the oversight within our health occupations. Is that correct?
That is correct, Delegate.
We're only talking about the insurance reimbursement. Yes. Thank you, Madam Chair.
Delegate Hutchinson.
Thank you, Madam Chair.
My pleasure.
There's obviously been a lot of moving parts here today, and I'm just trying to get understanding too. Perhaps Delegate Gazzoni just asked this, but I just want to make sure when I leave here. So any of the gender-altering, gender-affirming care procedures to a minor up to 18 would have to have parental consent. Is that correct?
Yes.
Okay.
That's not changed by the bill.
And then one more question. Is there ever a time that a breast implant is deemed medically necessary?
Based on the nodding head of the plastic surgeon sitting next to you, yes.
In terms of gender-affirming care, under that context, that is deemed medically necessary.
She has her time.
I would yes to that as well. If the gender dysphoria has been determined by a medical professional and it's been deemed as medically necessary, then yes.
Thank you.
And isn't it, anyone else for questions before? I usually let you all ask your questions, and then I sometimes ask a question. So I do have a question. And this will be for, I would say, the sponsor of the bill. You know, isn't it right to say that Medicaid funding is not a zero-sum game? If you need the care, you have to get the care, correct? Just like any other insurance.
That's who I want to be and who I think a lot of us want to be as a state, to support people in the state who don't have the means but have the need.
And just because if we were to offer this service, right, it doesn't mean that we have less money for other Medicaid services, correct? Okay, thank you. I want to thank the committee for having a respectful discussion and for your questions. I think it's important to ask the questions that you have in a respectful manner, and you've done it, and I'm very proud of our work. We do have a lot more people, so we're going to call another panel, but we are done with this panel that was the sponsor panel. I want to thank the sponsor panel for being patient and as we ask the questions. We don't usually allow that in the committee. I know you are, it's a lot of work and a stress regardless of where you are on the issue, to come up here and testify whether you support it or not. So let's not do that. But I do appreciate your time and your efforts. Next, we have Lily Pastor. Actually, I have Tamar Jones first. Tamar Jones from the Baltimore Safe Haven. Okay, thank you. And then we have Lily Pastor. Will you be so kind and come up? And I'm going to call Stacy Jefferson, Erica McDonald, Lee Binder, and Michelle Siri. Will you please come up? Lily Pastor, Stacy Jefferson, Erica McDonald, Lee Binder, and Michelle Siri. Just bring a chair up. And will you please get started? Tell us your name and why are you supporting the bill? And for the committee, this is still a panel of favorable. Good afternoon, and thank you for your patience, everyone. Go ahead.
Thank you very much, Madam Chair. Thank you,
pleasure.
members of the committee. My name is Lily Amara Pastor. I'm a nursing student at Anne Arundel Community College, and I'm a 36-year-old trans woman. I'll just very briefly say that I can speak as someone who's had a drastic change in her life due to access to gender-affirming care. I'm personally thriving and having a wonderful time as a student nurse at one of our state's top nursing programs, and I hope to, when I graduate, serve the state as a nurse. And that's all. Thank you very much.
Thank you for being willing to serve. We have a nurse shortage, so thank you for being willing to serve.
Oh, I know.
Who's
The
next?
state of Maryland is going to be paying for a bunch of my education because of that nurse shortage.
That's okay. We will gladly do it if you service our people in Maryland. Go ahead.
Good evening, Madam Chair and members of the committee. My name is Stacy Jefferson, and I'm the Director of Policy and Stakeholder Engagement with the Behavioral Health System Baltimore. We're a local nonprofit organization that oversees the mental health and substance use services for Baltimore City. And I am here today in proud support of House Bill 283. And I just want to reiterate a couple of points. Research shows that access to gender-affirming medical care is linked to better mental health outcomes. As in my written testimony, I referenced a 2020 study of transgender adults 18 and older, found access to gender-affirming care was associated with a lower risk of suicidality. Our current policies really create barriers to accessing adequate medical care for our transgender Marylanders, and everyone deserves access to health care. I think we can all agree on that. Without adequate care, they're exposed to discrimination, harassment, and violence that also often leads to negative behavioral health outcomes and triggers stress responses. And this toxic stress has a negative impact on both physical and mental health. And so BHSB asked the committee for a favorable report on House Bill 283 because we must continue to protect our most vulnerable Marylanders at such a small cost. And thank you for having me today.
Thank you for being here. Next, please.
Good afternoon, Chair Pena-Melnick and committee members. My name is Erica McDonald, and I'm a resident of Baltimore County. I'm testifying in support of the Trans Health Equity Act on behalf of the League of Women Voters of Maryland, representing concerned citizens throughout the state. The League is a nonpartisan organization that advocates for the health and safety of all Americans, which is necessary for a functioning democracy. I'm also here today because I've seen firsthand the difference that gender-affirming care makes. My son, who was assigned female at birth, had clear gender nonconforming preferences at age 2. When he came out to us at 12 years old, he had become withdrawn and depressed, and we fully supported his transition, changing his appearance, name, and pronouns, but we did not understand at the time the importance of gender-affirming medical care. And as a teen, his gender dysphoria increased. He had suicidal ideation, self-harm, weight loss, and crippling anxiety so bad that we had to homeschool him for a period of time. We eventually educated ourselves, found a knowledgeable therapist and gender-affirming medical care, and at 17, he began hormone therapy. At 18, he had gender-affirming surgery, which had a profoundly positive effect on his well-being. I cannot stress enough that access to this gender-affirming medication and surgery saved his life. And I have no doubt that without this care, he would not be well or able to prosper. He's now healing, he sees his friends, he engages with our family, he's started college this year. So it really changed his life. My family is fortunate to have private health insurance, and that covered his care. But transgender Marylands with Medicaid do not have the same access to care we do. And Black transgender Marylanders who are disproportionately impacted by violence and homelessness especially need this life-saving care. I urge you on behalf of my family and the League to support HB 283. Thank you for your time.
Thank you for sharing your personal story. We really appreciate it. We have Lee Blinder, sorry.
Thank you so much, Chair Pena-Melnick, and the esteemed committee members. My name is Lee Blinder. I use they, them pronouns, and I'm a very proud non-binary transgender Marylander. I'm also the executive director of Trans Maryland, and in addition, I'm also a commissioner with the Maryland Commission on LGBTQ Affairs. In those capacities, I'm here in strong support of HB 283. Trans Maryland is a multiracial, multigender community power building organization for Maryland's trans communities. We have the state's largest name and gender marker change program, and we also run the state's largest peer-to-peer support system. Through this capacity and through this work, we've talked to thousands of trans Marylanders, and this bill came out of those conversations. This bill is absolutely necessary in order to close this gap that we have between folks who have private insurance and then folks who are low income. This is essential life-saving care that is medically necessary and deeply needed. I'll note we're the only service provider who is working exclusively with transgender clients, who serves the whole state and also is run by and led by transgender Marylanders. There's no one better positioned than us to illuminate the need to expand these services. On a daily basis, I hear from transgender Marylanders who need access to this care. I also talk to transgender Marylanders who have paid insurance and can access this care. And I see the strong disparity and the difference between those communities. Our low-income Marylanders deserve access to this care. Modernizing gender transition and care through Maryland Medicaid is a very easy fix to pass the Trans Health Equity Act. And I strongly support, and strongly encourage the committee's support for SB 283, or HB 283, excuse me. Thank you.
Excellent time. Michelle, see if you can beat that.
I think I can, Madam Chair. I think I can. Good afternoon. My name is Michelle Seary. I'm the Executive Director of the Women's Law Center of Maryland. For over 50 years, the Women's Law Center's mission has been to ensure the physical safety, the economic security, and the bodily autonomy of women in Maryland. And when I say women, I include trans women, because trans women are women. And women, all women, have historically, and to this day presently, been forced to fight for equality in all areas of our lives. We are burdened by employment discrimination and a gender pay gap. We are disproportionately at risk for intimate partner violence and sexual assault. And we suffer disparities in health outcomes from a medical system that minimizes women's health and ignores a lot of those issues. But for our trans sisters, each of those challenges is significantly more acute, and even more so for low-income trans Marylanders. So HB 283 is just a small step towards addressing those inequities, and that is why I'm here to state unequivocally that this is a women's rights issue and that we urge a favorable report on HB 283. Thank you.
Thank you. Appreciate it. Are there any questions for this panel? Seeing none, I do have a question, only if you feel comfortable, Ms. McDonald. And thank you for sharing your story earlier. If you feel comfortable only, you don't have to answer.
I'll see what the question is.
Can you walk this committee through what was the process like for you?
The process
with your child of going to the doctor and all of that.
Well, it began by us supporting my son's desire to change his appearance and his name and his pronouns. And when that started, he also agreed that he'd like to talk to a therapist. And we did that for about 10 years, off and on. We had trouble finding therapists that were supportive and that were not judgmental and didn't make the situation worse, which was really hard on the family. We eventually found a therapist who was able to talk to us about the options for medical-supported gender-affirming care, which we had not been apprised of by his pediatrician, which was, it was difficult for us to deal with that and to find someone to care for him that we felt we could trust. And we, both my husband and I have master's degrees and we're information scientists. So we both did a ton of research into what the medical care was and the research was, and realized that there was more that we could be doing for him. And so we sought out care, which included a number of years of gender-affirming therapy that led to hormone therapy for him, which was over a year of that before he was able to have a double mastectomy. And he's had that about 7 months ago and is recovering and is started college and is, it's not overnight. It's going to take a while for him to recover from the years and years of depression and, suicidal thoughts. But he's doing it and he's re-engaged, so.
Thank you for sharing your story. We really appreciate it, okay?
Did that answer your question?
Yes,
Okay.
we did. It's not something that you decide to do tomorrow. It's something that takes a while and a lot of discussion and thought and reflection.
And when you see your child unable to get out of bed or having to be restrained at school because they're so anxiety, ridden, unable to eat, you, as a parent, you do what you need to do to support them.
Thank you.
100%.
I see no other question. Thank you for your time. The committee really appreciates you. And everyone else that is still waiting, thank you for being patient, okay? We're going to go on to the following panel. And I know the committee, we're just working through it. You can get some refreshments in the back, okay? Delegate Kaiser provided some food for you because she's the culprit, right? Anyway, so that's what we do in this committee. If you have a bill that, will require a long time, you have to provide food for the committee. So it's in the back. Last year, Delegate Hill had to provide food twice for two of her very long bills. So thank you, Delegate Kaiser. So we're going to call the Maryland Coalition of Families. If you can come up, please. In addition, we're going to call Pam Casemeyer, Jessica Emerson, Eric Colchamero, the Maryland Center on Economic Policy, Kylie Shumix, and we're going to leave it at that for now. If you can come up and get started as soon as you sit, and thank you for your patience again.
Thank you, Committee Chair, Madam Chair and committee members. My name is Ann Geddes. I guess I'm down as Maryland Coalition of Families, but I'm testifying today as a mother of a transgender child. Our son, Jordan, who was born a girl, developed significant mental health problems as an adolescent, including severe self-injurious behavior and multiple suicide attempts. These problems developed at the same time that he decided for himself that he was not of the gender assigned to him at birth. Because of his significant mental health issues, his father and I mistakenly did not permit him to undertake any gender reassignment measures as an adolescent. Because of his untreated gender dysphoria, Jordan ended up costing the state a tremendous amount of money. At a significant cost to the state, he spent 9 months in a residential treatment center that was paid for by Medicaid. He experienced multiple inpatient hospitalizations, which were paid for by Medicaid. He lived for 1 year in a residential rehabilitation program, which was paid for by Medicaid. At the age of 19, finally, when Jordan began his gender-affirming treatment, his mental health challenges dramatically improved. He stopped self-injuring, there were no more suicide attempts, and over time he got sober, moved into his own apartment, finished college, got off of SSI, which he was put on when he was in a residential rehabilitation program, then got off of SSDI, and is now employed as a software engineer with a well-paying job. Jordan is now a Maryland taxpayer. He is a giver and not a taker, at great savings to the state. Our son's gender reassignment surgery was truly transformative. All transgender individuals should have the opportunity to live a happy and productive life. HB 23083 would support this, and I ask you to please return a favorable report. Thank you.
Thank you, Madam Chair, members of the committee. My name is Callie Shumitz. I'm with the Maryland Center on Economic Policy. We are a nonprofit, nonpartisan research organization that believes all Marylanders should be able to achieve their full potential in a healthy economy that offers a widely shared and rising standard of living. We support House Bill 283 because access to comprehensive health care is an important part of achieving that vision. The fiscal note outlines some of the potential and fairly minor costs for this legislation, but it does not account for the significant benefits to the state and Maryland communities associated with ensuring that low-income transgender Marylanders have equitable access to gender-affirming care. As prior panelists have stated, research shows that when transgender and non-binary people receive needed gender-affirming care, there are a wide range of benefits, such as improved mental health, improved physical health due to greater connection to regular health, to other types of health care, and reduced workplace and housing discrimination. There's survey data that shows 1 in 4 transgender Marylanders report experiencing employment or housing discrimination. Improved mental health and behavioral health and other benefits are linked to less need for emergency care services, inpatient hospitalizations, which are the most expensive way to provide care. Improving Marylanders' physical and mental health, fostering greater connection to the workforce, reducing housing instability and homelessness, all have long-term benefits, not just for transgender and non-binary Marylanders who would benefit from this legislation, but for our communities and our economy as a whole. So I would ask for a favorable report on House Bill 283. Thank you.
Hi. Madam Chair, members of the committee, Pam Casemeyer, I don't think I could even remotely improve upon some of the testimony and stories that you have heard to date that justify and really warrant the passage of this legislation. So all I will do is tell you who I am here on behalf of. And it is the broad base of clinical providers. MedChi, the Maryland State Medical Society, the Maryland chapter of the American Academy of Pediatrics, the Maryland section of the American College of Obstetricians and Gynecologists, and the Mid-Atlantic Association of Community Health Centers are all strongly in support of this bill. And as you have heard over and over, so I will give you back a little time, this is medically necessary, clinically appropriate, only within the guidelines of what's recognized as clinically recognized care. That's a standard we can't argue with, and we urge a favorable report.
Madam Chair, Eric Colchmiro, for the record, with the Alzheimer's Association here today in support of House Bill 283. Alzheimer's is a disease that affects the transgender population. Our transgender and gender non-binary adults are more likely to report worsening memory and thinking, functional limitations, and depression compared to cisgender adults. Transgender adults, according to our research, were nearly twice as likely to report subjective cognitive decline and more than twice as likely to report subjective cognitive decline-related functional limitations, such as a reduced ability to work, volunteer, or be social. This bill affirms their care and provides medically necessary reimbursement for care. 51% of the LGBT population report being very concerned about having enough money to live on, and 40% say their support networks have become smaller over time. This bill suggests a solution which brings Maryland into compliance with federal guidelines, allows for federally reimbursable services, and costs a small percentile of the Medicaid budget. I urge a favorable report on this important legislation.
Good afternoon, Madam Chair and members of the committee. My name is Jessica Emerson, and I direct the Human Trafficking Prevention Project, which provides legal representation to criminalized survivors of trafficking and sex workers throughout the state of Maryland. We also engage in systemic advocacy designed to prevent exploitation in populations who are put at highest risk of exploitation, one of which are transgender and gender nonconforming people. So as a result, I am also here in support of House Bill 283. Efforts at raising public awareness about the crime of human trafficking largely ignore the impact that discrimination related to someone's gender identity and gender presentation has on that person's vulnerability to trafficking. One of the most common forms of discrimination that trans people face is the lack of access to gender-affirming health care. For many transgender people, their ability to safely navigate both social and professional spaces is closely related to having their gender identity affirmed through medical interventions like hormones and gender-affirming medical procedures. Without this access, transgender people face significant discrimination in the areas of housing and employment, leading to higher rates of poverty, homelessness, unemployment, and survival sex work, each of which directly correlates to an increased risk of both labor and sexual exploitation. Lack of gender-affirming care also results in greater risk of bias-motivated violence and abuse, leading to higher rates of suicidality, PTSD, depression, and anxiety, all of which are very easily exploited by a trafficker. This combination of stigma, discrimination, and dehumanization commonly drives transgender people further into the shadows where violence and exploitation thrive. This is why, as someone who is far from a healthcare expert, I'm here in support of this bill, because for so many transgender Marylanders, this is truly a matter of life and death. If we say as a state that we care about preventing exploitation and violence, we have to care about how it affects all people, not just the populations that we find sympathetic or unobjectionable. Wait, I had a good line, so I had to wait for the buzzer. Well, now there's all this buildup. The denial of dignity to one segment of survivors threatens the dignity of all survivors. So for these reasons, the HTPP supports House Bill 283, respectfully urges a favorable report, and thanks Delegate Kaiser for sponsoring this bill. Thank you. Jazz hands.
Panel. Seeing none, we really appreciate you, okay?
Thank you.
And thank you for, making the time, all of you, regardless of where you stand on the bill, for making the time to come. Next, we have another favorable panel. We have Rachel London, Nora Kraus, Paula Neira, Hope Brooks, Jacob Farashi, and Deborah Dunn. Will you please come up? Rachel London, Nora Cross, Paula Neira, Hope Brooks, Jacob Farashi, and Deborah Dunn. And if I did not pronounce your name, I apologize, but you can correct me when you give your testimony. Who would like to start? Could you please get started? Anyone?
Hi.
Thank you.
My name is Nora Kraus. I'm a 23-year-old trans woman. I live in beautiful Baltimore City. I'm incredibly happy, and I live an incredibly happy life thanks to hormone replacement therapy. I almost lost my life due to inaccessibility of some of the care outlined in this bill. Myself and members of my community like me deserve to know that the institutions that claim to protect us and whose job it is to protect us actually do so, especially in the onslaught of anti-trans legislation in the year 2023. I just want to read something real quick before I go. I cannot praise a fugitive and cloistered virtue, unexercised and unbreathed, that never sallies out and sees her adversary, but slinks out of the race where that immortal garland is to be run for, not without dust and heat. Thank you.
My name's Deb Dunn. I'm a physician assistant. I'm a family practice physician assistant. All of my patients are transgender and non-binary. I see children, adolescents, and adults, up to 80, 90-year-olds. And I can tell you that this is my 40th year of practicing medicine, and I started before any insurances were covering gender affirmation surgeries. So I was able to see the impact and the results of what happens when non-clinical people try to do gender affirmation surgeries. I have been intimate part of the lives of these children, adolescents, and adults, and I have personally have seen the change and the ability to be able to do mainstream school. Depression and anxiety scales have markedly improved. And actually, when puberty hits, that's when a lot of people become suicidal. And puberty blockers are absolutely saving the lives of these adolescents. There's not one parent that I don't go into that room with afterwards that don't feel extremely grateful and tearful, saying, I never imagined that my kid could be sitting in this classroom, raising their hand, dating, going to the movies, talking, feeling affirmed. It drives me every single day. It's one of the most grateful things I've ever done. And we already have these benefits for a Maryland medical assistant, but it's got to be all-inclusive. And not just that, they're life-saving. Also, there can't be insurance discrimination, which I see every day. Thanks.
Thank you, Madam Chair, members of the committee. Thank you for giving me the opportunity to testify today in behalf of this bill. I'm Paul Laniera. I'm a nurse, I'm a lawyer, I'm a Naval Academy graduate, and I'm the program director of LGBTQ plus equity and education at Johns Hopkins Medicine. But my comments today are my own. They may not reflect the position of Johns Hopkins, although I do note that Johns Hopkins officially supports this bill. The other thing that I am is a woman who's transgender. I transitioned decades ago at the cost of my naval career, at a time when there was no health insurance at all, but I had privilege, and I had a credit card, and I could pay for it, and it took me a decade to pay off. And I'm here today as someone both as a patient and also as a healthcare provider and an advocate. This is about health equity. This bill allows some of our most vulnerable Marylanders to be able to access medically necessary care that's available to those with affluence, to those with private insurance, but because of other factors in their life, often exacerbated those health inequities because of their gender identity. They have to rely on government insurance to be able to access medically necessary care. And this allows them to do that and provide the life-altering, life-saving care that can then help them be their most authentic self, reduce the possibility that they become the victim of violence because they don't look or sound feminine enough. I've been fortunate. I'm within the bell curve, but probably more the B. Arthur side of the bell curve than the Jennifer Aniston side of the bell curve. But it's not something I've had to deal with, others do. Right now, across this country, legislatures are trying to perpetuate health inequity and barriers to care that are well documented and been recognized by the federal government. We can stand up and be leaders, and that's why I support this bill.
Hope Brooks, and thank you for sharing your story. Hope Brooks.
Hello, thank you. My name is Hope Brooks. I am a transgender Marylander and the parent of a transgender child. And I just came here today to share one of my stories as a transgender woman navigating the healthcare system. So after years of suffering, being imprisoned in a body that daily calls me pain, I transitioned to living as a woman in 2019. The transition was amazing. For the first time in my life, I started to have a hope of living free of crippling dysphoria. Eventually, however, I knew that to escape the torment, I needed surgery. I met with a team of doctors and eventually a surgeon and scheduled my surgery. And my surgery was even approved by my coverage provider as medically necessary. However, when my surgery was approved, I was mistaken by my coverage provider as a cisgender woman. When they found out their mistake that I was actually transgender, the coverage was revoked. I was told that if you were cis, it was considered medically necessary, but if you were transgender, it was cosmetic. I was destroyed. The meager hope I had built was collapsed, and I despaired. I couldn't afford the surgery, but I couldn't afford to live continually with the pain that I was experiencing. So I decided to end my own life. And I would have done so if it hadn't been for a group of people who came around me and raised funds to support me for the surgery. The surgery that was deemed cosmetic only because I was trans. The same surgery that 6 of my doctors signed off as being both medically necessary and urgent for life-saving purposes. I absolutely would not be here today if I had not gotten that surgery. My children would be motherless. But instead, I'm living a life that's truly happy and fulfilled. I know personally how critically and life-saving these procedures can be and the cost of denying that coverage. I was told that my life was not worth the cost of a surgery. I hope that that wasn't true, and I hope that you will return a favorable response on this bill.
Rachel London.
Madam Chair, members of the committee, I'm Rachel London, the Executive Director of the Maryland Developmental Disabilities Council. Most recently, I had the opportunity to co-chair the Unlocking Opportunity Transition Committee for the Governor and Lieutenant Governor, where I led the work on historically marginalized groups. Over the last 2 months, I had numerous conversations with friends and colleagues in Maryland's transgender community. Each and every one was emphatic about the priority of this legislation, making sure more transgender Marylanders get the medically necessary treatment they need and want, and increasing access to health care in general. I want to really thank each and every one of them for educating me, the Transition Committee, and contributing their time, knowledge, and experience. But I'm here as the Executive Director of the DD Council to support this bill. As an organization that creates change to make it possible to live, for people to live the lives they want with the support they need, we often talk about people with developmental disabilities, including those with very significant support needs, having choice and control over their lives. In the field, as you all know, this is known as self-determination. This includes gender self-determination. In Maryland, about 100,000 people with developmental disabilities live. Not all of them receive services, but they all live. We don't know how many of them are transgender. But it doesn't matter, because what we do know is that people with disabilities are often face discrimination just because of their disability. Transgender people with developmental disabilities face even greater discrimination. One of the Council's priorities has always been to reduce discrimination, increase equity, and make sure people with disabilities have the same rights, and the same services, and the same supports as other Marylanders. That's exactly what this bill does, and that's why we're here in support. Thank you, Madam Chair.
My pleasure. Who's next?
Good afternoon. My name is Jake Ferruzzi, and I'm a transgender man from the 20th District, here to support HB 283. Starting around at age 3, I went to bed every night praying that I would wake up in a male body. I remember how it felt to have my heart break every morning. As a teenager, I couldn't look at myself in the mirror. I was depressed, never spoke in class, and couldn't see a future. When I was 15, my mom held me as I cried and told her I didn't want to live. Recently, my sister told me that in the years before my transition, I seemed barely alive, and after, it felt like, there's my brother, he's finally here. Years of feeling barely alive. Was that just a phase? I'm alive today because I was able to access gender-affirming care. At age 28, I've experienced many years of the joy I prayed for as a kid. That same kid who couldn't look at himself in the mirror, speak in class, or see a future is a proud transgender man and lawyer speaking in court and speaking to all of you today. I'm living proof that this care is life-saving and that this bill will save countless people who don't have the opportunities I've had and may not see their own futures. Maryland can ensure that their futures are made possible. As trans people, our lives are constantly debated by strangers who do not know our realities. But the reality is that we know our own hearts. We have to step out into a world that preaches conformity and vilifies authenticity. We are experts in our own lives. If you find yourself doubting that this care is life-saving, I ask you, why must you understand our internal struggle in order to want us to live? You can't deny the evidence when it's sitting right in front of you. Thank you.
Are there any questions for this panel? Seeing none, I want to thank you for being patient as you waited, okay? And thank you for sharing your personal stories. And every single member here listened attentively, so thank you. Next, we have London Smith, Emily Scott. Good afternoon. Who will get started?
After you. Good evening. As the Director of the Mayor's Office of LGBTQ Affairs, I have the honor and privilege to stand before you proudly and fervently declare that receiving gender-affirming care insurmountably enhanced my quality of life. Symbolically, this is my Valentine's gift to the trans community. My privilege is given to me to be in places and spaces, but I am grateful for my bodily autonomy and access to affirming care, such as SRS, voice therapy, facial feminization. Unfortunately, many of my Black trans friends who are the most vulnerable in Maryland have Medicaid and don't have access to this care and flee to safe havens like New York for these life-improving surgeries. Equity is a guiding principle in the mayor's office. We want to see our neighbors not only live, but thrive. There may be equality in access to Medicaid, but without this bill, there is no equity in services for transgender Marylanders. These life-saving procedures cause a severe strain on financial resources, forcing the most vulnerable further into disparity and activate survival mode and further exacerbate negative well-being outcomes. This would bring Maryland on the right side of history and compliant with the proposed new Section 1557 rule that is consistent with their previous guidance and states that excluding coverage for gender-affirming care constitutes sex discrimination. Baltimore City fervently supports this with our Article 4 as well. I urge everyone, I stand before you as a testimony in real life of what gender-affirming care can do. My life has changed dramatically. My clinician is over here, and she can attest to how I've grown and just turned into a better person. So, thank you.
Sharing your story with us today, we really appreciate it. Next, please.
Good afternoon, Chair, Vice Chair, and members of the committee. Thank you for the opportunity to testify in favor of this bill. My name is Emily Scott, and I serve as the pastor of St. Mark's Lutheran Church in Baltimore, an affirming church where I minister to many transgender people. And as a non-binary transgender person myself, I am motivated to ensure that we have access to the broadest spectrum of gender-affirming care, no matter what our income level might be. As a Christian and as a pastor, I am convicted by my faith and my tradition that transgender people are created by God and one part of this incredible diversity of humanity in which we all live. And I am not alone in this. Mainline denominations such as Presbyterians and Episcopalians, among many other denominations, affirm the goodness and holiness of transgender people. There are even examples of gender diverse people in the Bible. The Ethiopian eunuch is a central character in the book of Acts, for instance, who is the first convert to Christianity. While there are a few loud Christian voices on the right shouting for dehumanizing legislation against trans people, the large majority of Americans believe transgender people should be protected from discrimination. In my ministry, I have seen firsthand the pain and suffering of congregants who, because they are low income, do not receive affirming care. One congregant struggles greatly with dysphoria, which leads to extreme depression and poor physical health. And as a result, she frequently visits the emergency room. With trans-affirming care, these visits could be avoided and she could thrive. I've walked with many of my congregants who have encountered suicidality in their life. We have heard many of those stories today, and I must tell you, I do not want to bury any of my congregants, and each day I fear that I will. We have a moral and ethical responsibility to pass this bill. In both the Hebrew Bible and the New Testament, God commands us to care for the poor, the widow, and the orphan. God demands our care for transgender people who qualify for Medicaid because they are among the most vulnerable people in our society. Let's build a Maryland in which everyone can live into their God-given gifts, receiving the medical care that they need and deserve.
Any questions for this panel? Seeing none, thank you so much. Oh, there is? Okay, Delegate Lewis, did not see you.
Thank you, Madam Chair. That's because I've been behaving today, staying
Okay.
under your radar. I want to thank both of the panelists very much for your testimony. My question is directed to Ms. London Smith. As Executive Director of the LGBTQ Commission in Baltimore City, I just want to emphasize that you were from Baltimore City. Thank you for your work. And my radars, yeah. But really to thank you for your leadership. It's so important. And I wonder if you could talk a little bit more about the impact of this bill for Black trans people, especially for Black trans women who we know are disproportionately harmed by anti-trans and gender-based violence. How would this bill contribute to changing the environment that is faced?
Thank you. Unfortunately, Black trans women are forced into survival mode, and that consists of survival sex work, and that can further exacerbate like their health outcomes. Myself, I sit in a place of privilege, and I acknowledge that. But a lot of my friends don't sit in that place of privilege, and so this is my chance to sit before you and in my privilege, to give them a seat. I speak for them. Access to this care is life-saving. I've lost so many friends who just wanted to thrive. They just wanted to live. And because they couldn't get access to care, they committed suicide, or they got in survival sex work and they were killed in their line of work. So I stand before you, and also overdose. I've lost over 4 friends last year due to overdose from mental health and not being able to get access to care. And I stand on their shoulders, and I sit before you today representing them.
Any other questions? Seeing none, thank you. Thank you again for sharing your story. You have to be really fast with the light. If I don't see it, I can call on you, but go ahead.
No, I just wanted to lighten up the feel. What's your opinion of Unholy?
Who, me?
Yes, the song. It's an awesome song. Just saying.
I just don't know if I'm qualified to speak to that.
That was a very safe answer. Thank you. All right, let's go to the favorable with amendment. We have Bridge Dumaine from 1199 SEIU, and we have Charlotte Hoffman. Will you come up, please? Thank you. And who would like to get started? And again, thank you, everyone, for your patience. Go ahead.
Yeah. Good evening, Madam Chair, members of the committee. My name is Bridge Dumais. I'm the political coordinator with 1199 SEIU. My pronouns are they, them. 1199 represents members who provide gender-affirming healthcare all across Maryland and DC. I'm also the co-chair of End Medical Debt Maryland. Gender-affirming care, as you've heard today extensively, is medically necessary. Over a dozen healthcare workers submitted testimony highlighting this indisputable fact. Every reputable medical association agrees that gender-affirming care improves the overall quality of life and health of their transgender patients. I would also like to highlight that no healthcare workers submitted testimony opposing this legislation. So instead of going through the checklist again about why gender-affirming care is so important, I want to take a moment for us to look at the big picture here. There is a supermajority in Maryland that believes, whether it's reproductive health care or vaccines, that your body is your choice. So I ask the members of the committee to please apply this fundamental principle of bodily autonomy to gender-affirming healthcare. We live in a country that is meant to uphold the right of every person to pursue life, liberty, and the pursuit of happiness. And that is what gender-affirming healthcare provides. So to the members of the committee who may not yet understand the ins and outs of gender-affirming healthcare, that's okay. You don't have to, because healthcare providers and transgender patients do understand why it's medically necessary. And this bill very simply enables healthcare providers to determine medical necessity aligned with current clinical standards. I want to testify in support of Delegate Kaiser's amendment, and thank you, Delegate Kaiser, for introducing it. This amendment would make it so that the directory of transgender affirming care providers that would be listed would require providers to opt in and explicitly consent to have their names publicly listed. This is critically important as transgender healthcare is being politicized all over the country to protect the health and safety of our healthcare workers and their patients. So with that, I urge a favorable report, including Delegate Kaiser's amendment. And thank you, Delegate Kaiser, for sponsoring this bill.
Hello, Honorable Chair, Vice Chair, members of the committee. I am C.P. Hoffman. I am testifying today on behalf of the National Center for Transgender Equality Action Fund. I am also favorable with amendment, though I'm going to co-sign my co-panelists' comments and say thank you, Delegate Kaiser, for the amendment which resolves our concerns. So I'm going to hit on three things quickly that sort of address this from a national perspective, since I'm coming from a national organization. Although I do live in Prince George's County, so I'm not just like parachuting in, just so everyone knows. Woo! So first, I want to make clear that this bill really brings Maryland's Medicaid practice in line with the majority of states that provide gender-affirming care as part of their Medicaid programs. If you look at the other states that provide gender-affirming care, there are some that don't. Unfortunately, I'm working on it. If you look at the other states, they don't have the same sort of asterisk that Maryland does. Like if you look at Maryland's policy, it says we cover gender-affirming care except for these 30 different things. Technically, the list has 31 things, but one of the things is listed twice. I think it's both 13 and 15 are the same. We don't see other states having that same list of exemptions. Or exceptions to coverage. And so this is really needed to bring Maryland in line with what other states that offer gender-affirming care are doing. Second, one of the panelists a few minutes ago mentioned Section 1557 of the Affordable Care Act. This is the federal non-discrimination law in healthcare. It's been used against other states that have limited Medicaid coverage for transition-related care. So a few years ago, for instance, Wisconsin fought a long class action lawsuit that ended up with them losing and having to provide care. And that ended up costing them multiple millions of dollars to litigate that, when their own expert said that the likely cost was $300,000 a year for all gender-affirming care, not just the slight expansion here. I am out of time, so I will not hit on my last point, but instead we'll just say this Valentine's Day, please give transgender Marylanders the gift that we've been waiting for, and give us a favorable report on HB 283.
Are there any questions for this panel? Thank you for being with us today. We have Jeremy Browning.
Good afternoon, Madam Chair and members of the committee. My name is Jeremy Browning. I use he, him pronouns, and I'm the Administrative Director of the Maryland Commission on LGBTQ Affairs. It's my great honor and privilege to be here today to give informational testimony on this bill. I'd also like to commend the members of the General Assembly for the 2021 creation of this commission. It's great to have a seat at the table. The commission was created to assess challenges facing the community, and collect data across state agencies, study and establish best practices, and also give testimony before legislative and administrative bodies. So I know a lot's already been said today, so I don't want to repeat, but this is the top priority for the commission. So I thought it'd be really important to emphasize that. This would really be a vital step in ensuring that transgender and non-binary individuals have access to medical care they need. So this is really to support our most vulnerable community members. So thank you.
Thank you for your work and for being here today. We appreciate it. Are there any questions for this witness? Seeing none, you have a blessed afternoon.
Thank you.
Evening now. Next, we have a panel of unfavorable. We have Ayo Kimati, Brothers of the DMV, and we have Jonathan Alexander, Maryland Family Institute. And who would like to get started, please?
Madam Chair, I'm willing to begin.
Thank you, and I want to thank you for, I know you're the last, bunch of the witnesses. I want to thank you for being patient as we provided, the hearing and the testimony, and we're paying attention, so you can get started.
Certainly. Thank you, Madam Chair. I'm Jonathan Alexander, and I'm an attorney and counsel for the Maryland Family Institute, and I stand in opposition to this Bill 283 and the plan that it puts forward for additional funding for the physical deconstruction and revision of perfectly good bodies as an alleviation to the distress resulting from gender dysphoria. And I'm using gender dysphoria as it is listed here in the bill. I'm also narrowing on the text that refers to puberty blockers and other treatments to suppress the development of sex characteristics as also being wrong. Our bodies are created to naturally grow and to thrive, especially those of adolescents who have everything they need within them to develop into full adults. It is inconsistent with the natural blossoming of adolescence into adulthood to fund hormones and puberty blockers that stop and irreversibly destroy the body's natural ability to allow adolescents to grow into adulthood. And I'm aware of the statistics and the stories of individuals that are promoting this, but I'm also aware of the growing number of statistics and stories of individuals now hoping that they had never undergone sex reassignment surgery, now hoping that they had never taken puberty blockers, now wishing that someone came alongside them on their journey and sat down with them and told them that they were beautiful in the body that they were born in, and that irreversible surgery, puberty blockers are not the way to help them deal with the realities of gender dysphoria. That it would be better to encourage congruity between the mind and the body than to perform the severance of perfectly good working body parts or putting a hormonal stop on the natural development of adolescence into adulthood, where, of course, an untold number of struggles will appear, but can also dissipate when proper attention and care is given to the heart of the matter. For those reasons, I urge you to issue an unfavorable report on HB 283.
Thank you for your testimony today. Next, what is your name?
My name is Ayo Kimathi, and I'm here to testify on House Bill 283. I call this bill the Jeffrey Dahmer bill because in many ways, this is state-sponsored psychopathology. What I'm saying is that this is the second phase, or the phase that follows and builds off what I've brought here so I could share with the committee so you could see the psychopathological grooming that's occurring in the school system in PG County. So what we have seen, and I have it here so you can show it, we had people go into the school system and actually get into the libraries where the children have access to books. In those books, it teaches the children that they can pick whatever gender they want to. They can go whatever the direction they want to. So just like a pedophile would come and prepare a child for sexual abuse, we now have psychological sexual abuse through the state, sponsored and funding into the school system, teaching the children the first stage. You can do anything with your gender. This bill will be the second phase, going past sexualizing the children into psychopathology, where you're now saying self-mutilation of the child is available sponsored by the state to chop the child and mutilate the child, groomed through the school system, now coming through the state. When we are not putting the necessary funding into financial literacy, vocational training, agriculture, we're about to have a food crisis in this country. Maryland is one of the great states in terms of land to grow food. Why aren't we teaching that in school? And we're not putting money into preventing sexual abuse of children into the school and teaching children to be aware of sexual abuse. So what we're saying here is to take the taxpayer dollars and instead of fighting child sexual abuse, now we're talking about funding child sexual abuse. This is nothing less than insanity. Right now, the last thing I want to say, because I think it's very important, they have something out here called MAP, called Minor Attracted Persons, where they're trying to legalize and normalize pedophilia. This is really what we're talking about, and it's the second stage past that into pure psychopathology. I urge you to fight against this bill. Thank you.
Are there any questions for this panel?
Is there any way I can give these to anyone on the panel so you can have the information for yourself?
You can leave it at the desk and staff will get it,
Okay,
okay?
back
Because
here?
there's, just right there where you are, you can leave it
Okay.
right there.
Thank you.
Thank you. Any questions for this witness? Seeing none, thank you so much for coming. We appreciate it. Next, we have actually we have 4 virtual witnesses before we're done with the bill. And we have one favorable with amendment, and 2 unfavorable. We're going to start with the favorable, Mr. Zachary Berger, in the order in which they signed in. Thank you for your patience, everyone. Good evening, sir.
Good evening.
Will you be so kind and give us your name and get started?
My name is Zachary Berger. I am a primary care provider in Baltimore, and I have the honor of providing primary care and gender-affirming hormone treatment to transgender people in Baltimore. And far too often, especially for my transgender patients on Medicaid, I find myself telling them or experiencing with them the denial of services that are necessary to treat gender dysphoria. And as you might know, and not everybody knows, gender dysphoria is when someone's body does not line up with who they are as a person. And that can really lead to severe physical and mental consequences. Therefore, receiving medically indicated treatment for gender dysphoria can be life-saving. And the fact that a rich state like Maryland falls behind our neighboring states and other states in the union with regard to the treatment of transgender people is unconscionable. More than ever, we need to have our laws and our systems of health line up with our values. I need to be able to look my transgender patients in the eye and say that we've done everything we can to treat them as equal human beings who are able to get the health care they need. That's why I'm for this legislation, and I urge those honored representatives on the committee to be for this legislation as well. Thank you very much.
And thank you, sir, for your service, and thank you for your testimony. I'm going to ask the committee if they have questions. Are there any questions of this witness? Seeing none, thank you so much for being with us today and for your patience in waiting.
Thank you.
My pleasure. Next, we have Riley Rochon, favorable with amendment. Good evening. Good afternoon. Actually, good evening. You can get started.
Great. Hi, can you all hear me?
Yes, we can hear you very well.
Awesome. Thank you, Chairwoman and members of the committee. I would have loved to join you in person, but I'm still recovering from the flu, so I apologize if I still sound a little bit stuffy. My name is Riley Grace Rochon. I'm the Vice President of Free State Justice, and I just served on the Moore-Miller administration's transition team to advise them on their LGBT policy for the state of Maryland. Today, though, I am testifying in my personal capacity. Over this past year, several researchers and I have been preparing for this bill by writing a comprehensive report analyzing all the subjects that witnesses focused on last year, to try and inform you all on what the authoritative academic literature has to say on the different issues that we've been talking about today. For example, we researched the modern medical standards of care, including for transgender adolescents, whether being trans is an intrinsic quality or whether you can treat someone out of being trans, you can't, and the satisfaction, regret, and reversibility of gender affirmative care, including for puberty blockers and surgery. We submitted that report as written testimony, along with a one-pager for your convenience. I don't have time to go into everything that we discussed, so I'll focus on the main subjects one of the main subjects from the hearing last year, and also discuss this year why this care is medically necessary. I think this is important because medical necessity is actually a term of art. Generally, the main factors that we look for in determining whether certain healthcare is medically necessary under Maryland and federal law are: 1, whether that care is directly related to the treatment of an illness, injury, disability, or health condition; 2, whether that care is consistent with modern medical standards; and 3, whether that care is determined to be medically necessary by a relevant medical professional. And gender affirmative care meets all these criteria. It's administered for the treatment of gender dysphoria or gender incongruence, pursuant to the ICD-11, which was just updated this past year. It's administered consistent with the WPATH standards of care, which were discussed earlier as the standards used by Johns Hopkins. And transgender patients, or third, transgender patients who pursue gender affirmative care are assessed by medical professionals who meet the requirements set out by the WPATH standards of care. So that's all I can discuss with my allotted time, but I'm available for questions, and you can reach out to me via email. Thank you for your time.
Thank you, and I hope you feel better. Are there any questions for this witness? Seeing none, thank you so much for being patient and waiting for us.
Yeah, thank you for having me.
My pleasure. We have next 2 unfavorable witnesses. One is Dana Schulte and Vince McAvoy. Good afternoon,
Thank you so much,
sir.
committee. The legislator moves things stepwise and such things, so I want to detail for some of our new delegates some of the issues. Delegates Tomlinson and Jalega, I point to HB 132 in 2021, which was the camel's nose under the tent that proliferated and allowed this bill to come about in 2022, when it did not pass because it didn't have enough votes. Most liberal state in the union couldn't pass this bill then because they know that the veil covering these issues has been lifted. An article was released last week from a Missouri transgender mutilation shop where lesbian working for that shop outed the horrible methods these butchers use on children and others. So that they call themselves doctors or therapists, it's meaningless. The movement has been promoted by Planned Parenthood, whose view of children as abortion is okay, which is to say they're not caregivers. When Hopkins in my city backs us, understand they all but fired the chair of their psych department back in 2015 in the name of profits and wokeness. Hopkins has a wokeness litmus test it uses in its organization. Also, 50 trans folks are testifying on bills throughout our country. You should know that as you're reading testimony, lawmakers, that they're going state to state and doubling and tripling and quadrupling up on these bills. There are over 300 bills to stop this transgender madness. 60% of states are enacting such bills. 3 states just this month have banned or made it possible to sue these transgender mutilation practitioners. I'm rushing because the committee cut my mic last year. But I want to say that if not for censoring, as happened to me last year, and on platforms like Twitter and YouTube, this cult of transgenderism would have been aborted the moment the first parent spoke up and shot. Ultimately, this is a cult propagating body mutilation, sponsored by medical liars who joined with state Democrats alarmed that transgender activists would threaten primarying them. This is detailed last year in April. I have those if you want to see them. An inspection of Kaiser's timeline details the threats and also shows how...
Sir, you have to wrap up.
Oh, thank you, Delegate, I will. Shows how this bill was used as a litmus test for her district in appointing new lawgivers. I want to say that the next steps on this is malpractice.
Sir, it is, your time is up. Sir, your time
Okay,
is up.
thank you.
Please wrap up. Thank
Which
you.
allow recipients to sue these practitioners for mutilation, and I am available for questions. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you for being with us today. We appreciate it. You have a great day. Thank you for your patience.
Thank you, Delegate.
My pleasure. I'm going to call again Dana Schulze. I understand that the person is not in the waiting room, correct? All right, and that person was from the USAF Veterans, unfavorable. And this is actually the end of our witnesses. I want to thank everyone, before I conclude the hearing, for being patient, for being here, and for sharing your personal stories. And I hope you have a blessed evening. This concludes the bill hearing on House Bill 283. Next, we have the last bill of the day, which is House Bill 59, Delegate Hill. And we're supposed to be joined by the Judiciary Committee, Delegates Crashfield, Young, and Munoz. And I think that they're gone for the day, so. Oh, they're still working, because they work very hard. The Judiciary Committee works very, very hard. Delegate Hill, will you please get started, please?
Absolutely, please.
And
Thank
bring your panel.
Okay.
Okay. So this is House Bill 59, Delegate Hill, Health and Wellness Standards Correctional Facilities. And this bill, again, is jointly assigned with Judiciary. Delegate Hill, good afternoon, and I want to thank your witnesses for being patient and waiting. And we have your attention, okay? So if you would be so kind and get started.
Thank you, Madam Chair, and and I want to thank you for your flexibility in helping me with earlier today, so that we could still have the hearing today. Thank you.
My pleasure.
Actually, this is an interesting bill, and I think Delegate Riley would actually be able to tell you about it, because she's worked very hard with me in the subcommittee over the past couple of years, trying to see how we can get this bill through. I have written testimony in the file. There's an error in the written testimony. Item 3 is not part of this year's bill, but in summary, for those who are new to the committee, HB 59 recognizes that when we talk about health and nutrition, and when we talk about the cost of health care to the state, one of the areas that we are sorely lacking is with our prison and corrections inmate population. The standards in COMAR are that the food has to be wholesome, nutritionally adequate, prepared, well prepared and ample in portions and served at reasonable intervals, according to the testimony of the Maryland Correction Administration Association. The problem is that, as all of us know, nutritionally adequate and healthy are not the same thing. So processed foods, imbalance between the amount of carbohydrates, fats, et cetera, the amount of salts, sugars, all that stuff make a difference. And when we have our inmates and they are not having the most healthy of meals, we pay for that as taxpayers, and they pay for that in their health care by higher rates of hypertension, higher rates of high cholesterol, higher rates of diabetes, higher rates of heart disease, et cetera. So this bill very simply says that a couple of things. The standards that are being set for diets should be informed by the Department of Health to create and reevaluate every 5 years diets that are more than just nutritionally adequate. It then goes on to create a pilot program in 4 of our correction institutes that the department could choose for themselves, the Department of Corrections and Safety and Corrections, to take place in a plant-based food program wherein inmates will be offered plant-based food on a regular basis, and inmates who elect can choose to get as their diet plant-based meals. And what I mean by that is it's not, eating there is not like in a cafeteria where you go every day and you choose what you want. You're on a dietary regimen. You can be on a kosher dietary plan. If you have religious exemption, you can be on the regular dietary plan, et cetera. but you're on that plan. So the first part of the bill says that inmates should be able to choose the dietary plan that they want to be on without having a medical or religious excuse to do so. So that's the first part. And then what we would do in these 4 institutions that are part of the pilot program is we would look at the health outcomes, not of the individual inmates, so there's no issue of privacy or data or anything like that, but we look at the health outcomes out of a year and compare that to what the health outcome data was the previous 5 years, and then compare that to the institutions that weren't in the pilot. And what we would expect to see is in those institutions where they have a plant-based food diet as an option that folks can choose for a 6-month period of time, that within a year we should see lower incidence of hypertension, lower incidence of diabetes, lower incidence of people being transferred to the emergency room for out-of-control medical conditions. And that should prove that indeed introducing plant-based diets has the potential to help inmates live healthier, which as taxpayers would also lower the costs to the state. The bill as originally introduced just suggested or would have required that we offer plant-based diet options in every institution. And it was this committee and subcommittee has said, well, although it sounds like if you eat better, you'll live better and your health will be better, shouldn't we have to prove it? And that's why this bill comes in as a pilot, to prove the concept. And that's essentially what the bill does. There are some other details that we'll be happy to talk about. As again, most of the members of the committee are familiar with it. You look at the fiscal note and there's minimal dollars that are involved here, under $50,000. And most of the objections, if you read the unfavorable testimony, have to do with corrections saying we already give great dietary choices, and why should the Department of Health have anything to do with how we design our diets. And you'll also notice that the bill also specifies that the plant-based diets should be within the budgets that the corrections already have to work within. And that's, in essence, what the bill's about.
Next witness.
Hi, I'm Dr. Dana Simpler. Thank you for letting me share some medical perspective on this bill. I retired this past May after 35 years of continuous primary care medical practice. I've always counseled patients on healthy lifestyle, but 12 years ago, I was blown away to find out how powerful a plant-based diet is to prevent and reverse all kinds of medical problems, including diabetes and heart disease, 2 very common and very expensive diseases to treat. I've witnessed many, many people reverse their serious medical problems with a plant-based diet. New York City's Mayor Eric Adams is one such person, and he has publicly stated that he regained his own health and reversed his type 2 diabetes and went off medication after adopting a plant-based diet. A quote from him, when it comes to preventing diet-related chronic disease, there's growing recognition that it's not our DNA, it's our dinner. And putting money where his mouth is, starting in March of 2022, New York City made the default lunch in 4 large city hospitals plant-based with a 95% satisfaction rate. And in September 2022, it announced that these same New York hospitals will be offering a culturally diverse plant-based meals as a primary dinner option. And they're also promoting plant-based meals in their schools. So Maryland needs to be doing this too. Let's not be the last to the table. Let's be on the cutting edge. Let's promote the healthiest diet. It keeps people from getting sick. It helps reverse medical problems when people are sick. It's inexpensive and it saves money. It really should be a no-brainer. And as individuals, you as individuals may have your own reluctance to change your eating habits, which is human nature. But as legislators, I ask that you try to look past your own possible reluctance or possible misinformation about what is truly the healthiest diet for humans, which is a whole food plant-based diet. And if you'd ever like me to come back and provide you as a group more detailed information, what you can do for your own health, I'd be more than happy to do that. But I encourage you to support this effort.
We
Madam Chair,
we have 2 more witnesses virtual. Okay. We have, the first one is Joe St. George. And then we have Ruby Lathan, doctor in nutrition.
Ruby's up right now.
Miss Ruby Lathan, will you be so kind and get started?
Absolutely. Good evening. I'm Dr. Ruby Lathan, certified holistic nutritionist and board member for the HBCU College of Plant-Based Lifestyle Medicine, and I ask for a favorable report for HB 59. After my comprehensive review of the Maryland Department of Corrections 5-week meal menu, I see that it is essential that this committee provide inmates who are not sentenced to the death penalty the right to choose a nutritious plant-based diet so that they can live and not die a premature death from chronic diseases, which make up about 1/3 of the prison's $130 million healthcare budget. The inmate meal menu, which consists of high amounts of saturated fat, sodium, very little fiber, water, and macronutrients, serves almost 2 times the amount of animal foods than the maximum recommendation provided by the dietary guidelines for Americans. So this diet substantially increases their risk of diabetes, heart disease, stroke, cancer, and COVID. And so the good news is that this committee can do something about the health crisis in Maryland prisons, and that is to pass this bill so that inmates can choose to reduce their risk of costly chronic diseases and COVID by having access to plant-based foods regularly. In 2021, there were 3 important studies that came out that proved the efficacy of a plant-based diet against COVID, and that also supports the hundreds of studies that already prove that a plant-based diet can reduce and reverse chronic diseases. So these studies, along with many others, show that there's medical evidence that this is a medical necessity, and this bill will provide an effective preventative strategy along with other medical interventions for preventing chronic disease and COVID deaths in our prison. So therefore, I ask for a favorable report on this bill.
Thank you. I know Jill St. George is supposed to be here, but I know she cares about this bill.
Yes, you know
and
that.
We don't see her on at all in the weight room, so we'll see who's left at the end as well. So we have, and thank you, Dr. Lathan, for your testimony.
Absolutely.
We have next, actually, let's go to the virtual.
Sorry, Joe says she's not being admitted to the room, that she's in the waiting room.
What is her name? What is the name she has?
I'll ask her, I believe
And
it's
while
Joe
she-
St. George.
And while she comes, no, she's not, they can't see her under that name, but I will ask the Historical Black Colleges, Lakshman Mulpuri, will you be so kind and get started?
Yep,
Okay.
great. So hello, members of the committee. My name is Dr. Lakshman Mulpuri, and I'm a current member of the HBCU CPLM. I'm also a principal contributor to the language of HB 0059, and I'm testifying in support of this bill. Research from the Maryland Department of Public Health has shown us that prisoners have a rate of chronic disease that is nearly double the rate of the general population, and as a result, urgently require lifestyle interventions. Plant-based diets encourage the consumption of whole foods while minimizing or eliminating the consumption of animal products. They've been shown to substantially lower the risk of a variety of chronic diseases, which is vital for an at-risk population such as our inmates. The current iteration of this bill is not only comprehensive and practical, but it is necessary to promote the health of a vulnerable population with little recourse. This pilot program is an important first step in bolstering the rehabilitative arm of correctional facilities. Although the cost of these meals may be equivalent or even cheaper than standard options, their implementation may save the state of Maryland millions of dollars in chronic disease and associated medical costs. Men and women serving a defined term for rehabilitation in the state of Maryland should not find themselves condemned to a life sentence of chronic disease. Thank you for your time. I wanted to personally thank Delegate Hill for her continued support of this initiative, and I urge the committee to issue a favorable report for HB 0059.
Thank you. Can we try to see if Joe St. George can be allowed in? Okay, Dr. Lathan, what did she say?
She said she's in the waiting room under HBCU CPLM and that she wasn't able to change her name.
Okay, you can let her in. Thank you.
Madam Chair? While we're waiting, I just wanted to add for those who are new, because I should have made the point earlier, that the purpose of the bill is not to force anyone to eat anything, is to give them the option of having a healthy choice so that they have an option of improving their health. And since the corrections medical programs are designed not for prevention, but only for treatment of urgent problems, this is the really only health prevention that we're able to do.
Thank you. Joe St. George?
Hello, can you hear me?
Yes.
Okay, thank you. Hi, thank you, Chair, Vice Chair, and Committee. I'm Joe St. George, Chair of the HBCU College of Plant-Based Lifestyle Medicine, and it is our mission to train health professionals and from our HBCUs and alumni in how to prescribe food as medicine with lifestyle interventions to reverse treat chronic disease. We support HB 0059 to provide inmates the right to choose healthy plant-based medical interventions, because just as the panel before us, they're medically necessary to have this food because they have no choice for the following reasons. First, in the November 2021 Maryland Prison Food Study that was done by the Food Violence in Maryland Correction System reported over 500 inmates said the food was crappy, it was horrible, it was filthy, and it was gross. Not to mention Dr. Ruthie Lathan's report that said that the food is nutritionally deficient. We spend $50 million a year on chronic disease, and so this bill would save money and provide inmates the option and the choice to choose healthy food to address the medical needs that either when they go in, they don't have, and they come out with chronic disease. And it also is medically necessary for them to prevent the disease, because the current food is directly the causative factor or contributing factor for the diseases that the inmates suffer from in these institutions. Over 100 studies speak about plant-based lifestyle medicine as a means through which inmates or any person can reverse chronic disease. And you heard from the doctor that spoke initially. She personally has helped individuals with changing their medical issues. So we as an organization are ready to provide the educational programs within the prison system to help the inmates to learn and understand what plant-based lifestyle can do for them individually, as well as work with the medical professionals in the system so that they can be better equipped to learn to prescribe food as medicine, as well as the other lifestyle interventions. And Morgan State and Coppin professors are ready to also work with us to collect the research data that Dr. Hill mentioned that will be collected under this particular bill so that we can demonstrate the evidence will be the proof will be in the pudding. But we really don't need to prove this. This has been known for decades that plant-based lifestyle medicine can and does do what it does for all individuals, and that is improve their overall health, prevent chronic disease, and even reverse chronic disease. So we respectfully request that this committee vote yes 059 as a medical necessary method for our inmates. Thank you.
Thank you, and thank you for your advocacy. Next, we have Nicholas Spiller from the Public Health Law Clinic. And then we have Noah Prasma from the Physicians Committee for Responsible Medicine. And who would like to get started?
Good afternoon. My name is Nicholas Spiller, and I'm here on behalf of the Public Health Law Clinic at the University of Maryland School of Law. A healthy diet is an essential part of living a healthy and productive life. But unfortunately, in our prison system, that healthy diet seemingly costs us too much. So instead, we subject our incarcerated citizens to ultra-processed, low-nutrient fare that leads to an abundance of chronic illness. But the sad irony is that treating chronic illnesses is incredibly expensive. Maryland spends over 20% of its prison budget every year on inmate medical costs, over $170 million a year, much of which is tied to treating preventable chronic illnesses caused by poor diet. HB 59 will provide a crucial first step in righting two wrongs. First, it will give our inmates more humane, healthier, plant-based options. And second, the pilot program will serve to highlight just how much impact a more plant-based diet can have on our inmates' health. A healthier prison population requires less medical care. Further, healthier inmates will be better positioned to return to society following their release, as fewer will bear the burden of a chronic illness, which can limit their ability to find work, secure housing, and get back on their feet. And as an added bonus, the state might just save some money because plants cost less than meat. HB 59 also enables inmates to select medical and religious diets without approval, helping them to avoid dangerous delays as they wait for that approval. And finally, HB 59 allows for the Secretary of Health to have greater input on prison diets, which will help to ensure that prison meals actually serve a nutritious purpose. Prison sentences themselves are a harsh measure, but they aren't supposed to include a chronic illness. And unfortunately, this is exactly what is happening in our Maryland prison system. HB 59 begins the process of chronic illness prevention, which could save our state millions. Thank you.
My pleasure, and thank you. I allowed the last few seconds because you guys all waited to the end. So I thank you for being flexible. So go ahead.
Awesome. Well, thank you to Madam Chair and for members of the committee for the opportunity to speak. My name is Noah Promsma. I am a registered dietitian nutritionist with the Physicians Committee for Responsible Medicine, and I'm representing my organization and over 11,000 of our members who live in Maryland to voice our support for House Bill 59. So there are multiple reasons to support this bill, and especially the pilot program that it proposes. Most importantly, diets that focus on plants confer an abundance of health benefits and reduce a person's risk of chronic diseases. Plant-based eating patterns have consistently been found to be protective and even reverse these diseases, and there's a clear public health consensus around the benefits of eating more and even exclusively plants. That's why we believe it's really important to offer this option to inmates. So a plant-based diet has been proven to improve cholesterol. It can prevent and even reverse type 2 diabetes, obesity, hypertension, and heart disease. While reducing the burden of these diseases is always good policy, even on its own, it's also become abundantly clear in the wake of COVID-19 that these conditions have relevance for susceptibility to viral infections. Healthful plant-based diets support immune health and can be protective against severe viral infections. Healthful plant-based diets that would be proposed in this bill in the pilot study that it's recommending could help Maryland correctional facilities improve the health of the inmates in their care and to mitigate the impacts of future outbreaks. Also, passage of and implementation of House Bill 59 could incur cost-saving benefits to correctional facilities. This could be done by virtue of preventative and therapeutic effects of plant-based diets. This has been extensively discussed, and this would reduce, of course, healthcare expenditures. Comparable institutions who have led the way with plant-based meals have also discovered savings due to the lower cost of plant foods over animal foods. So the Physicians Committee heartily recommends and offers up our Universal Meals Program, which is designed for institutions like prisons. It is meant to be low cost and free of animal products, along with major allergens, and heartily recommend it for implementation as this program is considered. We thank the committee for consideration of House Bill 59 and encourage a favorable report. Thank you very much.
My pleasure. Who's next? Mariam Tabrizi.
Good evening. My name is Ashley Devon Johnson, and I am the Policy and Research Coordinator for Out for Justice. Out for Justice is a nonprofit organization that works with members who have been impacted by the justice system, and we hope to alleviate barriers that prohibit our members from actively reintegrating back into society. I'm here today in support of House Bill 59 because we know that what our citizens eat behind the wall matters. Today you will hear from an OFJ member that will share their direct experience while they were incarcerated for 13 years and what eating that type of food did to their health. I want to lift up a few other things. Currently, since the start of COVID-19, Out for Justice and many of the Maryland Justice advocates have worked directly with the Secretary of Corrections to see if we can support with reducing the risk and spread of COVID throughout our facilities. We have called on the department to increase the amount of immune boosting foods, also to look at things that will increase the amount of vitamin D and vitamin C and vitamin A that our loved ones behind the wall are experiencing. Many of our calls for advocacy were met with deaf silence. Today, and you will read opposition testimony that will say there's a process to implement these things and this does not need to be legislated. However, their process does not include full transparency with the public, nor does it allow for the Secretary of Health to influence what those health standards are. I think this bill is timely and it is necessary. I'm grateful that all of you all stuck around to this very last bill and you hung in there. But what I want you all to know is that many of our loved ones behind the wall desperately need help so their health can be improved. And I ask and urge you all to support this legislation. Thank you.
Marian Trevisi, will you come up, please? Thank you.
Good evening, Madam Chair, Madam Vice Chair, and members of the committee. My name is Mariam Tabrizi, and I'm speaking on behalf of the Humane Society of the United States, testifying in support of House Bill 59. I am also a Maryland resident, and I have a PhD in public health. So I have 5 quick, brief points I'd like to make. As we heard the other speakers talk about, incarcerated individuals in Maryland have a higher rate of disease burden compared to the general population. But unlike the general population, they do not have the ability to shop and prepare healthy, nutritious meals. And we know, as research has shown, this boosts immunity. Second, we're seeing increasing trends in the marketplace and the demand for plant-based foods across the country. The 3 largest food producers, food service companies, Compass Group, Sodexo, Armark, which run dining operations in tens of thousands of hospitals, universities, and schools, these companies have initiatives to provide plant-based meals on a national scale. Third, we're seeing trends at the federal level. During the recent White House Conference on Hunger, Nutrition, and Health in September of 2022, there was a call to provide greater access to healthy, sustainable, plant-based food options at federal dining facilities such as hospitals, government buildings, and federal prisons. Fourth, as we've heard before, access to plant-based meals not only provides an ethical and a humane choice, but encourages and promotes physical and mental well-being. And we know that this can greatly enhance the ability for incarcerated individuals to contribute and reintegrate back into society upon release. And actually, in 2015, the World Health Organization had a report that concluded not only does good nutrition support good physical and mental health, but healthy food is a key to an incarcerated individual's successful rehabilitation and resettlement. And then finally, we hope that the state of Maryland and their food procurement strategies supports a nutritious and plant-based options, allowing all individuals across the state, including incarcerated individuals, options for a healthy, humane, and ethical, sustainable food choice. So thank you for your consideration, and we urge a favorable report for House Bill 59.
So this is the sponsor panel, and we're going to open it up for questions now. We still have more witnesses. They will call after the sponsor panel, okay? Are there any questions? I see Delegate Taveras first, followed by Delegate White.
Thank you, Madam Chair. I remember a couple of years back, in New York City, we were using this kind of philosophy of good, healthy foods inside some of the more extreme alternative schools. And we were able to see that a lot of the physical altercations and problematic behaviors that were evident in some of the roughest schools, and I do mean rough, like rough, were eliminated. And so in some of these other states where we've seen this kind of transition, has there also been an improvement in behavioral patterns inside jail systems?
Well, as we decide who's going to answer, I want to directly answer, talk about the volatility that exists
No,
inside of our...
we don't do that. So I need whoever's going to answer the question, I need that person to speak up, okay? Go ahead. Thank you.
So I don't have any data off the top of my head. I was recently talking with a friend from California who they implemented a similar policy just across the entire state. And I think the downside is that there was no pilot study put in place. I think anecdotally, anyone there would tell you that there has been improvements. But I think that's a real strength of this bill, that there is an opportunity to collect hard data and share that around.
Thank you. Next, we have Delegate White.
Yes, thank you, Madam Chair, and thank you, panelists, for sharing. With the proposed engagement of the Department of Health in an advisory role, would this bill seek to improve nutrition standards in the meals served across the board in addition to providing a plant-based option, or is this exclusively focused on adding a plant-based option? Thank you.
Across the board.
Okay, thank you.
My pleasure. Any other questions for this panel? No, we cannot. You can speak without a question. I'm sorry. Those are the rules of the committee. I have to keep going. Otherwise, we will be here forever. That's why we have the rules, so I apologize. You know, you'll be able to give the information. If you have information you want to submit to the committee, you could do that offline. You can do it through the delegate. She has our information when it's in subcommittee as well, okay? Thank you so much for your questions. Delegate Bandari, I didn't know you.
Thank you, Madam Chair. I would like to clarify whatever our delegates is thinking.
I have a question.
What I was thinking?
Yeah.
So one of the points I was going to make to Delegate Taveras' question is that if you read the written testimony from AXME, representing some of the correctional officers, one of the points that they make is even the correctional officers have been calling for dietary changes and improvement in the food offered to inmates in the prisons. They think that it will make a huge difference in the behavioral, in the behavior of inmates, and that frankly, it sounds like from the testimony, they think it's the right thing to do. Thank you.
Okay, thank you. Any other questions? Okay. Thank you very much for being with us today. We really appreciate it.
Thank you all very much, and thanks for hanging out.
We do have more witnesses, so here's the next panel. We have Elizabeth Hillier, Farakwa Idris, Dana Simpler, MJ Sutton, Aaron McLermore. We're going to stop there, and then we'll call another panel. Okay.
Oh, my goodness.
How about Elizabeth Hillier? Maryland Office of the Public Defender? No? How about ASME, Local 1678?
This is Faruqa
All right.
Idris.
Wonderful. How about Out for Justice, MJ Sutton?
She had to leave.
Okay. How about Irene McLemore, Out for Justice? Will you be so kind and come up? And thank you again for being patient. I know you waited a long time. And then the ones that we have left, another panel will be virtual. So you can get started.
All right. Good evening, Madam Chair and all members of the committee. My name is Officer Farouka Idris. I am currently a correctional officer from the Maryland Correctional Institute, Jessup. I've been there for 10 years, and I'm an active member of ASME Local 1678. I'm here to actually support the bill, the H59 bill, that requires the DPSCS and the incarcerated to be able to choose their medical, their dietary preference without the need of medical papers or approval from anybody. Actually, this bill will help us to actually control the amount of illnesses of the incarcerated. Because personally, my experience when it comes to the incarcerated, we have a high rate of diabetes, cancer, because I'm a weapon officer, I take them to the hospital, and with all this, it's like I feel where they are. Now, when it comes to security of the institutions, the incarcerated becomes unruly, they become destructive, they don't want to lock in. It puts other incarcerated persons in danger, it puts the officers in danger, and if we do not give them this, it just make our work more harder. And with this is personal experience because I am right there. I've been with the department for 10 years, and with this, by supporting this bill, it will provide reasonable and measured approach to ensure that the food choices in the prison systems is evaluated on a regular basis and according to the best nutrition standards pertaining to the inmates. So we urge that the committee provide a favorable report on HB 59.
Thank you for your service and your testimony.
Thank you.
We appreciate it. How about you, sir?
Hi, Madam Chair and members of the committee. My name is Aaron McLemore. I'm a representative of Alpha Justice, and I support HB 59. In 1998, I began serving a 25-year prison sentence in the state of Maryland, of which I served 17 and a half years. The first 4.5 years of that sentence I spent in Hagerstown at the Maryland Correctional Training Center, which was nicknamed the Farm. This nickname came from the fact that the facility had a history of being a working farm, and it even carried a reputation amongst prisoners for having outstanding food. I was able to witness through my time a marked decline, especially around 2001, in the quality and quantity of the food being served, due to what we were mostly told were budget concerns. The decline was severe enough to lead me to developing several food-related health problems, including food poisoning and a rupture in my stomach lining, leading to blood in my stool. After an episode in 2007, where several prisoners suffered from food poisoning, I personally stopped eating the red meat that we were being served. And I, after much trial and error, transitioned to a whole food, plant-based diet, which I believe saved my life. Most prisoners compensate for the lack of nutritious food choices by buying food from commissary, but as you can imagine, this creates hostility and violence amongst the population due to many prisoners not being able to afford healthier food choices. I believe Maryland has a responsibility to its incarcerated population, and for this, I support this legislation.
Your time was excellent. I want to thank you for sharing your experience with us because it really makes a difference. You went through it, you lived it. Thank you very much. There's another person before you leave on that panel from Out for Justice. Is there another individual? There was, Nicole
Hansen, she's in JPR testifying.
Okay, wonderful. Well, thank you. I'm going to allow the committee to ask you some questions, okay? Are there any questions from the committee? Delegate Johnson?
Thank you, Madam Chair. And thank you for coming to testify today and waiting.
Since both of you have experience inside the correctional facility walls, and whoever's best to answer, we can just get one of you to answer. Do you think we'll have good participation from the inmates that would want a plant-based meal?
I absolutely believe so. Absolutely. Most people, we go through extreme measures to try to improve the quality of the food that we eat. And so, yeah, it would cut back on a lot of illegal activity and dangerous and maybe even reckless chances that people take to eat better.
Ms. Idris, the same question for you. Do you think that the inmates will participate?
Absolutely, absolutely, because the incarcerated persons in the institutions, they are open to new things. The incarcerated people in the institutions, they rather go for something that is organic than something that is processed. They complain a lot. Let me give you an example when it comes to, just an assumption or an estimate, let me say, if you have 100 inmates or incarcerated persons that have to go for feed up, maybe 100 or 99 persons will go because they don't want to have anything to do with the food because it has history of cancer. I've taken multiple incarcerated persons to the hospital with cancer, diabetes, that we have to have seizures and everything. So they are open, believe me, they are open to change. Anything brand new, they would take it. And so far it is organic, they would take it.
Thank you. Any other questions? Okay. Thank you so much. We thank you both for your experiences. We appreciate it.
You're welcome, ma'am. Thank you.
My pleasure. Next, we have the virtual oral testimony of Kimberly Furlington from the Maryland State Bar Association Animal Law Section. Good evening. Will you be so kind and get started? And thank you for waiting to provide your testimony. We really appreciate it.
Apologies, I just joined. Am I up?
Yes, you are, and we can hear you. Thank you for being here and for being patient.
Good evening. My name is Kim Fullerton. I am Vice Chair of the American Bar Association's Animal Law Committee, and I'm here today to testify and represent on behalf of the Maryland State Bar Association's Animal Law Section. Expanding access to plant-based meals will have a multitude of benefits for people, animals, and the environment. And I'll just quickly highlight why this bill is a priority for the MSBA. It provides much needed updates to the minimum standards for correctional facilities while generating transparency in efforts for improvement. We expect to save the state money and improve the health of Maryland inmates. And as inmates get healthier, we can expect continued savings because we're spending less on healthcare. It's important to note that decision makers like yourself will receive measurable findings from the data that's provided through the pilot program. This bill is a win across the board, and it reflects the priorities and initiatives of key stakeholders, including healthcare providers, minority communities, environmental advocates, animal advocates, taxpayers, the food service industry, and most importantly, inmates themselves. Even the United Nations identifies plant-based diets as a major opportunity for combating the climate crisis and improving human health. This bill represents Maryland's alignment with local communities and global leadership in tackling some of the world's biggest problems. So the MSBA is very grateful to Delegate Hill and both communities that are assigned to this bill for consideration of such important issues. Thank you.
Thank you for your work and your time. Are there any questions for Ms. Furlington? Seeing none, thank you, and thank you for being so kind and waiting, okay? We appreciate your work. You have a great evening. We have an individual virtual, we have a name here, Milton Mills, who signed up to do virtual testimony, but we can tell whether it's the person because their name is not on it. We're going to allow the person to come on so that I don't hear it later on that we didn't allow someone, okay? So just be flexible with me. I'm trying to be fair. Will you be so kind and allow that person on? We got to, and if we could tell our witnesses to make sure that the Zoom has their name, because it's difficult to let them in. And thank you, Ms. Furlington. It's loading. All right, just a little patience. It's the last witness, right? So let's take a deep breath. We're almost done. Thank you, Delegate Kaiser, for the food. And thank you, everyone, for being patient. 1 second. Well, the person is not, there's no one waiting? It's not connecting. So, Delegate Hill, the person is Milton Mills, and they were favorable, but the person is not connecting. So if you can find out who that person was, and if you could get that person testimony and provide it to the committee, and let them know that we try, okay? And they can actually come, if they want to subcommittee as well. And this was actually the end for the testimony. I just want to take a minute to thank the committee for its patience and for your questions and for, being here this late. I really appreciate it. The days are going to get longer because we're going to have a lot of bills and more witnesses than what we had even today. So, that's why we have certain rules, right, of one question, not, 2, 3 questions, because then it takes longer. Today I was flexible because there's a need to learn the subject matter well, and this is a great opportunity, and we had it in a very respectful way, okay? So I want to say, Delegate Woods, yes.
Chair,
Yes.
would it be appropriate to add pizza to the rules?
Yes, we will. If you keep us here late, you have to buy some pizza or whatever else, okay? You have a great evening, everyone. I want to thank staff. Thank you so much for staying here so late. And Aaron Hopwood and our marshal, thank you very much for being here. You have a everyone.